पंकज क्या कर रहा है यार, लाइट को बंद मैं कर रहा हूँ। मैनुअल कर रहा है।
सो फर्स्ट सेकंड थर्ड स्पीकर्स हैं यहाँ पे ना। आ गए स्टार्ट।
I request all the gentlemen to please be seated. Science knows no country because knowledge belongs to humanity and is the torch which illuminates the world. Good morning, ladies and gentlemen, mostly gentlemen this time. On behalf of the organizing committee, it is my immense pleasure to welcome you all to Sogocon 2025, the fourth annual conference of Society of Genitourinary Oncologists. I, Dr. Charu Sachdeva, welcome you all. We gather today not just to learn, but to challenge assumptions, to share the breakthroughs, and most importantly, to shape the future of genitourinary cancers. We are proud to have with us over 70 renowned faculty members, multiple international experts, and a packed scientific program that promises to be both intellectually stimulating and clinically relevant. Let's begin our journey. To set the context and begin the day, I would request Dr. Amitabh Singh, Senior Consultant, Department of Genitourinary Oncology, IGC-IRC, and Organizing Secretary for the Sogocon.
Good morning, everyone. So it's my proud privilege to welcome all of you for this Sogocon 2025. So this year, just we had a challenge to make a very new program which attracts everyone, and there must be something new because we are having a lot of conferences and all these academic lectures, the theme, it is matching with all the conferences. So we thought about this idea like de-intensifying the treatment and minimizing the toxicity of the treatment. So that is the theme of Sogocon this year. So we tried to chart out the program under this theme only. And most of the talks, whether they are related to the uro-oncology, radiation oncology, or medical oncology, so they are aligned with this theme only. But there are few talks which are not aligned because like panel discussion, there are some pharma-sponsored session. But most of the talks, they are aligned with this theme only. So with this, I would just, without taking too much time, I would like to start this proceedings. And the convener of this session is Dr. Sanjay Adla. So he is very senior faculty. He's a senior consultant at Apollo, Banjara Hills, Hyderabad. So he will be just inviting chairpersons, and then chairperson will invite the speaker. So there is a 2-minute discussion in the duration of talk. So I would request every speaker to just try to finish off their talk just 2 minutes before the designated time, so that we should have some time for discussion, so that we should not over exceed the duration of your talk. Sanjay sir.
Good morning, everyone. I'm going to start off inviting Dr. Aditya Pradhan sir, Nitin Sudhakar Kekre sir, and Ashok Hemal sir to the dais, who will be able to chair the session. And just to facilitate it first, I'm going to request the first speaker to take the podium, Dr. Srivatsa.
Thank you so much, sir. Sir, I would just reiterate the affiliations of our chairs, Dr. Aditya Pradhan, Principal Director, Uro-Oncology, Venkateshwar Hospital, New Delhi, Dr. Nitin Sudhagar, Consultant Urologist, Nowari Hospital, Vellore, and Dr. Ashok Hemal, sir, from US. Over to you, sir.
So, without wasting time, we'll start our first session when we have a number of interesting talks. The first one is by Dr. Srivatsa, who is a consultant and head of uro-oncology at Sri Shankara Cancer Hospital at Bangalore. He's talking on sharing perspectives, biopsy or no biopsy or problem.
Yeah, thank you, sir. A very good morning to you all, and many thanks for the opportunity. It's great to be back here where I trained under Rahul sir long back, 2010-11. So I have been given this task of discussing a perspective of how prostate biopsy is going to, see the light of the day in the future. I would like to start with 3 clinical scenarios. A 60-year-old asymptomatic patient picked up with a PSA5 and an MRI Pirates 2 lesion on a master health checkup. 65-year-old with a PSA8 with a Pirates 4 lesion. just one lesion in the left mid gland with no other lesions on MP-MRI. And the third one, a 73-year-old with a 36 PSA with significant LUTs, reported for LUTs, evaluated and found to have probably locally advanced prostate cancer. Now, all of them will definitely require a biopsy because biopsy is the gold standard, and the biopsy can accurately detect up to 92% of patients with clinically significant prostate cancer. The goals of biopsy are to detect clinically significant prostate cancer because we all know that prostate cancer is a spectrum disorder. It's not one disease entity, and there are different treatment opportunities for patients with prostate cancer. So to understand the exact biology of the cancer is very important. Biopsy also maps the heterogeneity of this disease and probably rules in or rules out patients to focal therapy. But more importantly, biopsy will give us tissue which can be archived for future genetic and molecular evaluation, which can guide future therapies. However, biopsy, if done on all patients, is not a very safe or straightforward procedure because it has its own complication rates, with 1% of patients having severe sepsis, 10% of patients having a hematuria, 1 to 3% of patients having retention, and close to about 10% of patients are missed with prostate cancer. The critical elements in a biopsy are the histopathology. We are obsessed with Gleason score for a long time. Most of our studies have revolved around Gleason score and has made it the most powerful prognostic indicator. We also understand the tumor volume. We can, like I said, molecular profile the patients, also do local staging, and very rarely can also identify variant histology and rare pathology in prostate tumors. But the question is, can we safely replace these treatments for diagnosis and for decision making on treatment with non-invasive markers? Where are we as on date? The current non-invasive modalities for prostate cancer detection are MP-MRI, blood-based biomarkers, urine-based biomarkers, and a PSMA PET CT scan. They have their own positive predictive value, negative predictive value, sensitivity, and specificity, with MP-MRI probably reaching the closest to what a biopsy can tell us. But then there have also been advances in prostate cancer detection. There are MRI evaluations which are beyond MP-MRI. There are advanced blood biomarkers. Then we have the ctDNA assay and the circulating tumor cells. And then there are several AI incorporated strategies. So coming to the MRI, which is probably one of the best tools to identify the prostate biopsy, best tools to identify the Gleason score pathology in the prostate. There are several advanced technologies which can be incorporated in a routine MRI, like the biparametric MRI, the resistivity index-based MRI, the MR spectroscopy imaging, and a tumor volume evaluation using a verdict MRI, and then combine all of these modalities or a few of these modalities with AI algorithms and give a AI enhanced MRI evaluation, which can probably come close to what we can achieve by doing a biopsy. I'll just restrict only to the AI enhanced MRI. What has been shown in two major studies which were well conducted and published in 2024, the PICAI study and the UCLA Unfold AI study, are that the AI enhanced MRI could offer improved detection. It could enhance PIRATS correlation and reduce the inter-observer radiologist variability. But most importantly, it enhanced or improved the clinically significant prostate cancer prediction, with the AUC or the R value coming as close to as what a biopsy could. There are several challenges, but because it's not generally available and it requires a standardization, but this is probably the best tool available as on date. This is a chart which tells us the different modalities of MRI in comparison to MP-MRI. And here you can see that the biparametric MRI, the verdict MRI, and the AI enhanced MRI marginally exceed what a MP-MRI can offer us in terms of diagnostic value. There are several blood-based biomarkers, PSA being the most rudimentary. I would just like to highlight on the 4K score, which comes close to the biopsy with a R value of 0.82, and the circulating microRNAs, again with a AUC of around 0.8. There are several studies which have looked at AI integration of these biomarker assays, and as on date, what has happened because of this is close to about 30% of unnecessary biopsies can be avoided because of an AI-based biomarker assay. Then comes the circulating tumor DNA and the circulating tumor cells in the diagnosis of prostate cancer. it has offered a significant transit for molecular evaluation and probably even a Gleason score prediction in patients with advanced prostate cancer, wherein it can detect the genomic alteration, it can also risk stratify, and it can offer a non-invasive monitoring, avoiding repeated biopsies in patients progressing to metastatic castration-resistant prostate cancer. Then the last modality, the PSMA PET. The PSMA PET has a very high sensitivity of close to 95%, but its ability to identify the pathology is low. Only about 70% of patients with clinically significant organ-confined prostate cancers can be accurately identified based on their aggressiveness on a PSMA PET CT scan. So to summarize, these are the non-invasive tools or biomarkers which can probably come close to what a biopsy can offer us. Here you can see that the MPMRI, the PSMA PET CT, and a multimodal AI tool will offer as close to as what a biopsy can offer us. So let's go back to the clinical scenarios. These were the three clinical patients. These were the three subset of patients who, probably where we could have avoided a biopsy, and what can we do for them? So in the future, if there is a patient with a suspected low-risk prostate cancer, amenably potential for active surveillance, we can do a MPMRI, then do a PHI or a 4K score, and then for a risk stratification, do a molecular test like Decipher or Polaris. For patients suitable for focal therapy, we can combine both MRI and PSMA PET scan, or offer multimodal AI evaluation to these patients, and also do a circulating tumor DNA to ensure that we are actually not dealing with a high-risk disease. The ctDNA in these cases will be negative. In patients with intermediate risk or high risk organ confined prostate cancers, that is the standard patient that we routinely see. We can do a PSMA PET CT, an AI enhanced MRI, and one of the blood based biomarkers to make a decision on the aggressiveness of the disease. And in patients with metastatic prostate cancers, we can, without a biopsy, rely on a PSMA PET CT or one of the AI based tools, a ctDNA or circulating tumor cells, and then make a therapeutic decision. What's the roadmap for future? This was published in the Journal of Urology. So what they say is by another 5 years, the validation will happen with all these tools. In another 10 years, there will be integration of all these parameters, and we try to aim for a better diagnostic yield with the R value of more than 0.95, and probably by the same time, we can also look at updation of clinical guidelines. The key here is that
Can you wind up? Thank you.
the key here is that all this data, whatever is generated across the world, should be cloud based, so that there is uniformity in diagnostic evaluation. So last slide. To conclude, non-invasive tools reduce biopsy by 20 to 58% as on date. The future looks bright with a more than 95% diagnostic accuracy using one of the modalities that I have described. But as on date, or probably even in the future, there's no tool that can replace a biopsy for evaluation of histopathology and archival, but probably non-invasive tools will dominate in the future. Thank you.
Thank you. So we are a little late. We can take probably one question. Anyone? Right. Thank you. Thank you very much, Vivat sir.
All right. Next speaker is Dr. Lin. He's a professor and interim chair of urology, and he's also endowed chair in a prostate cancer research program. He's a director of Institute for Prostate Cancer Research. He's a president of Society of Urologic Oncology. He's a co-chair of NCI steering committee. He's also chair of Prostate Cancer Committee. He's a vice chair of the NCCN Testis Cancer Control Guidelines, and he's a geosurgeon member. And he has done excellent work in the field of active surveillance. And he has given several talks in the area of the active surveillance, which is moving to the next paradigm in the realms of the cancer prostate. Dan, go ahead.
Thank you very much, and good morning. I really appreciate the opportunity. On behalf of the Society of Urologic Oncology, we have a nice relationship that we're having. Dr. Rao came to our meeting last year in Dallas for the Society of Urologic Oncology, the SUO, and we're really excited to have an increasing collaboration with your society here in India. And thank you again for inviting me for this talk. So in keeping with the theme of de-intensification, so that would be strategies to reduce the side effects of therapy on our patients. Of course, active surveillance, I think, fits exactly in that key area of what can we do to reduce the side effects of therapy and de-intensify therapy for our patients. This is some disclosures in the last few years. So I divided my talk into kind of 4 key questions. What's the evidence to support the safety of surveillance, and when should we be maybe worried about putting a patient on surveillance? What can we do exactly, as the moderator said, to de-intensify surveillance? Can MRI replace biopsies, again, reducing the burden on our patients? And then can we actually put intermediate risk patients, even expanding active surveillance to intermediate risk? I can just start out with the guidelines. So the AUA guidelines clearly say that for low-risk patients, active surveillance is the preferred management option. If one looks at the NCCN, many years ago for low risk, it was surveillance, radiation, or surgery, but now a few years ago it says preferred, very, very clearly preferred for low-risk patients. The European guidelines actually don't even allow anything else but active surveillance, saying that anybody with low-risk disease should be by active surveillance, not by surgery or any other modality. The Indian Council of Medical Research, when I looked up all their guidelines and you look online for the IMCR guidelines, it's very nice. It actually says patients with a life expectancy of 10 years. I really like the last phrase, there's no upper or lower limit for inclusion for age. Evaluate life expectancy, of course, and the Urological Society of India, the guidelines, this is just the executive summary. When one looks at active surveillance, and again, I really like what you all have done in these guidelines, saying suitability must include patients' financial condition and access to healthcare. That's very important for compliance for patients that are on active surveillance. And then, of course, this pre-biopsy multiparametric MRI, which we'll get into in a minute. How is it going now in the United States? I don't know about India. Maybe we can get in that in the question and answer. United States, for low-risk patients, and this is some data recently published, it's about 60% of eligible patients are getting active surveillance, about 60%. Why isn't it higher? If it's the preferred management, we can get into that maybe. And part of it is there's a very wide variation. All these little dots over here are individuals. You can see there are some practices that have individuals doing no active surveillance, and some practices with individuals doing 100% active surveillance. Why is there that discrepancy? I think people are worried about the safety. What is about the safety? And I'll give you some data now regarding the safety of active surveillance. We can date this all the way back 20 years ago to Scandinavia, where they randomized about 700 patients to either surveillance or watchful waiting or immediate prostatectomy. And when one looks at this, the dark area down there is death from prostate cancer, showing there's really no difference in low-risk prostate cancer. For death from prostate cancer, whether it's immediate surgery or even watchful waiting with a non-significant hazard ratio. In the United States, we had a very similar trial, over 700 patients. Again, watchful waiting, not surveillance, but watchful waiting versus surgery. And when one looks at the overall results, there really was no difference in overall survival, whether a patient got immediate surgery or watchful waiting at a PSA even less than 10. Then this brings us to the landmark trial called PROTECT-T. This is from Freddie Hamdy in the UK, where again, over 1,500 patients either were randomized to surgery, radiation, or monitoring, which was kind of like surveillance. And most of them were low-risk patients. And you see here, monitoring was not biopsies routinely, but just PSAs and maybe a biopsy if needed. When one looks here, after about 8 years, half the men in the monitoring arm actually got treatment. And then when you look at the bottom line results, overall survival or death from prostate cancer, if you look at the 3 groups, death from prostate cancer, no difference in this study. Now, there were a fair number, maybe double the number of metastasis for monitoring. We can get into that later, maybe why that is. This is our study, my study that we ran for the last 15 years, now over 2,000 patients in North America, long-term outcomes in patients. And again, when we published this in JAMA, they made us put these 2 words, protocol directed, meaning we did biopsies every 2 to 3 years, every 2 to 3 year biopsy, regardless of MRI, regardless of PSA, we did biopsies. And how did the patients do? Again, over 2,000 patients, most of them low risk. And you look here, the 10-year estimated metastasis, just over 1%. Very few prostate cancer deaths. When you look at other cause death, of course, 5%. So this looks like it's safety if you really follow your patients closely on active surveillance. Which patients should we think maybe not to do active surveillance on? There are those patients. The Prius study, they had over 9,000 patients, again, showed at about 10 years, 1% metastatic and less than 1% prostate cancer deaths. And then the final, there was a very large study here, over almost 30,000 patients in many countries, when again, metastasis probability at 10 years, about 1% if patients are followed on surveillance. Again, the safety of surveillance has been established. We know that there are some patients who might not do really well, and that's PSA density, maybe high PSA density, maybe high number of cores, and this is consistent with all this series. So with the first question, who is safe to put on surveillance? In low risk, all men, basically. Exceedingly low rates of metastasis if we follow our patients closely. Who might we not want to? Maybe patients with high PSA density or high tumor volume. So what about de-intensification? I'm sure many of you have patients who are on active surveillance who you do a biopsy and there's no cancer in the biopsy, so-called negative biopsy. And we published one of the first studies of this several years ago. BX1 is the first biopsy on surveillance. BX2 is the second biopsy. If a patient ever had a negative biopsy, the chance of having a future reclassification event was very low, less than 5%. In this, it was 9 different studies, including our own, that looked at this question. If there's a negative biopsy, what happens later? Not much, actually. Very well protective. And then finally, this one, which I think is probably the best one. This was a very large study, over 13,000 patients. 1 in 4 patients had a negative biopsy on their first biopsy on surveillance. 1 in 4. And 50% of the subsequent biopsies were negative. So this shows that we can maybe de-intensify the follow-up. If a patient has Gleason 3+3 grade group 1 disease, a negative biopsy, maybe we can spread out no biopsies for the next 5 years or longer. So those are the patients I think we can de-intensify on. To the last talk, a very, very nice talk about multiparametric MRI. Can MRI replace biopsies? Controversial right now. I think with this unfold AI and some of the other things happening, we'll eventually get there. But what is the data? The data aren't great for MRI on surveillance. MRI for diagnosis, you just saw pretty good results, but MRI on surveillance, you see the negative predictive value, 70 to 80%, and there's a lot of variability in interpretation. There have been 2 randomized clinical trials. I'll show one of them. This is over 250 patients, either randomized to regular biopsy or MRI plus biopsy, and at the end, it did not show any difference in upgrading between the 2. There were unique cancers found in each one. Now, on follow-up of this study, it did look like the MRI arm had decreased failures, maybe less patients progressing. But the authors themselves have some caveats. Maybe there was some imbalance in the randomization. And at this point in time, the final study, this was a very large study, over 2,000 patients, meta-analysis, 15 studies, precise criteria, and one looks at the negative predictive value. At best, 87%, as low as 81% negative predictive value. Clearly, they say serial MRI still should not be considered the sole factor for progression during active surveillance, and changes on the MRI are not accurate enough. The guidelines have come down. These are the Indian Council, the IMCR guidelines. It remains unclear whether NP-MRI should be performed during active surveillance, routinely or triggered. Of course, if repeat biopsies are needed, recommending systematic plus the targeted cores. In our AUA guidelines, we actually say MRI should not replace periodic surveillance biopsy. In Europe, they say base the change on biopsy, not on progression on MRI. So I think these are very clear declarative statements. MRI cannot replace biopsies and should not be the sole criteria for progression. The last question here is intermediate risk. To end with this, there are a lot of questions about whether we should do intermediate risk for prostate cancer surveillance. And our NCCN guidelines say, yes, it's an option as one of the 3 options, but there have been many studies that have looked at this. This is the Toronto series, 200-man intermediate risk on surveillance. You look at that. If you look at the 15-year metastatic-free survival, clearly after at Gleason 7 or higher, there's looked like higher metastasis-free rates. The UCSF group has looked at 400 on intermediate risk, and again, looked at 2 or greater cores of grade group 2 being suggestive of not. The PROTECT-T trial, if you look at those that had metastatic disease versus the whole cohort, you look at the grade group 2, there are a lot more. All right, so in the initial cohort, 24% were intermediate risk, but of those that got metastatic disease, 40%. So I think that this calls into question about metastatic, doing active surveillance in intermediate risk. And this is the final one, again, almost 30,000 patients. And there was similar treatment-free survival with intermediate risk versus low risk. but those at intermediate risk clearly had higher metastasis and death from prostate cancer, suggesting that maybe we should pause and not do active surveillance in all intermediate risk patients and consider other things like percent pattern 4, length of pattern 4, number of cores. So our guidelines say that certainly favorable intermediate risk can have active surveillance, but they say include those with low PSA density, low tumor volume, low percent pattern 4 on their biopsies. Again, the IMCR says it's only a favorable characteristics like PSA less than 10, clinical stage CT2 or less, and favorable biopsy characteristics. The Urologic Society of India also say in select patients, and I really like this, with a clear explanation for the increased chances of metastasis. We don't have this in our US guidelines. This is very, very, very clear statement to have a warning about active surveillance and intermediate risk. So my take home points, low risk disease, again, de-intensifying therapy. It with regular assessments has extremely safe, low metastatic rate. Use PSA density and volume of cancer to guide you. Negative biopsy is a very favorable factor associated with low reclassification rates. MRI at this point in time, unfortunately, cannot replace surveillance biopsies. We need to still perform our surveillance biopsies. In intermediate risk disease, we need to pause. There's a higher chance of metastasis and prostate cancer mortality on long-term follow-up. Consider these other biopsy characteristics. So thank you. I'll be happy to take questions if we have time. Yeah, thank you.
Oh, Dan, great talk as always, fantastic talk. So there are 2 comments and 1 question.
Yeah.
So regarding the MRI scan negative predictive value, what you saw, that is for the high grade cancer. But if you take intermediate cancer, then it goes down to 75 or 76%.
Yeah, that's true.
So that is for the MRI. The other thing I was asking regarding the PROTECT trial, the PROTECT trial, when they hypothesized, they thought of 10% mortality at 10 years. Whereas in the 15 years follow-up, there was only 1% mortality, not the 10%. So that is the basic, criticism for the trial.
Yeah.
And also the 2/3 of patients who were on the active surveillance, they underwent the treatment. 2/3 patient in this 15 years follow-up of the PROTECT-T trial. And all those patients who underwent treatment, they had advantage of progression-free survival, they have advantage of metastatic-free survival, and they have advantage of the prostate cancer mortality deaths. So
Yes.
these are 2 comments on that. The other thing I was asking, if you remember the NCCN guideline, earlier we used to say patient between 40 to 45 years of age, if you do PSA 2-3 times is stage less than 1, there's no need for the follow-up.
Yeah.
Even for the patient who is 60 years old, and you have done PSA for 3 years consecutively, if it is less than 1, there's no need for the screening
Yeah.
for the future. So what's your comment?
Yeah, so on the last one there, yeah, in the NCCN guidelines, it does say if a patient is 60 with a PSA of 1 or less, maybe no more PSAs. And that's based on very good data. He knows all the data better than anybody. That is based on a lot of the data, a lot of it coming out from Sweden, showing in the Malmo series, showing that patients that have a low PSA at age 60 or 50 maybe, that the chance of having prostate cancer death is less than 1%. It's very, very, very low. With regards to the PROTECT-T trial, and Freddie Hamdy and I have a lot of talks about the PROTECT-T data, that the majority of the deaths were those that were 3+4. They started at 3+4, not at 3+3. So they had a lot of 3+4s in that trial. And also monitoring was just sort of, maybe the PSA goes up a little bit, do a biopsy, not a scheduled biopsy. And so it worries me. I do wake up at nighttime thinking, oh no, are we doing the wrong thing? Because the metastatic rate was very high in this trial, like very high, 9% metastasis at 15 years, like 10 times ours. So I think it demands routine monitoring and maybe being very careful about 3+4 prostate cancer.
Dr. Gupta?
Yes. Oh, yes.
Is our concern in India
Mm.
and the cost of the fees in India don't pay any money to the patient or any diagnostic like biopsy or MRI. That is the concern. So intermediate 3+4, we are not comfortable for the.
Yeah, I agree with you. I think that there have been some studies that looked at compliance And in fact, in the Toronto series, the big Toronto series, the really major one, when they looked at compliance, coming back for biopsies, having a biopsy, if they didn't have that much higher death from prostate cancer, much higher metastatic rate. So it really takes patients coming in, coming back for the biopsies, being monitored very carefully. And then if they go from 3+3 to 3+4, then getting treatment. There are many people that go 3+3, 3+4, no, I don't want treatment, and then they have a problem. So I think that if it's a patient that will not follow your instructions, that will not come back, and they're 3+3, maybe they should just have surgery right away. I agree with that. Yeah.
Thank you, Professor.
Yeah, thank you.
Thank you so much.
Thank you. So I invite Dr. Yuvraja to basically talk about whether focal therapy is now the treatment for all intermediate prostatic cancers.
Good morning, respected chairpersons and dear colleagues. So my talk is on whether focal therapy is ready for all intermediate prostate cancer. I think it is a little bit overstretched as far as the indications goes, and let us explore what exactly means, where does this focal therapy stands out. So the basic guiding feature or a game changer is the MPMRI and targeted biopsy. These have completely changed our understanding and management of prostate cancer, especially early prostate cancers. And with the recent AI integration is becoming more and more important and easy to diagnose these cancers. So now we know that focal therapy, as a definition, it is a guided ablation of an image-defined biopsy-confirmed cancerous lesion with a safety margin. The question is, who are the candidates who are suitable for focal therapy? Although in India is slowly picking up, but it's not very well established in Indian subcontinent as far as the indication and the treatment goes on. But when we consider the Gleason scores, generally these are all typically 3+4, that is favorable intermediate risk cases are more suitable for focal therapy. Although few select cases of 3+3, the low risk Gleason group 2 and Gleason grade group 4 is very rare indication. We divide into favorable and unfavorable. So I think favorable goes in favor of focal therapy when compared to unfavorable. So all other indications are there in the list. So now the question of the multiple or multifocal cancer. So how does we look at or counsel the patient when we opt for focal therapy? Because many patients, we know that there are heterogeneous cancer and multifocal cancer. But the concept of an index lesion and an aggressiveness of an index lesion and indolent nature of a non-indolent lesions is by the concept of focal therapy, where we have to target only the index lesion, not the indolent lesions. So where does it fits into? So we know that radical therapies have got a problems. It's a morbidity significantly, perceived by the patients, and we have active surveillance with nice talk given earlier. So, but still there is a cancer progression of 20% in 10 years, or usually when you see the SEER data, it is almost 50% fallout in 2 to 5 years. So there is a psychological burden. So the focal therapy completely fits into these two extreme and doing nothing versus doing everything, which increases the morbidity. The range of technology were capable of destroying the prostate tissue. What we have is direct therapy, where we use cryo or nano knife, or indirect therapy, HIFU, as well as brachytherapy. So we have laser light and toxic which are not very popular. Then there are various strategies for focal therapy. Either it could be a focal therapy only the concentrating on the lesion, and then we have a hemiablation or a hockey stick or a whole gland. So as of now, the guideline says that whole gland ablation is not very acceptable treatment. So we are confined to focal or hemiablation almost 90% of the times. So now it is an a la carte approach. So the people ask me, so you have one energy source is enough? No, we don't. We generally minimum 2 energy sources are required because the indications and contraindication fits into 2. So generally for anterior lesions or the gland, if it is more than 80 grams, then we don't do HIFU. So for these patients, it is the nano knife which takes over, a cryotherapy which takes over the indication, and brachytherapy, a focal brachytherapy is coming as a big way, so that also takes over. Then we have HIFU, is a very versatile, which is available in India, so in 3 institutes. So we have a concentrated ultrasound energy into a targeted zone. So we have different instruments which are available. One is sonoblade, another is a focal therapy. But I think we all 3 are sonoblade as of now. who is not suitable for primary focal therapy, naturally who doesn't buy the concept of focal therapy. Some people don't agree with that. The reason is that, they always think that the cancer is going to come back in the other lobe or in the same lobe because it is a multifocal therapy. Or large intraprostatic calcification, more than 80 ml. So previous brachytherapy, these are the relative contraindications to do focal therapies. So generally, when we do HIFU therapy, we divide the gland into three segments, segment 1 to 3 from anterior to posterior, and then divide them again into from cranial to craniocaudal direction into 2 millimeter cuts, and then we ablate the tissue. So now, if you see follow-up after focal therapy is generally a little bit complicated because we have to identify the lesions which are significant. So our protocol in the institution protocol is to do repeat MRI at the end of 12 months, which acts as a basic baseline study, and then we follow up the patient and compare with the MRI as well as the PSA. At PSA elevation or MRI shows any new lesions, we subject from the biopsy, but we don't do routine biopsy in our cancer registry. So if what happens if there is a recurrence of the tumor, so we can do. So the only advantage of the focal ablation is the field is open. Either you can do repeat ablation, radical therapy. If it is out of field, again repeat ablation, radical therapy. Every option is open as far as the patient is fit to undergo this treatment. So do we have proof of this? So if we go back to Ashim Ahmad, so it's a 2012 paper. It's a very small study. You can see the long-term 89% of men achieved a trifecta with focal therapy. So then we have another study by almost close to 1,000 patients by Taimur and et al. And if you see, so most of the database, it says that so there is no difference between compared to IFU plus cryo versus LRP. That is that time. So LRP was very popular. So if you say SONA-blade data, clinical data, even for intermediate risk patients, if you see 92.2% cancer control at 7 years and 15 years, almost 68 to 70% cancer control. And if you see, this is a recent paper by Deepika Reddy. We say they targeted intermediate and high risk patient. Little bit unbelievable to do this type of treatment in high risk because these are all the patients who don't want to undergo surgery. So they were posted for this. And then the cancer control is very, very comparable. So if you see, this is a study by Dr. Shoji. If you see, for intermediate and high risk, 92%, 88% 4-year follow-up, PSF free progression survival. So then we have another study where we have, intermediate risk group with 12 months cancer-specific prostate cancer PRFS is almost to the tune of 80%. So I think the data is accumulating, although we don't have a direct comparison or randomized study. So we have, but there's one paper which says that for a patient with a unfavorable intermediate risk, it doesn't do well. So there's one paper which is recently published last year. So I think this is one paper we have to really critically analyze it and see. So because it is not for everyone, but future there are few randomized trials are going on. I think they are going to throw light on this PART trial, Kronos trial, and I think we are going to get the answer of focal therapy is going to be suitable. The most important is not now, as we know that active surveillance is accepting wide and wide. As Dr. Gupta told that in India it's very difficult to do this active surveillance. So we have a wide gap of patients who are all, require therapy, but radical therapy becomes more aggressive. And now there is a concept which is going in, especially in UK, is active surveillance plus. Means patient will be given focal therapy and active surveillance for the all other lesions. Index lesion is focal therapy. It means combine both and then give better treatment to the patient. The guidelines says that in the form of registry, highly select patients is an appropriate therapy. So in our
please.
Yeah. 8 minutes. Yeah. So HIFU in our institute, it is is a very small series, 82 patients. Focal 20 and hemiablation is the most common treatment what we do. If you see the Gleason score, so we have 3 plus 4, 46 is the most common indication, and 4 plus 3 very highly select patient who refuse to undergo other treatment, and they buy the concept of focal therapy. Complications are very minimal, and as of now, at the mean follow-up of 12 months, we have not identified any recurrence. But one patient had PSA elevation and he had biopsy proven lesion outside the ablated site. So that is the very early experience. We are waiting for long-term results. So is focal therapy ready for prime time for intermediate decision? Yes, for a favorable risk, but no for unfavorable risk. I think we should not choose them electively unfavorable risk, but it must be done very, very well, carefully selected patients, and rigorous follow-up is required as active surveillance is concerned. Thank you so much.
Thank you. Any comment, Adam or Dan? I have quick comment for you. So basically what you said, the focal therapy relying on the this MRI scan and the index region. As Dr. Professor Lin pointed out, MRI scan is a negative predictive value for the intermediate risk cancer. Even we are taking unfavorable, it's a 76%. Also, there is the whole gland involvement is there. So there are a lot of issues with the focal therapy at this point in time. And again, the transcriptive heterogeneity inside the prostate is not, so there are a lot of issues, but, we can discuss.
Yeah, it is always there because, we cannot get 100% answers for these things. So we are going to have some negative, false positive. So MRI is not suitable. But still, when you have a baseline study and compare it with serial study and at the high index of suspicion, do a biopsy, I think that's the maximum what we can do as far as clinical situation is concerned.
Dr.
Yes.
I was going to comment, it's a very nice presentation, and I think focal therapy is something we need to increasingly embrace. The question is actually one of patient selection, and I think it's really about the imaging. Can we identify where in the prostate the tumor is and ensure that it's not elsewhere within the prostate? And I think one of the problems with the 4+3 as opposed to the 3+4 is not so much the cancer is more aggressive in the focal area, or that the technology doesn't work. It's that those are patients that are much more likely to have multifocal disease. And so it's not really going to work in that patient population. But as our imaging improves and maybe incorporating AI, I think there'll be an increasingly large population of patients that we can treat in this way.
Thank you.
Dan, you have any comment? Okay. Thank you.
Who is doing your focal therapy? Urologists are doing, or
I'm doing.
your radiologists are doing?
No, we are doing.
Urologists are
Yeah.
doing. How much time you take in one case?
In one case, the ablative part takes around 45 to 50 minutes, but the entire preparation, everything takes 2 to 2.5 hours. It is like surgery only.
Yuvraj, can I ask you one question? You've had experience with the HIFU. TULSA has recently been shown in some of our conferences. So between technologies of the same energy delivered transrectal versus transurethral, what are your comments?
No, I don't have experience transurethral ultrasound therapy. That is
We just saw that in the last
machine.
meeting.
So I have seen the machine in somewhere in Europe, but I don't have any idea of that. I think Dr. Conetti can tell that.
Yeah. 2 more comments, Dr. Conetti.
A great talk, Yuvraj. I just had a quick question. We are still relying on MRI as the primary imaging modality, right? What's the role of PSMA PET in this, or maybe PET MRI even? Because you're just looking at imaging, but not looking at the physiology of it.
Yeah, it's a good question, but I think generally in our clinical setup for a primary diagnosis and staging, we don't do PET CT. Generally, we do it for a metastatic workup, and PSMA PET, we don't have it. So I think, only I think 1 or 2 institutes in India have PSMA PET, PSMA MRI, PET MRI.
But Dr. Conetti, again, the same issue, the MRI scan again is at 27% people, they have a normal MRI scan, but they can have a cancer prostate. Because based on the data of the MRI scan. So again, we are in the same. And the other thing is that biopsy is more important, because if you see the Larry Cloud's paper, earlier paper, even in the first series, 42% positivity. They ran the randomized control trial in Germany. The randomized control trial stopped because the infield 67% recurrence of the high-grade cancer. So a lot of the data emerging, but we are not yet there.
You're right, sir, because the protocol for most of the institutes doing IFO or any focal therapy, automatically they do at 1 year biopsy, at least, to know this thing. But in India, it's very difficult to, convince patients. So we have taken a suggestion that, based on this MRI and PSA, we will let us decide.
Thank you.
Thank you,
Yuvraj. So our next speaker is Dr. Jiten Jaipur. Is he here? He's online.
Yes, I am there, but I have pre-recorded my talk so that it's easier for the network.
Is it a recorded one? Jiten, can you hear us?
Yeah, I can hear you. I can hear you.
So we have Dr. Jiten Jaipur online from Portsmouth, and he's speaking on innovative intraoperative imaging techniques to reduce margin positivity and subsequent adjuvant therapy. Jiten, go ahead, please.
So can I request my pre-recorded talk to be played? That would be easier for you guys. Then I can answer the questions.
So
Or do you
it's a
want me to?
pre-recorded talk.
Yeah.
Yeah, we're just getting it on.
Thank you for giving me the opportunity to speak on innovative intraoperative techniques to reduce margin positivity and subsequent adjuvant treatment during robotic radical prostatectomy. My talk will cover the problem statement and innovations in the field and impact of those innovations on the outcomes. Radical prostatectomy carries the potential to impact the lives of patients significantly and irreversibly. And the true NTH post-surgery UK investigators remind this to us with their periodic analysis, latest of which from 2024, from 26 UK centers, including 2,000 men operated between 2015 and 19, shows that among men who were leak-free and pad-free at baseline, 1 in 3 reported wearing a pad at 12 months, and 1 in 10 reported a moderate or big problem with urine leakage. Among men with strong erections at baseline, at 12 months, only 6% reported erections sufficient for intercourse without a medication. 4 out of 5 men needed more than tablets and a vacuum pump when it came to keeping sexual function alive. During the same time, Bau's audit shows that while half of patients should have been eligible for a full bilateral nerve spare, only a third ultimately got it. And despite over-treatment and over-resection, 1 in 5 still ended up with a positive margin. Thus, there is a huge unmet need for better aid to intraop decision-making to save the nerves and preserve potency and continence mechanisms better. And we have innovated and tried to come up with solutions intraoperatively, which can be broadly classified into ex vivo and in vivo categories. In an ex vivo technique, we essentially extract the specimen to immediately assess its margins. The most popular among the ex vivo techniques is the NeuroSafe technique, which is based on the same principle of frozen section analysis, which is the standard of care for many other cancers as well. The main issues impacting its widespread adoption include the need for a dedicated uropathologist, added 1 hour of processing and analysis time, and the involved costs. However, newer ex vivo techniques using confocal laser endomicroscopy that is being currently trialed at Imperial allows you to immediately process the whole mount specimen for margins bedside in 10 minutes, and the images can be interpreted with aid of AI and a remote pathologist, with the learning curve being not prohibitive for a surgeon to also master. Their initial results of the Imperial Prostate Flores trial, announced in EAU 2025, show a high positive and negative predictive value reaching 80% for any margin. Techniques involving ex vivo imaging based on PSMA PET that we hope to trial in future at Portsmouth allow you to completely bypass the pathologist, but then brings the nuclear medicine specialist into the theater to give the PSMA-bound ligand in the morning prior to the operation. Intra-op PSMA scanner can show surprise new lesions that NeuroSafe may not even suspect. So for example, this case had lesion in the left lobe of the prostate on preoperative MRI, right lobe on the preoperative PSMA PET, but intraoperative PSMA PET showed a new third anterior apical lesion that was positive at the margin. Dar et al. Recently reported in EAU 2025 that in their cohort of 28 patients with high-risk cancer, 40 to 70% of patients which could have had both or one side nerves at least spared based on intra-op PET assessment of margins. However, a common issue with all the ex vivo techniques is that it's difficult to orient the margin positivity spot to the exact corresponding area of the neurovascular bundle, and we end up resecting the whole neurovascular bundle if the margin is positive. However, we can solve this challenge with an in vivo technique, and MRI combined with live augmented reality using the Tile Pro feature of the Da Vinci has been an area of active interest since past few years, and so have been 3D printed models of prostate to help surgeons better understand spatial orientation of lesions during dissection. Meta-analysis of small number of series show a trend towards better attainment of negative margins and higher potency and continence at 12 months using augmented reality models. We can also perform confocal laser endomicroscopy intra-op using fluorescein injection and a fiber optic probe, though it does add to time and responsibility on the shoulder of surgeon. However, I find in vivo technique relying on fluorescent probes and PSMA guided near infrared fluorescence to be the most appealing, as it allows the ability to pinpoint the exact location of the neurovascular bundle where cancer cells are, and then we can do a limited resection of the neurovascular bundle limited to that area. These innovations have now stood the test of a phase 3 randomized controlled trial and NeuroSafe Proof trial randomized 400 patients split into NeuroSafe and conventional RALP arms across multiple UK centers with inclusion criteria of men with strong erections at baseline, with IIEF 5 score at 12 months being the primary outcome of interest. Despite the surgery planning MDT recommending a bilateral nerve spare in only a third of patients preoperatively, 82% patients had a full bilateral nerve spare in the NeuroSafe arm, and extensive or multifocal margin positivity was no different across both treatment groups. However, patient in the NeuroSafe group had the opportunity for additional intraoperative resection for a positive margin, which was done in 17% cases, and cancer was found in the additionally resected tissue in 44% cases, justifying the decision. And as far as for the principal outcome, while 20% in the conventional RAL had mild or no erectile dysfunction at 12 months, this figure in the NeuroSafe arm was 40%. So data on NeuroSafe has now reached substantial numbers to draw some reasonable conclusions. It does seem reliably associated with better potency rates, while allowing for a lower rate of positive surgical margin, with no harm in terms of biochemical recurrence rates, at least in the short term. And there is no evidence to believe that long-term outcomes would be any different. So in conclusion, intraoperative margin assessment allows better preservation of potency while not compromising on any oncological outcomes, and in my humble opinion, should be the standard of care in institutes of excellence. Thank you for your kind listening.
Thank you, Jitin. Let me tell you, Jitin is a fellow of Dr. Sudhir Rawal. Dr. Rawal trained him. He's currently in UK. We are running behind time, but we have your email address and phone number, so we'll send you the questions. So we'll move on to the next speaker. And next speaker is going to speak on common iliac lymph node in radical prostatectomy.
Dr. Thiranjan Basu, is he there? Yeah. So common iliac node M1 or locally advanced?
Good morning. Thank you for the invitation. So my talk is on something different from what we started the morning with. It's on whether we stamp common iliac node as N1 or as M1A. And a first disclaimer, it's a very data-free zone. So whatever experience I am sharing here is based on very sparse literature available. So let's see it. On a single line, if you see the staging, I have purposefully kept the N and M for it's very simple for prostate cancer. You have nodes, regional, it stands as N1. You have non-regional nodes, then they go into M1A. And in non-regional, this para-aortic or common iliac, which is the topic of discussion, they fall into a non-regional lymph node. So in a single line, yes, a common iliac node would classify as something non-regional. But why we debating it? What we know about common iliac node, that over the years, the staging has improved with the diagnostic capability with PSMA. We better can pick up them as treating on non-surgical methods and even surgical, we better can delineate them. And also the overall approach has changed from a time where it used to be just a long-term ADT. something which is not positive prostate, to more curative approach, more of non-surgical approaches, and a systemic intensification. So that brings us, we know what we know from the pro PSMA study, there's an improvement in diagnosing this. Thanks. It's just improved the diagnostic ability from something which is in conventional imaging would have been N0 to picking up the nodes and will only focus on common iliac. We know across studies it is specific doing a PSMA PET CT, and even in typical sub-analysis with the common iliac node between a conventional imaging to a PSMA, there is actually a double rate of detection of common iliac nodes. We also know how our delineation has changed, something from older studies and staging system limiting the upper border of in a radically treating node to true pelvis to RTOG, then changing it to a cranial border, taking the distal common iliac, and then further going and taking the newer nodal guidelines, which include at the point of common iliac bifurcation. So we know that we are trying to treat them radically, even if by AJCC we are stamping them as M1A. We also know long back now, for about close to 10 years, that from the DanSprat data, there will be 10% isolated common iliac node when they were treating only prostate and not covering the nodal levels. So typically the isolated failures were around common iliac. In terms of survival, if it is a low volume metastatic HSPC taking common iliac as M1A, we know the non-regional cohort, which common iliac would be a part, would fare better than bone and better than the visceral disease. But unfortunately, the phase 3 randomized control trials have very poor representation of that, very poor representation of M1A, and be it common iliac separately, it's hardly there. We also know as the techniques have improved, by either you do a moderate hypofractionation or an extreme across studies, and most of the studies are from India. The often criticized part while treating common iliac, you end up having more bowel toxicity because the bowels would be exposed. If you really concentrate and see the late grade 3, which will be something to worrisome, and even taking grade 2 and 3 together, 3 never reaching a double digit, 2 and 3 even counting together as across series less than 20%. And these also have randomized data, the prime trial acute toxicity data, and also the late GU data even after post-TERP been published in a full text. So as also in the SBRT series, some have reported, most of them have reported, and the late grade 3 GU side effects are very low. It's just about 3-4 patients getting them when they are even covering the common iliac nodes. And in all the M1 series also, so somehow this delineation guideline is quite well settled. For common iliac, you go up to the at the point of the bifurcation is starting so that we don't miss it. And somehow even covering them in CTV node, we are naming it as M1, but it is covered in an N covering as we would have for lymph nodal. What we don't know about common iliac, which is the more of concern. Does local therapy have improved survival? Do we have enough data specific to M1A taking common iliac node? What should be the appropriate non-surgical radiation schedule, a moderate hypo or SBRT? Again, somehow we have two very strong data which are often highlighted for common iliac, both with Vedang's team in 21 followed by 22. The 21 data had 60 patients, among them 20 were common iliac positive. Most of all of them were treated by SBRT, and 80% received prostate with pelvic nodal coverage. And we can see the 3 years OS and biochemical failure-free survival, which are quite decent. In 22, which is compared between an CN1 and CM1A taking the common iliac, 130 patients with 43 being common iliac, 70% up had SBRT 5 fractions with prostate and pelvis, and a very decent 2 to 5 years biochemical failure-free survival. Even in the stampede arm, the most highlighted and the most strong data of M1A series, when it's a long-term published in PLOS 22 recently, the only non-regional lymph node cohort, M1A, would have been, had 81 patients representing 9% of the total cohort, and the hazards are quite good for better OS and FFS. This again will be criticized if they have reporting more toxicity. Unfortunately, no. The toxicities again as reported from Indian data and also from the long-term stampede H-arm data are quite acceptable. The first symptomatic local events, just about 10-13% of some UTI, catheter insertion in 7%, and needing TURP only in 4% while covering the common iliac node. When we don't have data, we go for consensus statements. The APCCC 2022, 94% of the respondents favored a local treatment in M1A disease. And in the last 2024, M1 HSPC with retroperitoneal lymph node, where the statement has encompassed whole retroperitoneal lymph node. Though there is no typical consensus, but 92% favored either a primary RT, systemic therapy, and metastatic directed therapy in different combinations. The Dutch have their multidisciplinary consensus meeting and given an idea about M1A stamping, but again, it's not specific to common iliac node typically. Three very important points comes out of it. All of them favored PSMA as staging, a solitary node, a node below aortic bifurcation, and up to 3 lymph nodes would be a curative M1A. And this also establishes the maximum utilization of ADT and RT and radiotherapy for treatment. They recently have also given an 2 scenario based low volume M1A disease as diagnosis. Again, not specific to common iliac lymph node alone, because M1A can have other non pelvic nodes as well. But these two scenarios where ADT and prostate radiation and a second generation androgen receptor blockade with or without MDT can be taken into consideration, where you have multiple nodes all less than 2 centimeter above iliac, or at times even above aortic bifurcation, or you have 2 nodes below the bifurcation and up to 1 or 2 bone mets. So this gives at least some decent guideline and data to suggest. Even in the post-op data, when we see, we know the pelvic lymph node dissection and extent have also remained debatable. Some benefit in metastasis-free survival if you do extended pelvic lymph node dissection, we know, and the EO is the only guideline which sort of endorse it. And the N1 M1A will have worse outcome than the N1 post-op, we also know already. This led to an EAU 2024 press meet that this PSMA M1A positive patient should be treated actually as M0 in the PSMA era. We should wait for these two trials, expanding the boundary, the pulse, which once you have nodes there, you try and even improve your coverage to the para-aortic elective radiation. They are treating by moderate hypo with a phase 2 study protocol of GI toxicity and trying to see a MFS in phase 3, as well as the Stampede 2 arm, which again relying also unfortunately on conventional imaging. The role of PSMA comes only as next generation if they are not saber able as they would stamp it. Their standard of care still remains ADT, second generation, plus minus DOSI with prostate RT. So these two would give us some idea in the long term.
So Basu, can you
last slide, sir. Just I can skip that. This is bit technical. Just while covering where are we really adequate by NRG CTV, there are some points to it. The cranial border is adequate. Manish from TMH actually has done an analysis, but for the left common iliac, probably they need some modification also. So I thought I would end with a short analysis of common iliac. We know the strength of it because it can be treated as high risk and high risk node positive in pelvis as we would have. It might delay intensive systemic treatment and avoid the long-term side effects of ADT and RP. We do have weaknesses. We have lack of data, mostly non-randomized and not specific to M1A with common iliac lymph node cohort. And we always have focused on systemic intensification across trials and guidelines. This leads to window of opportunity, probably ADT-based response and then treating them, PSMA-based response, trying to see prophylactic para-aortic irradiation, and even biology or genomic guided. We should not be an assumptive level of predictive the M1A of typically a non-biology driven, and it should not turn out to be a dicto simpliciter. Thank you.
Yeah.
So we move on.
So Dr. Basu, if you may, in these protocols, ADT remains an essential part. Is that right? So these would all. Yeah, ADT remains an essential part of therapy for all these. And as you mentioned, the systemic intensification. So in all these patients, it would be 2 years ADT or it would be 6 months?
No, sir. All these, because high risk node positive also, it is 2 years, at least 2 years.
At least 2 years.
Prostate,
And you
yes.
would also consider using abiraterone or enzalutamide along with the standard?
Across the trials, most of them have used it,
Both of
abiraterone.
them have
Yes, sir.
used.
Yes, sir.
Questions from you?
Now, from your data, how often it has happened that when you do PSMA PET, that you had picked up a skip lesion in common island?
So fortunately in India, PSMA-based PET is quite rampant for all high risk across all of us treating. We always have a PSMA PET. Picking up common iliac node where it was not reported maybe in other images would be around 10-15% max at the red cell.
How high?
Yes, sir. In high risk, and if you already have a pelvic node, then the chances increasing more.
No, that I understand. What I basically was asking was
Maybe around 8-10%.
Still, that is very high percentage because the reason is, so this is not a pathological diagnosis. This you are talking based on the PSMA PET,
Yes,
am I right? So now if you look at the data of the PSMA PET, we have a keynote speaker, he'll be talking. The biggest problem of the PSMA PET at this point in time in detecting the lymph nodes. So the false positive lymph nodes on PSMA PET is very high at this point in time. So you cannot totally rely on this. That is number one. They will talk, his keynote speaker is here.
Doctor.
The second issue is, as Dr. Kekre was pointing out, isolated lesion to common iliac is very rare. Not rare, it's very rare. If common iliac is involved, then internal iliac group of lymph node ought to be involved at least 40 to 50% time.
Yes, sir.
So that is the another caveat in what you are saying.
Yes, sir.
So that is what at this point in time, and in my opinion,
Can I ask Dr. Vedang to comment, please? He's here in the audience here.
Sir, I agree with what you're saying. Even in our paper where we compared the outcomes of common iliac or N1 or M1A, all those who had M1A, but the crux of it is we must treat, it's called M1A, but we must treat it with a curative intent. And the outcomes are quite remarkable at 5 years.
Whether the other problem in Indian population, there's a lot of chronic prostatitis, and also the non-reactive lymph nodes are very positive. You can see across, like you see the false positivity of PSMA PET in the Indian population is much more high because of the reactive involvement of the
I am
lymph
not
nodes.
sure that is entirely true, sir. I think the false positivity rate, or I don't think it's an India specific thing. And it's about 7 to 8% false positive and may not be so much in the node. So I don't think that's a big issue. But I agree that skip only common iliac, we have to be careful while interpreting it.
I think that's a very good point you made, that when you have a disease positive, whether you should treat with a curative intent going higher up. And if it shows a better thing, I think it makes sense.
Yeah, I think
Thank you
we
very
should.
much.
Thanks,
So
sir.
now I'm very happy to call one of my own fellows. Sorry, which one is?
Yes, this one.
Sorry, radiation toxicity.
Then
Has
the-
technology reduced harm? Dr. Malik. Yeah, sorry. I thought.
Good morning, everyone. We've had a very early start, and thank you to the organizers for inviting me to speak on this topic. So I'm going to talk to you about how technology has potentially reduced the toxicities in prostate cancer. Has reduced the toxicities of prostate cancer treatment. Now, radiation therapy for prostate cancer is widely applicable, both for localized, node positive, and limited metastatic disease. What is important to understand, and I understand that this is mainly a non-radiation audience, is that the curative doses for prostate cancer are very high. And these doses are highly toxic for the rectum and the bladder. Over the years, fractionation for prostate cancer has evolved from conventional fractionation to moderate hypofractionation, and there's a big push for ultra hypofractionated or stereotactic radiotherapy. And this is often used synergistically with androgen deprivation therapy, especially in high risk and metastatic disease. Now, this is the anatomy of the prostate, and if you see that it's surrounded or very close to the bladder and the rectum, and if we want to treat a box-like area, a substantial volume will get treated. So the local toxicities of radiation therapy involve urothelial or mucosal damage, vascular injury, and muscle layer changes, which contribute to chronic changes in the mucosa and the blood vessels that lead to late toxicities. And when we talk about toxicities, you're going to hear a lot of grade 2, grade 3, etc. The most common way of monitoring toxicities is with the CTCAE version 5 in clinical trials, but also the Lent-SOMA classification. And these are some of the the toxicity grades. So when you have very severe toxicity, gross hematuria, gross rectal bleeding requiring blood transfusions or active interventions, that's when it's grade 3. When it's lesser interventions, it's grade 2. Now, first, let's talk about intensity modulated radiation therapy. That has been there for a while. And basically what it does is that we are trying to conform radiotherapy around the prostate with a relatively tight margin. And we are giving radiation beams from many directions with what is known as inverse treatment planning, which is specifying what doses are allowed and what are not allowed to what are known as organs at risk. And as you can see from the dose distribution on the right, that you can sculpt the dose to come out of the rectum and the bladder. Now, IMRT has become the standard of care, not by virtue of a randomized control trial, but by virtue of large institutional case series. This is from the MSKCC, which shows that, even with the addition, a higher dose of radiotherapy with IMRT, that grade 2 or higher late rectal toxicities actually came down. So IMRT has become a standard of care. From a post hoc analysis of a large randomized control trial, the RTOG0126 study, which was not actually investigating IMRT, but allowed 3D CRT and IMRT as a part of a dose escalation protocol. They compared the toxicities of IMRT versus 3D CRT in the patients in the high risk or the high dose cohort, and found that there was significant reduction in the incidence of grade 2 acute GI-GU toxicities, as well as in late rectal toxicities. And it is from this trial that we have what are known as our initial dose constraints for radiotherapy to these structures. Now, there has been many studies, many small comparisons, and a meta-analysis of IMRT studies show that in several of, especially acute, but also late toxicities, there has been a substantial reduction with the use of IMRT. So IMRT has become de facto the standard of care, and all appropriateness criteria guidelines now specify that you must use IMRT. And if you don't have it, you should consider referring patients to centers that have IMRT. Now, when you are giving very conformal doses, you have to ensure that the dose is delivered in the right place. And this can only happen when you identify the targets properly, when you identify the uncertainties of daily treatment, especially rectal filling, bladder filling, rotations, changes in seminal vesicle positions on a day-to-day basis. And that is why we have to give a small margin known as the planning target volume margin around the tumor. And to ensure that the dose is actually going to the right place, we have to use what is known as image-guided radiation therapy. And image guidance is done in modern usage with the use of what are known as usually cone beam CT scans, which are special imagers that are attached to the linear accelerators, and they can image very fast in one rotation the position of the organs. And these have the technology, the imaging quality has evolved, and now with the modern imaging quality, you can actually see these organs very, very clearly. And what we have found out through research is that we have to do this imaging daily for prostate cancer because of the uncertainties of the rectal position and the bladder position on a day-to-day basis. And this has been proved through trials done in the US by Dr. Kopelian and colleagues, and also in local studies, including this study in our center, where we found that unless you do daily imaging, and this is a very important quality criteria, you need to give larger margins, and that will increase your toxicities. Now, it also turned out through research that the prostate also moves during treatment, especially if the treatment time is a bit long. And there was the development of electromagnetic tracking, which allowed the treatment to stop if there was, bowel gas passing through, or if there was peristaltic motion or other changes. Now, this technology now has been superseded, but it basically showed that with the use of these technologies, you can reduce your margin around the prostate to a much smaller, width, which allows you to reduce toxicities, and this was proved through prospective clinical studies. Now, all of this technology, all of the daily imaging, does it lead to clinical benefit? At the beginning, we didn't know whether it really leads to benefit for patients. Large institutional series did show, however, that after the adoption of image-guided radiation therapy, there was a reduction in the late genitourinary toxicities and improvement in the outcomes, especially in high-risk patients, by making sure that the treatment was being delivered to the right place. Subsequently, there was a large randomized control trial in France that compared less frequent daily imaging to less frequent imaging to daily imaging before treatment. And this, multi-institutional trial found that there were more than, grade 2 or higher side effects and better biochemical and clinical recurrence-free survival. So although these were not the primary endpoints of the study, they did show, benefits that really, validated what we thought is that daily imaging does lead to reduction of toxicities. Again, there has been a meta-analysis of image guidance radiotherapy studies. And if you see the hazard ratios, you will see that there has been substantial reduction in acute and late GI and GU toxicities from the use of image guidance, apart from the late genitourinary toxicities. Now, imaging has moved further forward. We now have what are known as MR-Linacs, which is a linear accelerator combined with MR imaging, and the MR-Linac has the advantage of better, soft tissue visualization that comes along with the MR imaging. And these images and videos show that how clearly we can see the margins of the prostate, and it also allows a cinematic representation, which allows a new form of gating. So with the use of this imaging, it is entirely possible to reduce margins or stop treatment midway if there is a movement of the target structure. This has been tested in a randomized control trial known as the Mirage study, which tried to reduce the margins from 4 millimeters to 2 millimeters with the use of MR imaging. And as you can see, there was a 50% reduction in acute grade 2, acute GU toxicity, acute GI toxicity, and in terms of patient-reported outcomes with the IPSS score and the EPIC 26 bowel score. And this was, further, with longer follow-up, the 2-year endpoint maintained these benefits. So there's a clear evidence that with the use of new technology, with the use of better image guidance, you're reducing what matters to patients, the toxicities of radiation therapy treatment. We now have other modalities in radiation therapy, one of them being proton therapy. And I won't belabor, the biological basis. Proton, treatments are delivered, using the advantage of what is known as the Bragg peak. And you can see that there's a much less dose spillage into surrounding normal tissues. And again, there's been small studies, dosimetric studies, clinical studies, which show that there is potentially a benefit in terms of toxicities with proton therapy. None of these were so far randomized control trials. However, unfortunately, the only randomized control trial that has reported so far, which is the Party-QOL QOL study, did not find a clinically significant difference in patient-reported outcomes. This has, however, only been reported in abstract form in a recent meeting, and we are awaiting the results in a full paper, which we can, of course, discuss and debate in the future. Now, these are some of the modalities with which radiation therapy has reduced, technical modalities with which radiation therapy has reduced toxicities. This has been, as the previous speaker showed, been used in ultra hypofractionated series, in SBRT studies, and modern series show that the side effects of the local side effects of the use of modern technology is really, really low. And what we usually associate, the toxicities that we usually associate with radiation therapy, proctitis, cystitis, bleeding, have been reduced considerably. But there's another angle to the use of radiotherapy, which is the reduction of the toxicity of androgen deprivation therapy.
Can we move to conclusion?
Yes. So there have been a series of studies in oligometastatic and oligoprogressive disease, which have tried to see whether the use of metastasis-directed therapy with SBRT reduces or can delay the use of androgen deprivation therapy. These are phase 2 studies, the STOMP and ORIOL, which have demonstrated nearly a 7-8 month delay in androgen deprivation therapy use, or a limited use of androgen therapy instead of potentially permanent or long-term use has been tested in the EXTEND and RADIOSA studies, which have also shown excellent results. Even in castration-resistant prostate cancer, carefully selected patients, when treated with metastasis-directed therapy, have shown an extension till the requirement for the next line of systemic intensification. Therefore, to conclude, technology has played a pivotal role in reducing local toxicities through better target delineation, planning techniques, and image guidance. Proton and carbon ion therapy have the potential to push these boundaries even further, and the selective use of metastasis-directed therapy can help delay or limit the use of androgen deprivation and systemic intensification, and thereby limit toxicities of hormonal therapy as well. Thank you.
Thank you very much. I think as we are running short of time, we can ask you questions later. I'm very happy to call one of my own students, Dr. Vivek, to come and speak about selecting patients for lymphadenectomy, imaging, and nomograms.
Good morning, everyone. Thank you for this opportunity. Yeah, thank you. So I thought I'd start with a couple of cases which I had actually come across during one of my first couple of years in practice. So classic case on the left, 69-year-old intermediate risk prostate cancer, and the guy on the right, high risk, very high risk disease, came from Africa for an opinion. So what do we do next? Who do we actually need to stage? So as per guidelines, only those who are ISUP 3 and above, high risk and very high risk disease, actually need staging. And when do we perform a lymph node dissection? It's indicated if the risk of positivity is more than 2% according to NCCN guidelines, or more than 5% according to EAU guidelines. The templates are pretty standard, and the morbidity of lymph node dissection as such is not that high. Of course, there is a risk of vascular injury at times, but that's very rare. So moving on to the staging in terms of imaging, the standard which was done in the past included the CT and MRI. Their specificity and specificity, while it's quite high, the sensitivity isn't very good. There's a lot of overlap between the diameters of a normal lymph node and an abnormal lymph node. Cutoffs are usually about 8 mm in the pelvis and 10 mm outside. And in low to intermediate risk disease, the actual detection of lymph nodes by these methods is less than 1%. Diffusion weighted MRI may help, but again, the negative predictive value is not high. So the next scan that was used for staging was the choline PET, which again has a better sensitivity, and a prospective trial showed it was better than conventional imaging, and it improves with high-risk disease. What we do, and a workhorse in India, is the PSMA PET scan. It has a high sensitivity, not high, but 65 to 75% higher than the others, but very good specificity. Small lymph nodes still may be missed, but the negative predictive value is quite high. As there was a discussion in Dr. Basu's paper, that the positive predictive value of these lymph nodes on PSMA PET is quite low, because there can be quite a lot of non-specific lymph node uptake sometimes. And this is more with the fluoride as compared to the gallium. So in a phase 3 trial of intermediate and high-risk disease, it just showed a sensitivity of about 40% and a specificity of 95%.
and again increased in high-risk disease. So this was a paper comparing fluoride and gallium, and you can see the positive predictive value of a positive lymph node on PSMA isn't that high. It's about 40% and 66 for gallium and 25 for for the fluoride. So overall, sensitivity is not great, but the negative predictive value is pretty high. When you compare it with MRI, it's definitely has a similar specificity but higher sensitivity, and both have low positive predictive values as we saw. And it does pretty well when you compare it with a lymph node dissection. So unfortunately, the guy on the left probably didn't need any staging, but this being India, everybody walks in with a PSMA, and both of them had a single positive lymph node in the external iliac region on the PET scan. So then we move on to nomograms. Do they help us even more than the imaging? So a lot of these nomograms use age, PSA, Gleason score, the clinical T stage, percentage of cores positive, and the percentage of cores with highest Gleason grade. They vary exactly in the weightage used, and the AUCs of these nomograms to predict lymph node invasion is about 0.65 to 0.75. They help us to detect whether it's localized EPE, whether the risk of seminal vesicle invasion is there, and lymph node involvement. And MSK-CC is the one which is most commonly used, and we have a number of others which may also help us. So this is the kind of outcome that you get on the website. You can get oncologic treatment outcomes as well as disease probability. So based on this, we classified on the MSK-CC, the guy on the left has just 4% chance of lymph node involvement. The guy on the right has a 68% chance. So 4% does meet the NCCN criteria to go ahead with a lymph node dissection in that case, but not quite on the EAU guidelines. So the next nomogram which we would discuss is the Briganti, which was specific for the lymph node involvement itself. And it also uses more or less some of the similar features. There is a huge evolution in the Briganti nomogram right from 2006. And the later ones, 2019, they started involving and including the MRI as well in the use of the nomogram. So that was supposed to increase our negative predictive value up to almost 98%, that if the nomogram showed a low risk, but that was at a cutoff of lymph node of 7%, so which is higher than both the NCCN as well as the EAU guidelines. So the newest one also includes a lot of MRI findings, and it has been validated in PSMA negative patients, and the AUC of that is still about 0.77. So it's not that much better than any of the other nomograms in terms of area under the curve. So this allows us to spare about 47% of lymph node dissections while missing 3.8% positive lymph nodes in certain cases. So what are the future directions that people are moving to for detection of lymph nodes in prostate cancer? Of course, sentinel lymph node dissection is a very proven technique in penile cancer. So there was a study and a systematic review showing it had a good sensitivity and negative predictive value with ICG. But these studies are very heterogeneous. There are variable definitions and techniques, and we need further consensus to guide the studies. One RCT showed a similar N1 rate and lower lymphedema. Of course, the morbidity would be lower versus EPLND. Technetium nanocolloid has also been studied, which showed good outcomes in the Sentinel study in intermediate and high-risk prostate cancer. And intraoperative PSMA injection, I think Jiten also touched on that for positive margins, but it can also be used to detect the lymph nodes intraoperatively. Again, sensitivity as per anything with PSMA for the lymph nodes may be a little limited. So addition of the PSMA to different nomograms may also improve the area under the curve, and this has been studied in a number of papers. So that improved the AUC from 0.76 to 0.82 in one study and 0.92 in another. But another similar study showed it was practically not much better compared to the Briganti of 2019. I think yesterday, Dr. Amandeep and the Tata Group, they presented their paper in the SOGO meeting, where the primary prostate SUV, if that is very high and the PSMA does not show any lymph nodes, those still have a high risk of lymph node positivity. So those may need a lymph node dissection. So incorporation of the prostate SUV in addition may help stratify further if you add it to some of our normograms. Finally, there is one newer PSMA agent which has also been used, studied in a single study of intermediate risk patients. This is supposed to have greater affinity and may improve the sensitivity, which is otherwise not that high with the standard PSMAs. Finally, everything is moving towards AI and machine learning. So there has been a lot of studies in this to see whether that can improve our lymph node detection. So a machine learning model helped to improve the AUC to 0.89 in a single study. A systematic review of 22 studies was just published this year, which actually still shows a significant variability in the positive predictive value, and the black box nature of some algorithms highlight the need for prospective studies, improved interpretability, and the continued involvement of experienced physicians in interpreting these AI results. So they conclude actually that as of now, AI is still an adjunct, but it's not a replacement for expert clinical judgment. So with time, this may help, but as of now, it's not yet reached the position where it can give us a clear idea, yes, go and do the lymph nodes or do not. So coming back to end with both our patients, we did the lymph node dissection, and as expected, the guy on the left didn't have anything, and the guy on the right did have a single node with 13 other negatives. So the way to reduce morbidity is stage patients only who need to be staged. I think, unfortunately, we stage everybody, and sometimes we do pick up a few false positives. PSMA PET has a high negative predictive value, but questionable positive predictive value. And I'm sure the talk later will help us understand even more about the PSMA. Use your common sense. That's what most of the normograms do to determine the risk and interpret the scans. Sentinel lymph nodes and AI-based algorithms are still early in their development, but may help to improve accuracy in the future. So as of now, the lymph node dissection remains the most accurate staging technique. And when clinically indicated, we have to go ahead and do it. Thank you.
Thank you. Thank you, Vivek. Dan, go ahead.
Yes, yeah, nice talk. Just a couple questions. And I guess my question is if you have a unilateral positive, I mean, the question really is discordancy. So if you have a high Briganti nomogram with a clean PSMA, would you just not do it? Number one. Number two, if it's unilateral solitary lymph node, do you omit the other side?
I don't think there's any data on that.
Actually, there is a randomized control trial going on. Randomized control trial going on that.
Okay.
And my question actually you answered. You are doing regularly lymphadenectomy in any case.
Yes, sir.
Or you omit lymphadenectomy.
As of now, I have not omitted. In India, most of our cases are high risk.
My question is now, depending on these normograms and the study with PSMA and all, will you omit irradiating the lymph nodes or still irradiate every patient?
Mostly we're radiating.
You're asking me about radiation or surgery, sir?
No, radiation. How can they ask about surgery?
I can answer.
Radiation surgery.
Even, I mean, in short, even with a PSMA PET for high and very high, who are non-metastatic, excluded on PET, I think the sensitivity of PSMA PET is not high enough to omit radiation to the pelvis, and I would use the same argument for surgery as well. Yes, for sure.
Dr. Kibble?
Yeah. I was going to comment. One of the things I find very interesting is that the PSMA PETs are showing us lymph nodes outside of the primary landing zone, not only in the pelvis, but perirectal lymph nodes, for instance, which are profoundly altering our management of these patients. And I wondered if you could comment. I mean, early on, people would say, go after those. And I would go after them and I couldn't get them.
Yeah,
I would be like, I really tried. And it sort of shifted a lot of the treatment, I think, a little bit more to radiation therapy in those patients so we can try and hit those lymph nodes. Do you have any comments on that?
So I would say it would be case to case. If it's a very young, fit guy, you may still go ahead and try. But of course, those perirectal nodes, they report 2 mm, 3 mm lymph nodes, which you really can't get. So you probably just leave them.
But some of the series they are able to get also the retropubic lymph node in space of Regis. You also, I think 0.2%, that was Sloan Kettering series. They presented the lymph node positivity in the space of Regis. You are right. With the PSMA PET, things are changing. I think we'll thank you very much, Vivek. End of this session.
Thank you.
Yes, thank you so much. Thanks.
Thank you very much, Chairperson. I'll just summarize one sentence for each of the talks. The sharing prostate biopsy, we have got evidence to say where we should not do a biopsy, but I don't think we have got the technology yet to replace the biopsies. Dr. Daniel Lynn's talk, I thought, was exceptionally good. There were 3 learning points from that. In that, don't trust the MRI in the active surveillance. Do continue to do the biopsies because they do add value compared to just doing an MRI scan. And the second most important point was in the active surveillance, if you do have a negative biopsy, you can de-escalate in that the chance of picking up cancer again on the repeat biopsy seems to be lesser. So that is regarding the active surveillance one. Focal therapy, is it for all intermediate? No, but probably for some selective cases you can. The Jiten Jaipuria's talk, it is about decreasing the morbidity. We are doing radical radiotherapy and the prostatectomy. We have to find an equivalence between trying to use the technology to achieve cancer cure, but as well as decrease the morbidity. M1A is metastatic in that common iliac lymph node is M1A, but we should treat them with curative intent. The radiation toxicity, there have been quite a few technologies. Among the ones that are currently available in India, the MRI-based radiotherapy seems to decrease the margins around the prostate, thereby decreasing the toxicity. What I didn't find was, is the efficacy still maintained? I'm expecting that the efficacy will be maintained, but we have to wait for the efficacy numbers. The last one is the selecting patients for the lymphadenectomy. PSMA, which is the bread and butter of us, as well as the patient, does have a high negative predictive value, but also has got a problem with the positive predictive value, and we are still learning. Thank you very much. That was a brilliant beginning for the overall meeting. We are on time to the minute. Thank you.
Thank you, Dr. Sanjay, for beautifully convening the session. Thank you, chairs, Dr. Aditya, Dr. Nitin, and Dr. Ashok Hemal for chairing the session. Moving on to the next round and rotating the conveners, we have Dr. Ginil Kumar Kochi from Amrita Institute of Medical Sciences, Kochi, and Dr. Sayan Paul, Senior Consultant, Apollo Multispeciality Hospital, Kolkata. We request the chairs for this round, Dr. Narmada P. Gupta, Professor Emeritus and Padam Shri awardee by the President of India, Medanta, Gurgaon, Dr. Vineet Talwar, Director Medical Oncology, RDC IRC, Dr. Suman Malik, Senior Consultant Radiation Oncology, Narayana Hospital, Kolkata, and Dr. N. Raghavan, Senior Consultant and Uro-Oncologist, Apollo Hospital, Chennai.
Meeting time. Small on time.
We have got 5 talks, 1 debate, and a panel discussion in this session. I request the chairperson to keep the time, sir.
Good morning. May I request Dr. Adam S. Kebel to come on the dais. Dr. Kebel is the chair of urology at Mass General Brigham, the Elliot Carr Cutler Professor of Surgery at Harvard University, USA, and he's also chair of Harvard Residency Program. He received his BA, MD, and many other fellowships, and he has a leadership position in AUA quality control, NCCN prostate screening guidelines, NCI genitourinary trial steering committee, KALGB executive committee, and many other associations. Thank you very much, and please start your lecture.
Thank you very much. It's truly a privilege to be here and to begin this association between your organization and the Society of Urologic Oncology. I'd like to particularly thank Dr. Rawal, Dr. Talmar, and Dr. Singh for inviting us today. So the focus has really been on de-intensification. I'm going to be talking about intensification of therapy. And I always like to start my talks also with talking about a particular patient, 58-year-old male, presenting with a PSA initially that's normal, but then it rapidly escalates. Biopsied and found to have Gleason 9 cancer in multiple cores, including T3 disease involving the seminal vesicles. And this is the kind of patient we're increasingly seeing and struggling with. How do we manage them? Because we want to cure them, it's a young man, but how do we do that? And surgery alone is probably not enough, okay? So the real question is how are we going to manage them better? So this is data from Scott Egner, which is now about 15 years old, but I still think is germane. The dark bars, these are different grades of prostate cancer, and the dark portion of each graph indicates the percentage of the patients who die of prostate cancer. And what you can see is for patients that have Gleason 8 cancer and above, the risk of death is 1 in 3 at about 15 to 20 years, which is fairly significant for prostate cancer. And we often argue about what is the best management for these patients. Is it radiation therapy? Is it surgery? Is it multimodality therapy? We're going to give them surgery knowing that they're going to need radiation. And what I would argue is that's all about the management of local disease. And really what kills patients is metastatic cancer. And many of these patients have micrometastatic disease. PSMA PET is a huge advantage, but still we miss metastatic disease, and systemic treatment is needed to treat these patients. So, take you back to around 2000 when I was training, and many of you in the room were as well. This was the algorithm for prostate cancer management. And then in 2000, really all we had was androgen deprivation. That was really the only treatment that we had at our disposal. And then docetaxel was introduced, and all of a sudden we had a new disease state, castrate-resistant, docetaxel-resistant prostate cancer. And really, docetaxel was a huge improvement. But really what I think it did was stimulate people's interest in treating patients that had metastatic castrate-resistant prostate cancer. And there was an explosion of new treatments, okay? Even targeted treatments with PARP. And most recently, introducing novel androgen deprivation for patients who have just rising PSAs. And the question that we're asking increasingly over and over again is, can we treat these patients with systemic therapy that have locally advanced disease and cure patients that were incurable? So another way to look at this is for end-stage disease, these systemic treatments increase life expectancy about 2 to 4 months. If we treat them for metastatic disease, castrate-sensitive metastatic disease, we'll increase life expectancy by about 2 years. And can we cure patients by treating them even earlier in their disease state? Our radiation therapy colleagues are just well ahead of us, and I realize this is a multidisciplinary meeting, so I put my hat off to them about the fantastic work they've done through the years. This is the granddaddy of them all. The study was last updated in 2010, where they took patients with high-risk disease, treated them with radiation and very strong hormone therapy, and demonstrated a clear improvement in their survival. So the red line is radiation therapy alone. The blue line is radiation plus hormones. Clearly, radiation and hormones decrease the likelihood of developing metastatic disease. And more importantly, overall survival was improved in the patients that got the combination therapy. And multiple studies through the years have continued to look at whether they can tweak the hormone therapy in order to improve it, decrease the intensity, increase the intensity, and trying to come up with a better way of therapy, a better way of treating these aggressive prostate cancer patients. So this is, and they're continuing to push the envelope by using novel hormonal therapy. So this is part of the Stampede trial. We're going to focus on really the 1,700 patients that had very high-risk localized prostate cancer that got androgen deprivation and abiraterone, and some of them got a little bit of enzalutamide versus radiation therapy alone. And not surprisingly, if you had the combination therapy, you lived longer. and less likely to develop metastatic disease, and live longer. And I think what's most impressive is these Kaplan-Meier curves are continuing to spread apart beyond 10 years. So this is a durable improvement in overall survival. We actually have a study, a randomized study in urology in the surgical literature that shows something similar. This is the CLGB trial, now called the Alliance trial, PUNCH trial, in which patients were randomized to docetaxel and androgen deprivation, followed by surgery, versus straight up surgery. And importantly, they found that when they looked at overall survival, there was an improvement in overall survival with the patients who got the combination therapy prior to surgery living longer. Okay, roughly halving the risk of dying of prostate cancer. Unfortunately, the primary endpoint in this trial was biochemical-free survival, and it did not reach its primary endpoint. Now, purists out there say primary endpoint wasn't statistically significant, therefore we're not going to use it. I think the real issue is this was very toxic therapy. 25% of them roughly had grade 3 toxicity and 19% had grade 4 toxicity. So you're taking patients who feel good, they're having surgery, they really have no problems, and you're exposing them to a very highly toxic treatment. And a lot of patients balk at it. So over the past roughly decade, maybe even a longer, 20 years, we've done a series of trials, multi-institutional trials, including University of Washington, where we've tried to intensify the use of neoadjuvant therapy using hormonal therapy as opposed to chemotherapy. This is basically the algorithm, and Mary Ellen Taplin, who's really been the brains behind most of these trials, is pictured up in the top right-hand corner, took in patients with very high-risk disease, treated them with either very intense androgen deprivation or even more intense androgen deprivation, did some correlative science, then did a radical prostatectomy. Now, those of you in the room, again, like me, that have a little more gray hair, say we tried this before around the 1990s and it didn't work. And what I like to point out is these were not patients with high-risk disease. These were patients with low-risk disease. The duration of treatment was not very long, and the agents that we used were not very good. So this is the first trial that was done, a pretty primitive trial, basically using LHRH and then adding increasing intensity of therapy, bicalutamide, dutasteride combination, and then finally ketoconazole, treated them only for 3 months, and then did a radical prostatectomy. It's even hard, I put this slide up here, but it's even hard to demonstrate that these patients had high-risk disease, okay? And there aren't very many patients in each arm, only about 10. And while it was a randomized trial, it clearly isn't distributed very evenly. So it's hard to really understand who we were treating. What we did find is that the androgens were significantly decreased in the tumor with the more intense therapy, with the patients who got ketoconazole, compared to the patients who got less intense therapy. And we saw that in the less intense arm, really nobody had a complete response. But in the patients that had the more intense therapy, the therapy with ketoconazole, about 10% of them had a pathologic complete response. This is the last trial we did. I'm not going to go through all of them. And you can see, same basic idea, taking patients with high-risk disease, but now we're treating patients with leuprolide, abiraterone, and apalutamide versus abiraterone and leuprolide, doing a radical prostatectomy, and then treating them for an additional 6 months, so 12 months of treatment. It is unambiguous that these patients have high-risk disease. Just to focus on the NCCN risk stratification, 95% of them were defined as having high-risk prostate cancer. And what did we find? The complete response rate was pretty much the same, around 10%. But now, if you include the number of patients that have minimal residual disease, less than 5 millimeters of cancer, now we're up around 20%. So if we look at all the 5 studies, the important thing to take home from this is as we move through time from the first study through to the 5th, an increased intensity of therapy, moving from simply using leuprolide along with a dutasteride to now, it's a little cut off at the bottom, but apalutamide, abiraterone, and LH. And we're increasing the duration of treatment. Now we're treating up to 12 months. And when you look at this, you can see that as you move from left to right, from the least intense therapy to the most intense, the complete response rate stays pretty much the same, but the minimal residual disease rate actually increases as we increase the intensity of therapy. Now, those of you in the room are like, well, don't we want to cure patients? Isn't that what I started at the beginning? We already know how to eradicate the cancer in the prostate. We either give them radiation or we remove the prostate. And so we want to cure some of these patients, correct? So along again with colleagues at the Dana-Farber and the BI Deaconess Medical Center, we pooled about 200 patients who were treated in these 5 trials, and we were looking at time to biochemical recurrence, time to metastatic disease, and looked if that minimal residual disease actually had any impact. 5-year follow-up, a high percentage of these patients developed metastatic disease, 20% reflecting how aggressive the cancer was, and roughly 5% of them actually died within that 5-year period. But the metastasis-free survival overall was pretty good, around 80%, and an overall survival around 98%. In the patients that had no cancer, none of them had developed metastatic disease. Patients that had increasingly large tumor burdens remaining, more and more likely to have a recurrence. So to look at it from a Kaplan-Meier perspective, you can see the patients that had a better response in the tumor appeared to do better from whether they developed metastatic disease or not. A similar study, but this time matching about 212 patients in these 5 trials with patients that we operated on who had identical pathology preoperatively to see whether there was a difference. And what we found is it roughly, and again, this is a non-randomized trial, but the hazard ratio is 25.25. Pretty impressive improvement in both biochemical-free survival and metastasis-free survival. And these are the Kaplan-Meier curve, again, demonstrating a very dramatic difference and improvement in the patients who got the neoadjuvant therapy. So what I've shown here is longer ADT correlates with better pathologic response. More intense ADT correlates with better pathologic response. I didn't show this, but lower tumor antigens in the tumor actually correlate with better response, and that also better pathologic response then correlates with a lower recurrence rate, and that the treated patients did better than matched controls. And what this phase 2 data led us to design is a phase 3 trial called Proteus, which is totally completed now. We're just in the analysis phase. I'm one of the PIs along with Mary Ellen Taplin. I have no idea what the results are at all, but my hope is that we're going to be presenting within the next year, completely accrued. And what the study was apalutamide plus ADT versus ADT alone for 6 months in patients that had a high-risk disease. You had to have Gleason 8 or above, and then radical prostatectomy and an additional 6 months of treatment. So this is my concluding slide. Intensification of therapy earlier in disease improves survival. High-risk patients undergoing radiation therapy. Our radiation therapy colleagues have proven that, okay? Men with biochemical failures appear to do better with earlier treatment, and men with castrate-sensitive prostate cancer. And therefore, these earlier and earlier treatments of the disease, it behooves us to now, the next logical step is to show that perioperative systemic therapy can do the same thing. So in the future, I think we're going to treat the localized tumor. Some of these patients are going to be cured. Some are going to have occult local disease. Some are going to have occult systemic disease. And we're going to have to treat those additional sites of disease as they happen. Thank you very much.
Thank you, Dr. Kebel. Anyone like to make any comments?
The difference between the RPM trial and for this trial is the methodology and the study pattern.
Say it again, which was the first one?
In Belgium, there's a study on.
Yes, I think I read that trial. I think that trial used darolutamide, am I correct? Apalutamide. Are we talking about the radiation therapy trial? I'm sorry. It was phase 2, that's right.
We have a progressive experience of using neoadjuvant therapy in our setting as well.
Yeah.
And, but it is a non-randomized fashion because it's just an exploratory projects. So the couple of observations which I made in the patients we had, and of course, Raghunath also has a body of experience there. What we observe in our patients is that abiraterone works much better when we see the BCRs compared to any of the enzalutamide or apalutamide. So, and is that something you have observed as well? That's question 1. And question 2 was, how many of the patients had adjuvant, as in what we call peri-adjuvant therapy rather than neoadjuvant alone?
I'm not sure. I'm going to answer the first question first, and I'm going to come back to the second one.
Okay.
So I kind of agree with you. And I think the more intense therapy we gave always had abiraterone in it and appeared to be a little more effective. I thought the P0 rate anecdotally in my hands, because I don't know the actual results, but I've done probably 300 radical prostatectomies in all these different trials, and have found that I think the abiraterone patients are more likely to have P0 states or minimal residual disease. But you're behooving to the companies and what drug. And also, I was involved in a very complicated trial in which we're using docetaxel and androgen. It got too complicated, and the FDA wanted us to do abiraterone, and apalutamide, and then regular leuprolide, and it was just too complex, and it wasn't going to happen. In the end, we wouldn't find anything out. I'm not sure I understand your second question. Can you repeat?
The concept was neoadjuvant therapy, where you give therapy and then do a definitive therapy to the prostate. But Proteus has come with a peri-adjuvant, and most of us, at least me and Raghunath, are doing peri-adjuvant for the last 5 to 7 years, where we give therapy before surgery and then therapy after for 6 months to 12 months.
Yeah.
So this is peri-adjuvant. In Ravi's paper, was it peri-adjuvant or neoadjuvant? Because my understanding was it's a neoadjuvant rather than peri-adjuvant.
It was neoadjuvant. It wasn't any treatment
When did the
afterwards.
concept change to peri-adjuvant? Because Proteus is a peri-adjuvant.
No, I agree with that. And when we tried to do adjuvant trials, we found that it didn't work because the patients either had an undetectable PSA or not. One of the earlier phase 2 trials we did, we had to see if men in the United States would be willing to be treated after the surgery because they hate the hormonal therapy. And we found that they did. And that's what allowed us to, in Proteus, incorporate it afterwards, trying to just increase the duration of treatment. So I agree with you.
Can I just ask, 3 months versus 6 months in the neoadjuvant part?
Yeah.
How did you come? Because majority of them, even the Arneo that Ginil was mentioning, had only 3 months, and the MRD and the PAT-CR rates were similar to. I know your paper from the 2014, wherein you say that 3 months compared to 6 months, there is a better overall pathological CR rates. But in your study, you have gone for 6 months and then 6 months.
So, I mean, I think what happened is this is just, living the dream of running a series of trials. We wanted to intensify the therapy. As we pushed beyond 6 months, we found the patients weren't really willing to accept it. Also, as a surgeon, I trained in the era where people were playing with this in a 3-month period, and I found the radical prostatectomy was a lot harder, particularly the nerve sparing. And when you get around 6 months, the prostate sort of stabilizes, and I actually find that the nerve sparing, et cetera, is sort of back to its sort of baseline. So I think from both the surgical perspective and the ability of the patient to tolerate the intensity of the therapy, 6 months is sort of the sweet spot. And then extending it afterwards allows you to continue the androgen deprivation for a longer period of time.
I'd like to ask you, is it still in the trial phase, or it has become a standard of practice?
No, it has not become a standard of practice. So I'm at a center where we really believe in this, but we only do it in trial settings. Our latest one is one where we're using precision medicine to help guide which therapies they get. So adding a PARP or adding an immunotherapy agent, depending on what sort of mutations exist. Our hope is that it will become the standard of care, but all of us have seen treatments that appear to be wonderful, and then when you actually study in a randomized setting, it proves not to be any better than the standard of care. So I would caution people to do this until we prove it.
Yeah, Vedant.
This is slightly philosophical. In the ever persistent debate about surgery versus radiotherapy, ADT in high risk, one thing I could never counter against radiation was you need ADT. And that is a problem that my colleagues, surgeons, patients, they care about, that you need ADT with radiation to get the results. Now you're adding the same ADT to all the patients.
Right.
And continuing it for a year later, and that is going to suppress the testosterone for another year. So how does this fit in with the entire philosophy?
So I agree. I mean, more patients, I end up operating on an awful lot of patients, not because they fear the radiation, because they fear the ADT. And now I've gone ahead and staked my career on giving them exactly the agent that they're all trying to avoid. But I would say these are patients that are really, these are not patients that have, Gleason 6, Gleason 7 cancer. These are patients who die of their cancer. And I think that intensification of therapy and when we save their lives is actually the bottom line. And I think early intensification of therapy may save them longer term androgen deprivation. So in Steve Freeland's trial where the patients got enzalutamide and LHRH or LHRH alone, in a disease state where they have a rising PSA. I think one of the things that's lost in that trial is the patients that got the more intense therapy, when they stopped it, had a longer drug holiday before it was restarted again. So hitting it hard early may decrease the total amount of time the patient needs to get androgen deprivation over their lifetime.
See, you have added this neoadjuvant and peri-adjuvant therapy, but the debate of the radiation versus surgery is still going on.
I know.
Go on forever.
Yeah.
It never stops. Only last question for me is, do you notice a difference between LHRS agonist versus LHRS antagonist?
So we haven't done the study where we've gone ahead and given it. I mean, there's some clear advantages to the well, I always have trouble thinking of the agonist. I get that right? No, the antagonist. The antagonist. I mean, mostly it's a pill that they can stop and start very quickly, so the patients love it. That the hot flashes and everything get better much more rapidly. I can't imagine that there'll be a huge difference in terms of using it in the perioperative period. But my guess, if this study is positive, that'll be one of the next studies that's going to be done.
Thank you, sir.
Yeah.
Thank you.
In the inclusion, sorry, just one question. In the inclusion criteria, do you have only Gleason 9 or Gleason 8 also? And what about the lymph nodes? N0 disease, N1 disease? In the inclusion criteria for your neoadjuvant chemotherapy, neoadjuvant hormonal therapy patients, do you have only Gleason 9 patients or Gleason 8 patients also? And do you have N1 disease only, or do you have 9 with N0 disease?
So
I just want a
right.
little more elaboration on the inclusion criteria.
So it was Gleason 8 and above, and it had to be higher volume disease. So you had to have multiple cores, I believe 3 cores or more, all more than 50%. Because what we didn't want to treat is the patient who got an MRI, they targeted the biopsy, and at 10% of a single core showed Gleason 4+4. We did include patients that had positive lymph nodes. In our phase 2 trial, the lymph node patients did not appear to respond as well as the patients that had presumably localized disease, but we felt it was important to include those patients as well. And in the randomized trial, I think it's about 10% of the patients have positive lymph nodes. Does that answer your question?
Yes, yes.
Yeah.
Thank you.
Thank you, Dr. Kibel.
For a small announcement, high tea is running in the refreshment area. Alongside the ongoing event, you can enjoy the high tea parallelly. Thank you. Continue to you, sir.
So we go on to the next lecture. This is balancing early treatment intensification with treatment-related toxicity, doublets, triplets, and quadruplets in metastatic hormone-sensitive prostate cancer. And may I request Dr. Atul Batra, who is Professor, Department of Medical Oncology at the All India Institute of Medical Sciences. Over to you, Dr. Batra.
Thank you, Dr. Vineet, for calling me here. It's a tough task in 15 minutes, talking about balancing the early treatment intensification with treatment-related toxicity. But philosophically, it's more or less similar what we were talking about. And now we have started talking about in even the non-metastatic settings. Now we have started thinking about neoadjuvant things, neoadjuvant abiraterone, enzalutamide, apalutamide, and then even considering docetaxel. It's a little bit easier for the castrate-sensitive space because we have a little more data to support some of the trials. So over the years, we have seen that a lot of agents have come up in the space of prostate cancer, and all the agents that were initially studied in the castrate-resistant space have now come and occupied the castrate-sensitive space. So it's become a clustered space with a lot of targeted therapy, a lot of immunotherapy, and everything coming up right in sensitive space. And this is how it has progressed, that after almost 70 years where ADT remained as the standard of care, we started moving to docetaxel, then ARPIs, and now we are talking about, for the last 3 years, a triplet therapy. And off late, we're also talking about quadruplet therapy, somewhere similar to myeloma. So where there is no debate, let's start there, that's doublet therapy. So all of us agree that ADT alone in 2025 is not the standard of care for a patient with metastatic hormone-sensitive prostate cancer, unless in very, very unusual circumstances where the life expectancy is low and it's just, ADT is the only feasible therapy. We have numerous trials for all ARPIs. And if you look at the hazard ratios, they're almost similar, ranging from 0.61 to 0.65. Aeronaut is a latest edition, and we don't have the OS data that's matured enough to say that it's somewhat similar, but overall they appear that it's more or less similar. And the decision is mostly based on the side effect profile of the agent rather than the efficacy. The efficacy more or less appears to be similar. The trials where Docet-XL charted trial was the first amongst all these, where we learned a few lessons with Docet-XL. What we learned was that was mostly the high-risk disease that was benefiting, and later on the longer-term survival, we learned that low volume and metachronous disease was probably the subset that was not benefiting. But with the trials coming up with doublet of ARPIs, probably ADT plus Docet-XL lost its kind of place in the first place. But before we could settle that debate, we got two other trials. That was PEACE-1 and then ERASENS, both in the year 22. PEACE-1 was reported first. So PEACE-1 was a little different trial. I mean, it had two questions first. It was whether addition of ebiratron over the standard of care adds to in metastatic castrate sensitive space. And the other question was whether RT additions adds to the survival or not. Now, midway, Docet-XL became the standard of care, and hence there was an amendment that Docet-XL was allowed with the SOC. The earlier SOC was ADT alone. So practically we had four arms: SOC, which was ADT alone; SOC, which was ADT plus Docet-XL; SOC plus ebiratron, again two types: ADT plus ebiratron and ADT plus ebiratron plus Docet-XL. But they made changes in the sample size calculations to make sure their analysis was powered enough to answer this question whether triplet is beneficial or not. A more cleaner trial was ERASENS trial, because it simply asked whether addition of darolutamide over and above ADT plus Docet-XL improves the survival or not, and the primary endpoint was overall survival. So a little cleaner trial, ERASENS, but both more or less had one common question: whether triplet compared to ADT plus Docet-XL. Now, this is the most important part here. The comparison is with ADT and Docet-XL and not with ADT and ARPI. What does it do? Enzamet, I don't consider it as a pure trial, but because again, only 45% had this triplet thing, so let's not focus on this. But if you look at the results of ERASENS and PEACE-1, there were certain differences in the trial inclusion criteria that ERASENS actually allowed metachronous and PEACE-1 did not. But overall, they showed that overall survival improved with the addition of the third agent. Both the trials showed with a hazard ratio of 0.68 here and 0.75 there. So this now showed that a triplet improves the overall survival. Now, this is a hardcore outcome. There's no debate that it improves the overall survival and radiographic progression-free survival. But the question remains, this was never compared to addition of Docet-XL to an ARPI. Understand? This is placebo plus ARPI plus ADT was never a control. It was always Docet-XL. So we don't know whether a triplet, how does it fare as compared to ADT plus an ARPI. We know across doublet comparisons, although they are indirect comparisons, there's no direct comparison of a doublet with Docet-XL with a doublet of ARPI, which one fares better. But we have done a lot of meta-analysis, network meta-analysis. The hazard ratios are better. The benefit of Docet-XL kind of wanes later on. And ADT plus an ARPI benefits all risk disease and all volume disease. So this question remains uncertain. And now, do all patients merit triplet became the question because of the toxicity, as we discussed in the last presentation as well, that Docet-XL has toxicities. Almost a fourth of patient will develop grade 3 toxicity. So is there a subset of patient that benefits from the triplet? So we did a subgroup analysis. They did a subgroup analysis to compare high volume versus low volume. High volume clearly shows a difference in the graphs, whereas low volume, of course, the events would occur later, and this is a subgroup analysis, mind you. So the number of events have not occurred in that subgroup, but it does appear that maybe it is somewhat similar to charted, that the benefit of Docet-XL or triplet therapy here is more or less limited to high volume days, suggests, right? Then we look at the low risk, high risk thing based on the latitude definition, but it appears that risk-wise, we are not able to differentiate much. we try to look at de novo versus recurrent metastatic or the metachronous disease. The numbers were less, and therefore the confidence interval actually crossed 1, but again, not very clear whether this benefits or not. So overall, where are we? That if we look at high volume disease, the options for a treatment are a doublet with a ADT plus ARPI, or a triplet with an ARPI and a docetaxel. And if it's a synchronous disease, it would be considered for fit patients. But if it's a metachronous patient, then again, we need to discuss. It was only the ERASENS trial, 14% patients, and the benefit may be limited. Still, we don't know exactly. But for a low volume patient, it does appear that probably ADT plus ARPI remains the standard of care only for few younger patients, or I mean, these volume is very kind of weird sometimes that you have a whole of X's involved and we still call it low volume. And if you have just 2 vertebra and 1 femur involved, you still call it high volume. So it's sometimes a little weird to classify those patients just based on distribution. We need better ways to classify our patients. Can we do better? Now, this was just based on volume risk. We being medical oncologists, we try getting NGS into everything and then see what we can do molecularly. And this is what was seen with a large comprehensive genomic profiling, that we saw a lot of patients, a proportion of patients who had such mutations which could be targeted with the available drugs. Like BRCA2 was there, PTEN was there. We had drugs which are already there. And then we also started seeing from certain data that comes from UTA, and that showed that the SPOP mutation, patients who had this mutation, they tend to do extremely well with a doublet ARPI as compared to a docetaxel. So there was no benefit in patients who had this SPOP mutation as compared to those who had this mutation. But again, this is retrospective data, and this was done on a larger database in the US, and it showed a very remarkable result, but there's no prospective validation here. Likewise, if the patients carry TP53, PTEN, RB1, we've started calling them triple negative. If they have these mutations, these tend to do extremely worse. And probably these are the patients where docetaxel benefit can be observed. Again, these are retrospective data. These are not prospectively validated. So these are suggestions that these may help. Right now, not into clinics. Some people do use it, but we need to be aware that there's no prospective validation. Now, what about our old biomarker, what is PSA? Can we do something with the kinetics? So it is seen that patients who have the old 7 months less than 0.2, they tend to do extremely well as compared to those who have a higher PSA level after the induction therapy, around 7 months mark. So we see that across the trials. So can we do something? Can we de-escalate or escalate based on this? We have a presentation after this by Vinayak. We'll be talking about de-escalation. So there are ongoing trials in patients who have PSA less than 0.2 after 6 to 12 months, whether we can do an intermittent ADT here. We are coming back to what was done earlier and was negative, but was done unselected. Now we are doing in a selected cohort who do well with the initial therapy. Likewise, for apalutamide, we have such trials, and vice versa. Can we just start with ADT plus ARPI, look at their PSA, if it stays above 0.2, can we add docetaxel later on? Can we select our patient based on what their PSA kinetics are based on the initial therapy? So there's a lot of escalation and de-escalation trials going on in this space, and with time only we'll be able to kind of refine what is right. Apart from this, we have a lot of trials where targeted therapies are being brought up in the metastatic castrate sensitive space. For Capitello 281, we have a press release. The abstract is yet to be read. It was a positive trial as per the press release, where adding capivasertib with abiraterone and ADT did improve the primary outcome. Again, Amplitude was presented last month at ASCO, where addition of niraparib in patients who had HRR mutations did show improvement in radiological progression-free survival. Likewise, there are trials where they're trying to add talazoparib or PSMA-based therapies based on that. So this space, again, will have to kind of personalized therapy is going to be the answer here. We look at their markers, biomarkers, we look at the mutation, we de-escalate or escalate based on the PSA kinetics. And of the latest addition is the quadruplet. There was a phase 2 Cascara trial that was presented in 2 years back in the ASCO. So this was a small trial, but an interesting one, where there were only just 61 patients, but importantly, around 40% of patients had TP53 mutation. These patients tend to do bad, and these patients were treated with ADT plus cabazitaxel, carboplatin, abiraterone, highly toxic, But we saw that at 7 months, almost 61% of the patients had a PSA of less than 0.2. If this is compared, shouldn't do cross-trial comparison, but still if we do, this was 45% in the charted experimental arm. So we're seeing some signals, but I think this is a little far off. Another part of the amplitude trial, so here also patients were allowed to have 6 cycles of docetaxel earlier, so they could receive a triplet and then again go on a different triplet. So practically they're also receiving 4 therapies here with ADT, docetaxel, abiraterone and niraparib. Around 20% of patients did receive this quadruplet, and this was a positive trial. The full paper is yet to be published, but this was just presented last year. A lot of interesting things going on with HRR, and this is one thing that I feel that these PARP inhibitors would take the space in the sensitive end. So this is what the future of treatment looks like for metastatic HSPC, but we'll have to do a molecular profiling of such patients. If they have something called SPOP mutation, they may do very well with just ADT plus ARPI. If they have HRR mutation, they get a PARP inhibitor. If they have the worst of the lot, then probably a quadruplet therapy here with cabazitaxel carboplatin. And then if they have PTEN loss, then we add capivasertib, PSMA-based therapy, immunotherapy. So it's going to be a lot more complicated, but a lot more personalized based on what kind of a disease the patient has. And this is what we learned over the last 3 decades in breast cancer as well. It used to be treated as one disease, and now it is treated practically as 3 separate diseases at the very least in the clinics. So with this, I think I'll conclude. In today's world, there's no role of ADT alone, except in a very, very exceptional case. Doublet at least would be the treatment for most patients. We need to choose which patients would merit benefit of a triplet therapy. For now, I think high volume disease is one subgroup that benefits. And then if we can do the molecular profiling, those who have P53, PTEN and RB53, RB loss, then these are the patients who can benefit from a triplet. But we need more biomarkers and we need to personalize this treatment for patients with metastatic hormone-sensitive prostate cancer. Thank you so much for your kind attention, and I'm happy to take any questions.
Thank you, Dr. Atul, for such a nice presentation. The obvious question comes in the hormone-sensitive setting when you give 3 drugs together and the patient progresses, what next?
That's, I think, but that is a place. But this patient, if we did a doublet, probably also would have progressed much earlier. So I think with that thing in mind, so this patient would have done even worse if we had treated him with just an ADT plus ARPI. So what we are seeing is an improved version. Cabazitaxel we would do an HRR. If that's positive, then we treat with PARP inhibitor. But if HRR is negative, then probably cabazitaxel would be one choice of drug.
Correct. So basic accent is the more you can stretch the hormone sensitive period, the better it is for the patient, whether you give
Earlier we bring in all the therapies. I think the patients are younger, they're able to
and you get a higher overall survival. Thank you. Any questions?
I have one question. I presume medical oncologists fascinate about NGS. I'm sure you've done thousands of them as well, at least hundreds of them. How many of these mutations are you finding? What is published in the Western literature? These are what you observe here in India.
We'll tell you about India. So we just published last month in JCO Precision Oncology that we have very similar mutation profiles. Around 11% of our patients with metastatic hormone-sensitive prostate cancer have germline mutations. Of this, BRCA2 is most common, followed by ATM, then CHEK2. And if you look at HRR, we did a study together, pan-India. Dr. Vineet Talwar was actually initiated that study, and we were also part of that study. Around 24% of our patients have HRR somatic mutations. So 11% you get germline, and over and above, 13% would be somatic. Around 13-14%. Now, when we talk about PTEN, we also participated in Capitello 281. That's just in around 10%. Right? And P53 we see very commonly, especially in patients who are doing bad. So we tend to do mutation profile a little later on, but I think it should be moved into the first line. We don't have data for that. It would eventually come into first line. When do we do this mutation profile? Germline, you do it upfront when the patient is castrate sensitive because it has other implications on the family. It has no treatment implications as of now, but amplitude, if it gets approval and we have TALAPRO-3 that's coming up, we will have implications of doing an HRR testing upfront, somatic as well as germline, right? For now, we do some somatic testing later on, but there are problems of doing somatic testing later on. You do it after 10 years of initial biopsy, your block is really in a bad shape. The DNA just gets fragmented, and it's better to do it upfront, even if you're not going to take a decision based on that. So I would say around 30 to 40% will get some kind of mutation in your the tissue, and around 12% of patients in the germline.
Thank you. Thank you so much. Thank you, Dr. Atul. So our next speaker is Dr. Vinayak Maka, Senior Professor, Ramaya Medical College, Bengaluru. And he will discuss one important aspect of de-intensifying hormonal therapy in metastatic hormone-sensitive prostate cancer after deep PSA response. Over to Dr. Vinayak.
Thank you, sir. And thanks, Sogocon, for giving me opportunity. Very unusual topic. This topic was very enlightening for me to do practice also. So I think few of the slides my friend Atul has covered, so it's primed at least for the talk. So why it's relevant for clinical practice? Let's seeing the reasons. This space, metastatic hormone sensitive prostate cancer, is one subset from last at least half a decade. We're seeing only intensification happening. We started with ADT, which was there. Then we said not enough. We added docetaxel. We added novel androgen blockers. Then triplet. Then almost going for quadruplet. So is there a subset of patients who would not require such a escalation is the question. These are the evolution of the all approvals for last half a decade. Very interesting space, but its price has grown a lot. And I think our practice has seen patients of lot of patients are receiving all the treatments, at least triplet for most of the patients, and patients who are not fit, at least doublet, which is androgen blockers. We use it. Why we do it? Simple reason. You can see that incremental survival increase, like from starting from ADT alone, now to P study is almost 61 months. So there is incremental life expectancy survival is which we see with patients who are hormone sensitive prostate cancer. But they don't come without any caveat. They come with adverse effects. Lot of our patients, we assume chemotherapy is more toxic, but trust me, the androgen suppression with bitopertin and enzalutamide, it brings its own set of caveats of problems which are unique, which require more of physician than actually of we are more comfortable with chemotherapy than with this drugs, which is because it continues for longer time. And if we're saying 61 months of survival, we're giving 61 months of the novel agent. So there is a school of thought that we need to be de-intensified. So there are a lot of biomarkers which can help us. A few of the biomarkers Dr. Atul has covered, but first, at least few of the markers are not real prime time practice, like preterm mutation. There are drugs which are targeting them and they are coming into the practice. P53 mutation, pathway like RB pathway alterations, AR pathways. Like example, if I have androgen receptor mutation amplification, the stop may be detrimental. So we need to know which whom we should not de-intensify. And the one biomarker or clinical biochemical marker is PSA nadir less than 0.2. Yes. This has been studied. It is not a new marker. This having PSA less than 0.2 is studied long back in the oncology group trials, where they had taken three categories less than 0.2, 0.2 to 4, and 4, and they found that there was intermediate versus continuous thing. There was the survivors were not non-inferior. They could given a break. But this topic has come again into the question because of the study presented by Ironman's registry data in the ASCO GU last 2025. So where they looked as PSA nadir less than 0.2 as a key early prognostic marker where we can de-intensify treatment. So this study had all the arms. One of the caveat is triplet therapy was not included for various reasons, but it had ADT alone, ADT plus androgen receptor inhibitor plus chemotherapy. So what they found is if they defined PSA less than 0.2 nanogram per ml, all the patients had at least, if you have ADT or ADT plus chemotherapy, at least 28% of patients were able to achieve PSA nadir. Whereas if you use androgen receptor inhibitors, it was almost half of them would receive the achieve the nadir. And given a time of another 1 year, another 10% of patients would achieve the PSA nadir. So based on that parameter, what they found is the relapse rates in this subset of patients who achieve PSA nadir within 6 months had a best outcomes irrespective of treatment outcomes, whether you're given ADT plus androgen receptor inhibitor or even chemotherapy. So this data was very discussed in the GEO update where they're thinking to de-intensify. And I think there are few more studies where they look closely the PSA nadir and their outcomes. Charted study and all the newer triplet therapy, they have found to be very significant biomarker to predict to de-intensify the patients who would taking the hormone therapy. So what can we de-intensify? There are no studies, as we're speaking today, where there is no studies where they have studied in a randomized fashion of de-intensification. But the thought is, can you de-intensify only ADT? Can you just like our enzalutamide study in non-metastatic disease, where there is a persistent rise of PSA, can you de-escalate only ADT, or you de-escalate by removing ARPI, or remove both? So merits of it is lesser side effects and financial cost. This will be the gauging for the de-incentivication. So what is planned in patients who are good responders is having intermediate therapy or having treatment breaks. There are two studies which have been highlighted by previous speaker. So one is de-escalate study where they de-escalated patients who achieve nadir. The time frame was from 6 months to 12 months. So where they're looking at overall survival as the endpoint. So they're looking into continuous treatment or intermittent. Another study is Libertas study where they have looked into having at 6 months a hard stop. If you achieve an nadir at 6 months, we are offering them intermittent versus continuous. This is both are randomized studies. These are two studies which will help us to de-intensify the regimes based upon the PSA nadir. So the other side of the coin, if you are de-escalating, can you escalate for the patients who do not achieve PSA nadir by 0.2? Yes, there are two studies, which is not my mandate to talk, but there are two studies, which is one SWOG Canadian study where they have added docetaxel to the patients who do not respond and started with ADT plus ARPI, but who do not achieve a nadir, they were escalated with chemotherapy. Peace 16 study where they have done in the patients who poor responders, they have given lutetium therapy. This has two studies which will help us to escalate and de-escalate, and achieving a PSA nadir will be one of the very good endpoint we will not going to look in our practice, where patients we want to go to early remissions, we can de-incentify. But as of now, data is not very reassuring to de-escalate. This is my last slide. Thank you. Any questions?
So we can have few questions from audience. So in your current practice, do you de-escalate?
No, sir. No, sir. Actually, we look closely the PSA nadir achievement, but I think the data is not there to de-intensify as of now. There are initial studies before the era of our novel agents or chemotherapy where there were mixed results. So I think this data is yet to come, but I think I'll take the house call.
So in my practice, I am already practicing this de-escalation, those who have got 0.2 after any kind of treatment. And then I keep them on surveillance, regularly follow up with 3-month PSA. And if it is going up, then we can again start. So this intermittent androgen blockade therapy in our radical prostatectomy, post-radical prostatectomy patient, I'm following last 10 years actually. And I was always debating in my mind whether I'm doing right or wrong, but I'm happy to see now studies are coming.
I think that.
So this is especially in a country like India.
Can I make a comment?
I just wanted to talk about the duration of response also. Supposing the patient had minimal metastatic disease and has been responding well and has remained at a very low level for 5 years plus, then that is also time when we can safely
either shift the patient to active surveillance and stop the ADT.
Yes, sir. So the
Apart from
arms have not been
Apart from
randomized.
the initial response, the duration of response and the persistence of response is also perhaps important.
So one thing I believe is important for de-intensification is the duration of ADT that has been given. So we note that for LHRH agonists, if they are given for periods more than 9 months, like for years or 2 years, the patient, despite discontinuation of the androgen deprivation, may never recover his testosterone levels. So in such patients, an important metric is the eugonadal biochemical recurrence-free survival. So in patients who you start de-intensifying, you start doing their PSA and testosterone
Yes.
at 3 monthly intervals. And we have started de-intensifying a lot of our patients. And we find that those who are on LHRH agonists, as studies show, do not recover their testosterone as early as those who are on either degarelix or relugolix for that matter.
So they indicate they're very sensitive to the hormone manipulation. They would be much more definitely call for a de-intensification of them.
Exactly.
Thank you.
Thank you so much.
Thank you.
Yeah.
So the next will be a debate. So we are going to invite our speaker Rajiv Saini, who's a medical oncologist at Jammu. The debate is there is no role of radiation in oligoprogressive or oligorecurrent prostate cancer. So let's get Dr. Rajiv Saini on the stage.
Good morning, sir. Today it is homecoming for me today. Standing at RGCI here, where I worked as trainee 8 years ago, is feeling nostalgic. To be invited back, not as a student, but as a speaker, is both humbling and deeply meaningful. I want to express my gratitude to my guide, my mentor, Dr. Vineet Talwar, and organizers of Sogocon for giving me the opportunity to be here. So today my role is to speak in favor of the debate, no role of radiotherapy in oligoprogressive, oligorecurrent prostate cancer. So before starting on the debate, I want to highlight few points. So what are these oligometastatic diseases? Because as we are using more and more hormonal therapy and targeted therapy, we are coming across these subset of metastatic disease. Oligometastatic prostate cancer is defined clinically by lesion enumeration, typically between 3 to 5 lesions depending upon the trial. So among these oligometastatic prostate cancer, there are various subgroups. One is de novo or synchronous oligometastatic disease, where oligometastasis present at initial diagnosis. Then second is oligorecurrent, that is metachronous disease arising after definitive therapy to prostate cancer. And third subset is oligoprogressive disease, where isolated lesion progress in a background of otherwise stable disease controlled by systemic therapy. So the first two subsets, they usually are hormone sensitive prostate cancer, and the oligoprogressive disease is usually castration resistant prostate cancer. So what are the current standard of treatment at present? For low volume metachronous metastasis, ADT with one of the following preferred regime, that is abiraterone, apalutamide, and enzalutamide. So this is in low volume metachronous, that is oligorecurrent disease. And what about oligoprogressive disease? So these are the various trials which already being discussed by Dr. Batra, which have shown that doublet is preferred over ADT alone. And this trial, except charter trial, most of the trial has shown OS benefit in low burden disease also. So regarding oligoprogressive disease, presently we have to change the therapy, systemic therapy once disease progress. What is the preferred treatment? If no docetaxel or novel hormone therapy was used, we can use abiraterone, docetaxel, enzalutamide. But if we have used any of these agents, we can use other agents which are not used. In addition, if we have this mutations, molecular study, like we have mutation, BRCA mutation, HR mutation, we can use the targeted therapy also. So the median OS, overall survival in hormone sensitive prostate cancer, typically low burden disease is around as high as 90 months, while in the castration resistant prostate cancer for low volume disease, it is as good as around 50 months. So if we have such a good overall survival, why there is need to debate? So the reason is because we have desire to achieve more and do differently. Moreover, we have encouraging data from lung, breast, and renal cancer, where the treatment of oligometastatic disease with SBRT has improved PFS as well as overall survival. And we do have some small retrospective and single arm data from prostate cancer regarding this SBRT. So we'll now go through the what are the evidences supporting this SBRT? Can we rely on these evidences or not? So we know the definition of oligorecurrent prostate cancer, usually less than equal to 3 new metastases appear after successful primary treatment, typically present as a biochemical recurrence that is rising PSA, which on imaging confirm as limited metastatic disease. So we have key phase 2 randomized trial, STORM trial, where 62 patients with less than 3 equal to extracranial metastasis after primary prostate treatment were randomized to metastasis directed therapy versus surveillance. So here the primary endpoint was to delay starting ADT, time of androgen deprivation therapy. And what are the results? Here median ADT free survival was longer in the MDT arm, 21 months compared to surveillance, which is only 13 months. And there is no grade 2 or higher adverse events were observed in the MDT arm. So this study shows that we can delay use of systemic therapy with MDT with very low toxicity. Another trial is Oriole trial, where 54 men with hormone-sensitive prostate cancer and less than equal to 3 metastases randomized to again SBRT versus observation. And the primary endpoint was disease progression at 6 months. So what are the results? Progression at 6 months was significantly lower in the MDT arm, that is 19% versus 61% in observation with very low toxicity. So this study also shows that disease control benefit with excellent safety. And third is Saber Comet trial. This is basically a trial where multiple histologists were included and only 16 out of 99 patients had prostate cancer. This shows benefit of MDT and overall survival for oligometastatic cancer, but extrapolation to prostate cancer is limited because of the heterogeneity of the study. So these evidences conclude that radiotherapy is safe and may delay disease progression and time to systemic therapy for selected patients with oligorecurrent prostate cancer with good quality of life and cost effectiveness. But evidence usually are from phase 2 RCT. They support use of MDT for ORD, but definitive phase 3 data are lacking, and these studies have not clarified whether this intervention can improve overall survival or not. Coming to second subset, that is oligoprogressive prostate cancer. This is defined as the progression of limited number, typically maximum of 3 of lesion, with majority remain responsive to ongoing systemic therapy. Typically occurs in subgroup of castration-resistant prostate cancer and caused by the evolution of one or more subclones to become resistant to ongoing systemic therapy. So what are the evidences in this subset? This is Pajula et al. In 2021 prospective data, where 2 studies, they pooled phase 1 analysis of 2 studies with castration-resistant prostate cancer, less than 5 progressive lesion on imaging, treating with SBRT alongside continued ADT. So 2-year next line systemic therapy free survival is 67.7%. This established safety of this intervention suggests delay in progression and systemic therapeutic switch.
Doctor, another 2 minutes to finish your argument.
Yeah, there are various retrospective evidences also showing that SBRT to oligoprogressive disease can prolong time to next line systemic therapy. And now there is phase 2 RCT, which is directly comparing MDT with standard of care, whether it has any overall survival benefit or not. So with all this data, can we conclude that we can use this therapy or not? But there are few points which we have to look. One is lack of definitive phase 3 evidence. Despite multiple promising phase 2 trial, there are currently no conclusive phase 3 randomized controlling trial demonstrating that MDT in this setting will improve overall survival or long-term disease control. Most clinical decisions are based on smaller early phase studies or retrospective analysis rather than gold standard evidence. These studies have not demonstrated any overall survival benefit. All these studies have used surrogate endpoint like delaying biochemical progression or time to androgen deprivation therapy, but not in overall survival or definitive cure. So this two impact on longer term clinical meaningful endpoints remain unproven. Third is heterogeneity in the patient population and study design. Most of these studies have no consensus on the lesion count. Some studies have used 3 lesions, some studies have used 5 lesions. And moreover, some studies have included only bone and lymph node disease as oligometastatic disease. Some diseases have included lung, liver lesion also in their trial. And also, most of these studies have used conventional studies in diagnosing oligometastatic diseases. As we know that PSMA PET is more good in picking up these lesions, because those diseases which are oligometastatic on conventional disease may be polymetastatic on PSMA PET. Fourth point is biological basis is incompletely understood. The oligometastatic state may simply reflect current limits of imaging rather than a unique biological phase. Cancer may progress systemically regardless of the local treatment, and MDT might not alter the natural course for patients whose disease is biologically predisposed to widespread progression. Because the spectrum therapy of cancer shows that the cancer cells are in the phase of clonal evolution and with varying degree of metastatic potential. So treating only local sites does not implies that it will treat the metastatic site also. Fifth point is potential for overtreatment and toxicity. Although generally well tolerated in short-term study, radiotherapy carries risk, especially when applied repetitively or in older patients. This MDT cause possible delay, but not avoidance of systemic therapy. It may only postpone the need for systemic therapy without fundamentally changing outcome. For many, the window of benefit is short-lived due to eventual progression. Seventh point is its bearing on economic and resource consideration. Frequent imaging, planning, and delivery of advanced radiotherapy may strain healthcare resources for a modest or unproven effect, diverting resources from intervention with proven survival and quality of life benefits. Ongoing trial may alter recommendation because there are key phase 3 study like Platon, Force, Stampedam, M radius are expected to clarify the true benefit, because in these studies they have compared MDT with standard of care. And till now, while the guidelines support the use of radiotherapy in this situation, ongoing research is still exploring the optimal integration of radiotherapy with other treatment like hormone therapy and the best patient selecting criteria for maximized benefit. So finally, to summarize, there is no robust evidence supporting the routine use of radiotherapy in oligoprogressive or oligorecurrent prostate cancer. Systemic therapy remains the foundation of management. Radiotherapy should be reserved for clinical trial or highly selected cases. Risk, uncertain benefit, and evolving understanding of disease biology counsel against routine radiotherapy in this setting. Need for large prospective randomized studies to assess survival, quality of life, and cost effectiveness of radiotherapy. Improved biomarker or imaging to select true oligometastatic or oligoprogressive candidates. Thank you.
Thank you. Thank you so much. Please take a seat. So Abhilash, Dr. Abhilash is radiation oncologist from Vizag, one of the stars. So Abhilash, defend yourself. It's MDT is not very beneficial.
Good morning, everybody. Thank you for this opportunity to the chairs, Rajiv Gandhi Hospital, Sogocon. It's great to be here. And I think Dr. Sani has actually made quite a few points in my favor. And he's already given me enough ammo to defend this. So let's take the discussion forward. So I'm obviously against this motion, being a radiation oncologist. Two keywords here. De-escalation is the theme of today's meeting. Oligoprogressive, oligorecurrent prostate cancer is definitely a very niche setting. We still haven't really understood the concepts or the philosophies behind high risk and locally advanced cancer. How can we understand the biology of oligoprogressive or oligorecurrent? So just if you rethink metastatic prostate cancer, yes, systemic therapy is the backbone, undisputed facts, nobody is denying it. Over the last 2 decades, we've improved the survival, more or less doubled the survival. This comes across from the Harvard group and also from the Stampede data. Dr. Max recently had a keynote lecture in EBM Tata conference in February, which I attended. You can see that the survival has more than doubled in the last 2 decades for metastatic prostate cancer. You have a plethora of systemic therapy options, FDA approved in hormone sensitive and castration resistant. I'm not going to get into it. My colleague knows better about them. The cost effectiveness or the side effect profile, that's what they deal with day in and day out. But I think we have too many options in prostate cancer. So the key adverse effects: treatment resistance in the form of castration resistance, erectile sexual dysfunctions, and because of a lack of a molecular target, potential high rate of mortality. So where does radiation therapy fit into this entire picture, or do we just discard it in in the case of metastatic prostate cancer? And could it be really the missing piece which could help you guys go forward and help you give better delayed next line systemic therapies? Just a basic understanding of what oligo recurrence is: limited sites after curative therapy. Oligo progressive disease is an already metastatic patient undergoing systemic therapy, but some focus of progression which possibly can be ablated or targeted. The absence of evidence is not the evidence of absence. Carl Sagan, the famous American astronomer. But yes, it's a poorly understood area. And for today, we may not have evidence. Say 10 years down the line, we could all have a lot of evidence. Background, my colleague has already spoken about it, so I won't delve into this. We'll be talking about points 2 and 3, the oligo recurrent setting and the oligo progressive setting. So what is MDT? I mean, the audience is mostly a uro-oncology audience, so I don't have to stress. High targeted, specific approach. The idea is to delay the progression and delay the need for aggressive systemic therapy. Mind you, we are not saying avoid systemic therapy. We are just saying potentially delay it, potentially avoid the adverse effects of ADT, delay it, prolong it. That's what we're saying. There is some proven data for PFS plus minus OS benefit, like my colleague also said and agreed. QOL preservation is probably the big thing I'll be talking about. And yes, used with systemic therapy. He cited some limitations: requires advanced imaging, image guidance, robust QA. I mean, if you want better outcomes, you need better technology. And not suitable for widespread metastasis, I agree. The major limitation which I'm willing to accept is there is no phase 3 data. Yes, as of today, we don't. I completely agree to that. So this is just a pictorial representation of MDT to all the disease, only to the recurrences, to progressive disease, or to the symptomatic sites. How do we go about doing this? But please understand that the systemic therapy definitely runs in the background. So let's begin. Oligo recurrence can be in 2 types. It could involve only the pelvis, nodal recurrence, or distant recurrence. If you look at the data for nodal recurrence, if you zap them with MDT, you see that in this single arm study, you could delay palliative ADT by 1.5 years for those patients. So that's definitely a big deal. And there was an overall survival rate or response rate of 60%. So there is definitely some data here, some leeway here for MDT. If you step it up, go to the oligopelvis study. So instead of zapping just the node, you treat that entire pelvis chain and you boost the node with radiation. So you see that these are long-term outcomes. 5-year ADT-free survival is 64%, which is quite significant, which I think all of you will agree. 1/3 of the patients were in CR after 5 years. You've given this patient a tremendous boost in his quality of life. These 2 studies which I talked about were compared in a randomized control study in the Peace Storm study, which created quite the storm, published earlier this year in the Lancet. So you see that they met their primary endpoint. A 4-year metastasis-free survival was statistically significant in the favor of elective nodal radiotherapy for oligorecurrence. This is local pelvic oligorecurrence. You see beautifully the graphs separating, statistical significance, undeniable benefit. The STOMP and the Oriole, my colleague has already spoken about them. This is for distant oligorecurrence, so not confined to the pelvis. If you just observe them, as opposed to you treat them with SBRT, there is a statistical significance for PFS. We have the extent study where they've used intermittent ADT for oligometastatic disease. The combined therapy is definitely better than hormone therapy alone. In the Radiosa study, they've combined it with ADT versus SBRT alone. And yes, all patients had testosterone recovery at 1 year. I think somebody spoke about testosterone recovery earlier as well. So this trial kind of proves it. So all our medical oncologists have a lot of systemic therapy options. So they've combined that as well along with SBRT, something called androgen annihilation therapy. Sounds like definitely scary. There was a lot of morbidity as well, definitely from the medical oncology side effects point of view. But you saw that 50% of patients had testosterone recovery. A bulk of the data lies for oligorecurrent, which I've just spoken about. Oligoprogression is an even more complicated disease, and I agree that there is very limited data. So until 2022, in the APCCC, this was questioned if this was really a clinical entity. They compared it to the Loch Ness Monster. Does it even exist? Is it there? Is it not there? Fully understood. But bang, there was data, I think in 2023, the ARTO study, which Dr. Idril Malik just briefly referred to. If you use abiraterone versus abiraterone plus SBRT, this is oligoprogression, mind you. There was definite biochemical response in about 80%. They did a subgroup analysis, and the subgroup analysis actually showed that the SBRT could be equivalent to your second line systemic therapy. So that was a big game changer. Last two slides.
Yeah.
You have the TRAP study and the phase 2 Medcare. These are single arm studies. They've basically shown that you can delay the next line systemic therapy. You push it as far as you can and try to improve the patient's quality of life. The big hit, which was recently published, Wolverine meta-analysis, I remember I had posted this in the uro-oncology group as well. Statistically significant progression-free survival in favor of MDT. Statistically significant radiographic progression-free survival in favor of MDT. Statistically significant freedom from castration resistance in favor of MDT. Near significant overall survival for MDT. So coming back to my initial slide, there is a role for radiation in oligoprogressive and oligorecurrent prostate cancer, and I am against this motion. Thank you.
Thank you so much. Both of you did a grand job. I believe that it has to be designed on a case-to-case basis, and definitely for oligorecurrent disease, there seems to be a very strong role. With oligoprogressive disease, one has to exhibit caution and understand what is the reason why we are doing intervention. And such MDT has a value definitely in quality of life, but whether it really affects the OS is something we need to see.
I think time will
As
answer
you
that
rightly
question
say,
for us.
another 10 years, we'll be in a much better space than where we are. I thank both of you. Thank you so much for that.
Thank you, sir.
So with that, we move to the next topic, that is molecular testing in prostate cancer. When, how, and how much. So that's the hot topic of the meeting, especially when you're talking about de-escalating. And we request our Director, Lab, Molecular Diagnosis and Transfusion Services, Dr. Anurag Mehta, sir, to delve on that. Over to you, sir.
Thank you, Dr. Varit, for your invitation, as well as for your introduction. Good morning, everyone. And this morning, I'll speak to you on molecular testing in prostate cancer. And I will focus on three aspects of molecular testing: the molecular architecture of a prostate cancer, and that will explain to you the rationale for testing, how is molecular testing used in clinics, and the brass tacks of testing, for example, the sample for testing, the timing of testing, and possibly that will explain to you when, how, and how much. So let's start looking at the molecular landscape. So let's start looking at the molecular landscape of prostate cancer. A little over half of these prostate cancers are driven by ETS family of gene rearrangement or their overexpression, invariably with TMPRSS2. So we have TMPRSS2 ERK fusion rearrangement, TMPRSS2 ETV fusion rearrangement, and so on. And little less than half of these prostate cancer are driven by an assortment of mutations like the most frequently reoccurring one is this POP mutation, FOXA1, IDH1, and several others. The point which I will like to highlight, and you shall take note, is that about 18% of the prostate cancer have inactivating mutations in homologous recombination repair genes. And this incidence rises to about 25% with the progression to metastatic disease. Likewise, CDK2 biallelic inactivation is seen in 2% to begin with, increases to 5%, and the MMR deficiency is seen in 1%, and that rises to 4 to 5% with the progression to metastatic disease. And take note of one more thing, that about half of these cancers which are driven by HRR gene inactivation, half of them, 12%, are actually inherited cancer. So a very large chunk of prostate cancers are inherited cancers. About 1 out of every 8 cancer is an inherited cancer, and this requires germline testing. And unfortunately, this is an underutilized testing, and I will exhort the surgeons to include germline testing for prostate cancer in appropriate context for detection of these cancers and then the subsequent family risk. And another point to note is the androgen receptor genetic alterations. So all these alterations actually converge to drive dysregulation of the androgen receptor pathway, but the androgen receptor physical genetic alteration only happen at progression. And what are those alterations that happen at progression? The first is the mutation in the ligand binding domain. And what does it do? It makes the ligand binding domain promiscuous. Now it can utilize, instead of dihydrotestosterone, any other steroid. It can utilize glucocorticoids. It can actually utilize even the ARSIs, the signaling inhibitors. And then we can have amplification. Obviously, the protein dosage is increased. And then we have splice variants, which actually do not need a ligand. So what are the clinical implications? And these are emerging and important. So please remember this mutation L702H makes this pathway sensitive to glucocorticoid. So if you're using glucocorticoid with abiraterone in this situation, this may actually fuel the growth of tumor. And likewise, 877L, here the enza and apalutamide can be used not as an inhibitor, but as a promoter of androgen receptor pathways. So with this mutation, you will be advised not to use enza or epa and instead use daralutamide. And the other implication is that we have a new emerging drug, which is a PROTAC degrader of the androgen receptors. And this have been shown to benefit, especially the cases which carry these two mutations in 878 and 875. And 46% PSA50 responses have been observed. The other alterations that have been seen are the methylation in a variety of genes, and of these GSTP1, RASF1, and APC are especially important because the methylation in these 3 genes have been used for diagnosis. So now just to sort of summarize what we have learned, the HRR gene loss of function increased by 7% with progression of this stage of cancer. Likewise, MMR deficiency and CDK biallelic loss also increases with progression. And this has an implication. The implication is that testing the archival tissue to detect actionable biomarker at the onset of metastatic castration-resistant prostate cancer may lead to underdetection. So you have to use a fresh tissue or maybe a liquid biopsy. The significant epigenomic alterations are observed in prostate cancer, which we will use for diagnostic test. And AR alterations are uncommon as a primary driver, but become frequent during progression. And these alterations are gaining relevance in clinical application. So you may not be using them today for deciding what drug, what ARSI to use, but they may become relevant over time. So now the next is, how do we use the genomic information in clinical practice? So first is therapy selection, and we have established usages, and we have emerging usages. The established usage is HRR gene inactivating mutations, which are used for selecting patients for PARP inhibitor, and the testing and the context is metastatic castration-resistant prostate cancer. Likewise, we use MMR deficiency for agnostic usage of pembrolizumab. The context remains the same. And then we can also, in the emerging therapies, you use CDK12 biallelic loss of function. And it has been seen that these have high tumor mutation burden and are enriched in those who will respond to immune checkpoint inhibitor. The context remains same in castration-resistant prostate cancer. And then AR ligand binding domains I have already spoken to, and the context will be whenever you have to use the novel and ARSI or abiraterone. And then another emerging use is a PTEN loss, for which AKT inhibitors are being tried as an emerging therapy. The trial so far has recommended its uses in metastatic castration-resistant prostate cancer, but conceptually people think that this can be used both in the early stages and hormone-sensitive prostate cancer also. And then we have a diagnostic use in which we look at the methylation profiling, and obviously this will be used at the time of a diagnosis. Similarly, we can use a microarray-based gene expressor classifier, and this gene expressor classifier will tell us about the aggressiveness of the tumor, and this also has to be done either post-biopsy or post-radical prostatectomy, and then the detection of inherited cancer. This should be done at the time of diagnosis, but if it has not been done at the time of diagnosis, it should be done whenever it is possible. And now a little bit about the brass tacks. So about 25% of metastatic castration-resistant prostate cancers have inactivating mutations in homologous recombination repair genes, and 60 to 80% of these will respond to PARP inhibitors. But only 6 to 9% who do not have HRR inactivation will respond. Therefore, testing for HRR gene inactivation is useful in selection of PARP inhibitors. There are two settings in which PARP inhibitors are used, either upfront with the androgen receptor signaling inhibitors or after exhausting the ARSI and the taxanes. The genes that can be tested in or have been tested in different trials are different, but most of us confine ourselves to the gene list that was used in the PROFOUND trials, the 15 genes that were used in the PROFOUND trials. And a point to note and take home is that those with BRCA2 will respond best. Those with BRCA1 will respond little less than BRCA2, and then ATM, PALB2 and others. Also take note of the fact that germline BRCA, those who harbor germline BRCA alteration will respond better than those who have a somatic BRCA mutation, and those with biallelic BRCA2 alteration will be the best responder. And some of them have been the extreme responder, while those with monoallelic BRCA2 are likely to show less pronounced benefit. So when to test? Obviously, it is obvious at castration resistance. Preferred sample, liquid biopsy, because you want real time now, not the archival tissue, and you are unlikely to do a fresh biopsy, but just doing this testing. However, if the liquid biopsy fail, then you will have to do a fresh biopsy. You can use archival tissue with a rider that you will under-detect some cases of HRR. And as I said earlier, the report should have biallelic, monoallelic, subclonal. And if it is subclonal, the report should indicate that this is less predictive of a response to PARP inhibitor. Most patients are not likely to respond if they have a tumor fraction of 40% and if they have an allele frequency of 10 or 15%. So that should be noted. And if the allele frequency is very high, that should also be noted. And if the allele frequency is very high, this could be a germline. Like in this case, the allele frequency was high. So we went ahead and tested him by Sanger sequencing on blood, and we identified the same mutation. So you can do on the tumor tissue the task of also identifying the germline mutation, but you have to be very aware of the WEF for this. And then you, for MMR testing, 5% of prostate cancer, advanced cancers are MMR deficient. This could be because of sporadic or because of Lynch syndrome. And as we know, deficient MMR is an agnostic marker for pembrolizumab. But however, the benefit of immune checkpoint therapy in prostate cancer has been ambiguous. However, newer combination, dual inhibition with EP and Nivo, or combining with the taxane are being tried. And we're getting some good, better responses, disease benefit response of 50% and others. And again, how to test? The commercial liquid biopsy tests such as Guardant, Foundation, and Tempus are good. It is very difficult to validate MSI on a liquid biopsy in a hospital lab or in a small commercial lab. So it's best to use, if you want to do MSI on liquid biopsy, the commercial test. But if you have a tissue, you can do IHC, which is wonderful, or you can do it as a part of a validated next generation panel. The same applies to biallelic CDK12 loss. So I will not go into the details of this, but this is becoming a biomarker for immune checkpoint therapy because they have high tumor mutation burden. And the only type of prostate cancer, because prostate cancers are very cold cancers, like hormone receptor positive breast cancer, unlikely to respond to immune checkpoint inhibitor. But it has been seen these are the tumors with biallelic CDK12 loss, which may be hot tumors and may respond to immunotherapy. And it is not uncommon. In our limited testing of prostate cancer, we have already seen 3 cases of biallelic CDK12 loss. And then PTEN is another emerging marker. And a trial called iPotential 150 has shown limited benefit only in the radiographic progression-free survival. The overall survival has not been identified. And PTEN is becoming conceptually a marker for AKT1 inhibitors like capivasertib or ipatasertib across all stages of prostate cancer. And this can be identified by IHC on the tumor tissue. But unfortunately, again, you will want to do it at castration resistance. And this evolves from 15% to 50%. The incidence truly increases. So you will have to use liquid biopsy. And then we have a decipher test, which is based upon gene expression profiling. And it divides the risk into high genomic risk, intermediate genomic risk, and low genomic risk. And combining the genomic risk with the clinical risk, you can either de-intensify or intensify the therapy, both after biopsy and also after radical prostatectomy. And then we have this test based upon, this is called confirm MDX, based upon the methylation of those 3 genes I had already spoken about. So when a biopsy is negative, but suspicion is very high, we can use confirm MDX. And this is based upon the methylation in the vicinity of the tumor tissue. So if you have failed to take the tumor tissue, the tissue that you have obtained in the biopsy will show the methylation signature. And if methylation signature is present, that means you should repeat biopsy. And if a methylation signature is absent, then you can revert to routine screening program. And lastly, something very dear to me is to identify prostate cancer and assess family risk. Because 10 to 12% of prostate cancers are inherited, germline testing is strongly recommended. It is as frequent as ovarian cancer. Ovarian cancer specialists are doing it. Prostate cancer specialists are not doing it. So this should be an important message from my side. And this should be done for risk reduction counseling for male breast and pancreatic ductal adenocarcinoma in the patient, and also for family screening. When to test? Test at diagnosis. If you have not done that, whenever possible. Whenever you make a fresh contact with him now, do it. And who to test? So in early prostate cancer, with the very low risk and intermediate risk, testing is restricted to those who have a positive family history, or those who have a intraductal or cribriform morphology, or if they have a personal history of breast cancer. And all other patients of high, very high risk, regional disease, metastatic disease, they should all be tested and tested for nearly these dozen genes which are associated with inherited prostate cancer risk. So to summarize, molecular testing is critical for guiding the effective use of PARP inhibitors and for identifying prostate cancer patients with underlying hereditary cancer syndromes. Germline testing has not gained traction in the prostate cancer field, and there is an urgent need to embrace it vigorously. Molecular testing can streamline diagnostic processes, help assess prognosis, and enable better informed treatment decisions. So thank you so much. I will close here.
Thank you, sir, for such a lucid lecture. And we as clinicians, we also take guidance from you, especially when it came to PARP inhibitors. Initially, it was all comers, like we had the Propel trial and the Talapro, and slowly we came to know from the Magnitude trial that we have to sift out the BRCA mutants who would get the best benefit, especially the BRCA2. And now they are moving from the castrate-resistant arena to the hormone-sensitive arena. You have the host of trials which have been alluded. And of course, we have the other markers which are coming in vogue and some agnostic markers. Thank you very much, sir, for the lecture.
So, after the molecular testing, now it's time for the PARP inhibitors. So PARP inhibitors, we know in CRPC, now it's using in HSPC as well. So PARP inhibitors in HSPC and CRPC by Dr. Vashish Mania, is senior consultant, medical oncologist and hemato-oncologist at Breach Candy Hospital and Saifi Hospital. Over to Dr. Mania.
Thank you so much, sir. Thank you, Dr. Talwar, and such a pleasure and a privilege to be here at RGCI. Dr. Anurag Mehta, phenomenal talk, has really made my life significantly simpler because I will be focusing on a part of what he spoke about, and that is indeed role of HRR testing and PARP inhibitors. Where do we stand today in terms of HSPC and CRPC? So let's deep dive into understanding what's the fuss about HRR testing. Don't we have enough troubles deciding whether should we be using a triplet, a quadruplet, a doublet? Should we escalate? Should we de-escalate? Why do you want to address one more problem if it's not worth solving? It probably is worth solving. So we will quickly touch upon what's the fuss about HRR testing, what is HRR, whom to test, when to test, whom should you add PARP inhibitors, when should you add PARP inhibitors, and what are the potential side effect profiles of using these drugs. So again, succinctly put by almost 3 of my colleagues in the last 1 hour, there is enough evidence to believe that this is an important area to be addressed, because 1 in 3 patients who is metastatic would be HRR positive, either germline or somatic. They have both prognostic and predictive implications. Prognostic because if you are HRR positive, you will probably do worse, and predictive because it opens up a new therapeutic armamentarium. What really is HRR all about? HRR, or homologous recombination repair, is a DNA repair pathway of clinical interest because of its sensitivity to PARP inhibitors and potentially platinum-based chemotherapy. These include directly or indirected pathways of genes which are BRCA1, BRCA2, CHEK2, ATM, PALB2, FNCA, and RAD51D, among others. So what we all probably know about is the basic DNA damage whenever there is a single-stranded DNA break. Because of an intact PARP, it uses the base excision repair pathway and the cell survives. However, if these cells are subjected to PARP inhibition, there is accumulation of these single-stranded DNA breaks, which eventually, if unrepaired, lead to replication flock collapse and a double-stranded break. Now, if there is a double whammy, along with PARP inhibition, if one also has an HRR which is deficient, then it leads to what we call as synthetic lethality. It leads to cell death. So having presence of HRR deficiency and PARP inhibition is lethal to the right cells. So when would you do this testing? What all should you test for? and who would you test? I think these questions were answered in the last 30 minutes, so I'll breeze through them. Looking at the NCCN guidelines, all high risk, very high risk, regional, metastatic prostate cancers. So technically all medical oncologists should be testing these patients because we get most of these patients. It's uncommon that you have an ultra low risk patient walk into your clinic and would be on your follow-up. A positive family history of cancer, a family history of high risk germline mutations, somebody's BRCA positive mother and the son would want to get himself tested, and cribriform histology also underlying telling us that there could be a potential genomic instability. Again, reiterating what Dr. Mehta already spoke about, these tests, according to the NCCN, could be divided into germline and somatic, which is biomarker molecular-based testing. If you have a family history or an intraductal histology, irrespectively, if it's very low, low, favorable, unfavorable, intermediate, you should still be tested. If you are high, very high, or if you have regional or metastatic disease, irrespectively, you should undergo germline testing. When it comes to somatic, probably you would want to undergo somatic testing if the life expectancy is more than 10 years, or if you have regional or metastatic disease, to find more patients who are HRR positive or DMMR. Why do we talk about HRR being prognostic? Because if you have a DNA repair abnormality, one realizes that these tend to get accrued. So if you look at, and when should you test it? I think, again, Dr. Mehta beautifully, succinctly mentioned that if you're testing these patients when they're early in their disease life cycle, you're likely to miss them. So about 10% of these patients would be positive at early stage diagnosis versus 27% patients when they become metastatic in nature. So it's very, very important, even if patients who have been tested at baseline and are negative, and if they do become castrate resistant, it's definitely worth testing them again. And why the fuss about BRCA being a bad gene? I think the data is here for all of us to see. If these patients are BRCA positive, they are more likely to be T2, T3 than T1. They are more likely to be a Gleason's of 8 and more if they are BRCA positive. And they're more likely to have nodal involvement, 6 versus 1.6%. So these tumors are often more aggressive. They're often advanced at diagnosis with a higher T and N stage, and hence have a poor prognosis. What should we test for? Again, BRCA2 being the most common one, so it should at least include an MSI panel by IHC or NGS if resources are not a constraint, and at least test for germline HRR, which includes BRCA1, 2, ATM, PALB2, and CHEK2. In the absence of a family or a family history of typical clinical features, it may yield low results. And the prevalence of inherited DNA repair mutations in men with prostate cancer, has been reiterated now, is found to be around 11.8% based on a large analysis of 700 plus patients. So when we look at germline mutation, about half of these would be BRCA2. BRCA1 is very uncommon. ATM and CHEK2 are more common compared to BRCA1. For all comers, if you put somatic and germline together, again, BRCA2 is the most common one. 8% germline, 7% somatic. BRCA1 together, somatic and germline constitutes less than 2. ATM is more common, CHEK2 is more common. So which patients who should be tested? Again, reiterating positive family history, known DDR mutations, intermediate high risk biochemical relapse, and metastatic prostate cancer. Also those with a ductal or intraductal histology. What do you test for? Somatic tissue, if possible. Ideally, if they metastasize, do it again if it's negative at baseline. Germline testing should be recommended for all comers, is what all of us believe. Liquid biopsy, CTC, interesting concept. Is it for all comers? Probably no. If you cannot biopsy a metastatic site, if the patient has bone-only metastases, a rising PSA, and it's worth contemplating doing a liquid biopsy. However, watch for chip mutations because they often can spoil the party there. So coming to addressing the treatment, which is using PARP inhibitors, we have 4 of them, 2 of which are available in India, olaparib and rucaparib. The other 2 are not yet available in India, which is talazoparib and niraparib. When should you add it? What is the current evidence of data in HSPC and CRPC? Unfortunately, as we speak today, there is no randomized published data of overall survival benefit of adding these drugs in HSPC. In CRPC, there is reasonably strong data. However, there are three areas that we need to quickly discuss today as to which mutations in DNA repair genes would benefit the most from PARP inhibition. What should be the sequencing of these drugs? Now, these drugs are available. When would you want to use it? Would you use it before chemotherapy, after chemotherapy, before ARPI, after ARPI? Would you want to use it alone? Would you want to use it in combination? This slide actually encompasses all of that data. So BRCA2 followed by BRCA1 is the most sensitive. PALB2 ATM are less likely to be sensitive. Olaparib has the most robust data based on the profound cohort genes. In olaparib, you can check it can be used for all comers like HRR, including BRCA. While for rucaparib, the data is only for BRCA1 and BRCA2. Again, for talazoparib, it's for all comers which are HRR genes. Sequencing of therapy, again looking at pure FDA approval after androgen receptor therapy like abiraterone and enzalutamide, monotherapy of olaparib is currently an FDA approved therapy. And after chemotherapy, you can use either olaparib or rucaparib. So use of single agent rucaparib post AR therapy is currently not US FDA approved. Monotherapy versus combination therapy, let's quickly understand. So what is the data say? Looking at the profound study design, which divided these patients into two cohorts, A and B. Cohort A was the one which were more likely to respond, which is BRCA1, BRCA2, and ATM. It randomized patients who had progressed on prior abiraterone or enzalutamide to single agent olaparib versus placebo. And radiological PFS is what it was the primary endpoint. And the cohort 1 data is very, very obvious and evident. There was a median overall survival benefit of 19 versus 14.7 months. If you adjust for crossover, the HR became even more robust at 0.42. If you combine all comers, which is A plus B, BRCA plus BRCA-like genes, the OS benefit is less profound with an HR of 0.79. However, if one adjusts for crossover, because crossover was allowed and rightly so, the HR again goes towards a significant limit of 0.55. The other data was post-taxanes. What if this patient had a high burden disease and this patient received taxanes while he was HSPC or even in CRPC state? Then the data is there for combining a PARP inhibitor with abiraterone or a PARP inhibitor with enzalutamide as well. Again, radiological PFS was the primary endpoint and OS being the secondary endpoint. Again, very robust data, early separation of curves which continue to remain separate, a median radiological PFS of 16 versus 24 months with this combination therapy, and a strong hazard ratio of 0.66. Also, what we see is that the benefit was for all comers, irrespective of when was docetaxel used. It was more profound, surprisingly, in people who had high volume visceral metastases. And the benefit was obviously far greater in HRR deficient versus non-HRR patients. TELAPRO trial, I think Dr. Talwar briefly mentioned about it. Very, very interesting data because it interestingly also looks at all comers, and it's talazoparib, again a combination of talazoparib plus enzalutamide versus enzalutamide alone in people who may have used abiraterone or docetaxel when they were HSPC. It again looks at radiological PFS, and OS is a secondary key endpoint. Again, very, very early interesting suppression of curves. Hazard ratio of 0.63, the median OS is not even achieved in the combination, and it's even more profound expectedly if you are HRR deficient. 27.9 months versus 16.4 months PFS is very, very uncommon in such subset of patients because these are technically high-risk patients. I have used this slide from up to date because I thought it was very, very, self-explaining. So all patients who should receive ADT, obviously, and basis what the other treatments they have received and the current approvals, the flow chart should be looked at. So has the patient received a normal hormonal agent like abiraterone or enzalutamide when they are CRPC and they are HRR mutant? If the answer is yes, then the second question is, have they received taxanes yet or they haven't? If they haven't received taxane, then the current approval is for single agent olaparib over chemotherapy. If they have used taxane, you can either use olaparib or rucaparib post-taxane as a single agent drug. When it comes to the patients who have never received these ARPIs then you can combine ARPI along with a PARP inhibitor, which is abiraterone plus olaparib or niraparib, or you can use enzalutamide plus talazoparib. The other question which is not answered in this slide is sequential therapy versus using the combination. Again, no real evidence to believe that one is better than the other. But if a patient is reasonably younger, fitter, then one would potentially look at a combination therapy of a PARP plus an androgen receptor inhibitor versus if the patient is elderly, 75, 80, then you would want to use these drugs sequentially. How safe are PARP? Again, for most medical oncologists, they've been using these drugs for a while, and anemia and fatigue constitute a major problem in terms of giving these therapies. However, there was not a significant dramatic upswing in these toxicities synergistically with the use of abiraterone and were reasonably safer. Again, other side effects like nausea, diarrhea, constipation, back pain are there more commonly in the combination therapy compared to a single agent drug. So choose your patients wisely. If you have a patient who is younger, fitter, no major comorbidities, has had a reasonably fair hematological profile, worth using this combination. If the patient is frail, elderly, you would want to use these drugs sequentially. So we probably have answered these 8 questions. 3, I've had the luxury of Dr. Mehta answering them before me. Thank you. Thank you so much.
Just one question, that how do you place PARP inhibitors in hormone-sensitive prostate cancer? Do you use or?
So the current evidence does not support its use. The current evidence mentions that hormone-sensitive prostate cancer who are HRR deficient should be treated like anybody else.
Any more questions from audience? So thank you very much.
Thank you. Thank you so much.
We are just going to start the panel discussion. We are going to invite Dr. Kumar Prabhash from Mumbai to come in, invite the panelists, and as chairpersons, we will disappear from this place, which will pave way for Kumar to take over from here.
Good morning, everyone. I thank the organizer, especially Dr. Vineet, for inviting me for this session today. And my job is to have a discussion regarding CRPC and the treatment options. And I request the panelists to come on board. Dr. Varun Goel, medical oncologist from Delhi, Dr. Swati Chug, medical oncologist from Delhi, Ram Abhinav, medical oncologist from Coimbatore, Anandya, medical oncologist from Delhi, Dr. Adam Stewart Kibble, uro-oncologist from United States, Daniel W. Lin, uro-oncologist from United States, Aravind Panda, urologist from Hyderabad, and Sujana Priya, radiation oncologist from Hyderabad. So we do have a good mix of specialty here.
Hello.
So everyone is seated, so we can start the session. We'll start with the first case. Maybe we'll put something interesting there. It looks like this was the first panel, so we don't have HSPC. So we'll talk about some HSPC and then see, because your CRPC is dependent upon what you did in HSPC, and we did have some interesting discussion. What do you do in HSPC apart from ADT to combining 4 drug? So let's see what people do and what we do subsequently. So, gentleman, 48-year-old, not so uncommon in Indian context. The 48-year-old will be fairly very young in Western context for prostate cancer, but you do get it. no comorbidities, no family history, had LUTS, and the PSA was more than 100. There was prostatomegaly, adenocarcinoma on biopsy, Gleason 9, PNI positive and positive in 90% of the core. This was the PSMA PET result showing it's all over. And the biopsy report is conventional prostate cancer. Gleason 4 plus 5 is 9. So you have a high volume disease, metastatic, hormone sensitive, and then we can have from all the panelists in today's time, we heard from people how to go from one extent to other, how they will treat it. Maybe we can start from here. And everyone can have a view because prostate cancer is today treated by oncologists, radiation oncologists, medical oncologists, and they all have a view for the same. Yeah.
Yeah. So I would, this patient is young and definitely he warrants triplet therapy. And also, yes, for the second question, I would consider NGS with HRR plus HRD is generally a part of, if you do NGS with HRR, they do it sometimes. If HRR is positive, then I will do HRD. Otherwise, I would not do. But yes, he will get triplet therapy in my practice initially, and I would do molecular testing. So if
molecular testing, yes, HRR, definitely HRD.
If HRR is positive, yes, HRD. NGS will cover all that.
Cover all that. Ramavan, same? Somatic and germline. Okay.
So ADT with taxane plus that is triplet therapy with HRR, HRD I don't usually do, but if it's available, I would do it. And also NGS. And preferably both germline and somatic because he's 48-year-old. We have a high chance of germline mutation.
Yes, sir.
Same here. Triplet regime because it's high volume disease. Would prefer for triplet regime and also HRR, including germline and somatic both upfront.
Thank you.
Definitely would like to go for a triplet regime containing an ADT. And for regarding molecular testing, HRR, germline, somatic both, including of NGS.
Sir, I will concur with our
same. So
panelists. So triple regime and HRR with the NGS, both somatic and germline.
Thank you. Yes, sir.
I would, at our institution, we'd refer to medical oncology, but he would get triple therapy. He would get germline sequencing and tumor sequencing.
Yeah, very similar. We have a multidisciplinary clinic with medical oncology, of course, and there's no surgical at the front end, but we would do commercial testing as well as ctDNA as well.
Oh, ctDNA added to it. And ctDNA for?
It would be a in-house ctDNA for research purposes only.
Oh, okay.
Yeah, so I kind of concur with all my panelists, and I would also like to add a bone modifying agent if possible, because he's having a lot of bone lesions for bone health.
Bone health.
Yeah.
So bone health, not for metastasis.
No, for bone health.
Bone health.
Yeah.
Great. Yes, that's true. Important to test for bone health and to add bone modifying agent for bone health. The difference is that don't give on a monthly basis. Give it 6 months a year. That will be good enough in case bone health requires the intervention. Otherwise, good. So looks like two things is fairly well established. One is testing. So looks like sensitization for testing has been enough that everybody concurred that do testing, have the report with yourself. Second is that if you have disease, high volume, we can keep debating what do you call high volume. But if your disease is a lot of them, 3 drug, almost everyone agreed that we need to be using it. Coming to testing part of it, again, we heard everyone concurred germline and tissue both. We had some discussion regarding ctDNA. Maybe can you want to add a value? What potentially ctDNA in research adds value? Where there is going to be the potential for ctDNA in future in case where it is getting tested as far as the prostate cancer is concerned?
So we've looked at the value of ctDNA in quantification for sure to look at first initial disease response to the initial 6 months of therapy. So trying to have what we call a fast switch. If the ctDNA is changing in the first 6 months of therapy, at that point in time, whether to switch to another therapy or not. It's similar to this idea about de-intensification or intensification based on the PSA response. We've done that for many years already, looked at the nadir PSA, but now we can look at ctDNA response as well. So that's what we're doing in a research protocol, of course.
Ram, Avinam, you want to add something? ctDNA, where else you think It will be useful for in your treatment decision making.
Otherwise, if biopsy is not feasible, then I would go for CT.
Excellent. So you have biopsy not feasible. So what is that ctDNA? We say a germline you do in blood. So what is this difference between ctDNA? This is for audience that you have sent for blood. So what is this germline and ctDNA? Are they different?
Yes, they are different.
Excellent. So what is trying to convey that in case you don't have a tissue is older, you have done your germline perfect that you do from the normal cells. What you're doing for ctDNA, it is going to come. Like if you take lung cancer, today we do in almost all patients ctDNA for doing the somatic testing. And if you don't have enough tissue, you can do ctDNA. And if you have mutation in ctDNA, specificity is excellent. The problem is the sensitivity. And that is the reason, because you do have tissue in most of the patient, we don't do it here routinely. But in case you don't have it, if you're doing ctDNA and you are getting those mutations, it is good. So difference between germline and ctDNA, in case you don't have tissue, you can do it. And for monitoring, as was mentioned, it will be coming soon. You have in colon cancer now you do have as a part of, by and large, FDA label is there. You don't have an NCCN guideline, but whole lot of people uses it. And if you see the curve for ctDNA based therapy modification, we will be shortly using it.
So just one point to add.
Go ahead.
Like,
Yeah.
we may use this ctDNA as a monitoring purpose when like we have started PARP inhibitor, but if we getting resistance and patient is progressing, maybe some type of resistance mechanism we can get on that.
Totally agree. And again, I repeat, we do in lung cancer. In case in lung cancer patient, you have given therapy, a tablet, we give it, and subsequently, go ahead, Ram, you add.
So I don't do ctDNA at this point, but what I understand is CTC would be helpful in monitoring the disease, whether ctDNA would be helpful in monitoring this.
Okay, so we didn't want to go there, but having said that, you have gone there, we can have a bit of a discussion, because if you take NCCN guideline few years back, CTC was considered a part of a routine care, and now you don't see it. So what happened? So
Yeah, I don't know. It was, I don't know, are you part of the guidelines? The NCCN? Not that one, yes.
not that.
So it was a very big debate about CTC versus ctDNA, and I think that the sensitivity or the specificity when one looks at the performance of CTC, it went down with time over the clinical trials from the bank specimens. But the ctDNA, the readout of the actual mutational landscape, was much more robust. That's why the CTC went away. That was my impression. I don't know whether anyone, Bod or anyone else that's involved in the NCCN, but that was a great debate.
Five and above.
Yeah.
And just a comment about different guidelines. So guidelines are set up in different ways. AUA has very strict guidelines, which can get in the way sometimes because you want to go ahead and discuss something and they say, well, there's no level one evidence, therefore we can't endorse it. And a lot of our practices are not based solely on level one guidance. NCCN is based on a bunch of people getting in the room and arguing. And often the loudest voice is the one that wins, not the one with the best data. So just take NCCN guidelines with a little bit of grain. And that's why sometimes you see it flip back and forth.
So what, yes, sir, go ahead.
I'm just going to make a comment to what Dan and everybody was saying. The problem with CTCs is the Veridex assay is not very sensitive. So Howard Chair, who did a lot of the original work, has stopped using CTCs. They got rid of all their analyzers. That's the biggest problem. You cannot find the CTCs reliably. So that's why people have defaulted to ctDNA. And there's not a competing assay that allows you to detect ctDNA at this point. But we have been doing some work which is able to find ctDNA, and at least in advanced prostate cancer, we're able to actually look at signal. We can find PSMA and other, we're actually looking at, exosomic analysis of proteomics to see if we can separate out. But it's still a ways away before we can actually bring it to prime time. But that's really the fundamental problem with CTC. You cannot find them.
Okay. So I think so what we understood with all the discussion, the CTC, one of the challenge has been you count only few cells, like 5 in number. So you have to take a blood and then you find those cells, and then cells has to be, prostate cancer cells, and then counting. So think about you have 3 and 6. So those chances of having those issues and error becomes higher. And that's the reason it is usually not done. It fall out of the favor, but it is catching up again because in that cells, whatever you pick up, you can do sequencing. So pretty people are what they are doing it. So we did some work for CTC in head and neck cancer. Again, it's tough to pick up those number of cells. But what the smartly people have done now, pick out those cells. Now you are getting a bunch of cells and you're doing genomic analysis. Can you do those 5 cells and individually do genomic analysis? And that looks interesting. So looks like there is a slow and comeback for CTC, but not for routine care at this moment. And you can do in research setting. Yeah, go ahead. Go ahead, sir. Yes.
So what we have done now is to subcategorize these tests
Mm.
in a particular patient.
Yes.
So if we are looking at making a ruling in or ruling out metastatic disease, we just do a cfDNA, which is much more cost effective, and then we can just get the yield. We don't need the circulating tumor cells. We don't even need the ctDNA. But if you're trying to look for a marker out of this, then probably, like you said, a CTC or a ctDNA may be more better. But I think we should start looking at even cfDNA as a probable marker for metastatic disease.
cfDNA for yes,
cell-free DNA.
Cell-free DNA. Got it, sir. Cell-free DNA. I'll make a statement on that, sir. Yes, go ahead. Yes, that is true. Huh.
So what is the purpose of testing the somatic mutation? Germline, I understand, because we have to see whether this component is hereditary, transmission. So that can be done at a later date as well, when you have the chances of somatic mutations occurring will increase as the CRPC progresses. So what is the actual role of the somatic mutation? when we are
Got your point.
targeting?
I wanted to bring it later, but as you have raised it, so we can. So question, there was some discussion on it, I know, in the last few, presentation, but 2-3 people can comment on it. Why you want it now? When you want to intervene it later, why you want this information now?
No. This patient is young, and if he has a BRCA1 or BRCA2 mutation, and maybe we can change the sequencing. We may not introduce chemo very early, or you may introduce PARP inhibitors early in this treatment. So you definitely need in this case.
Okay, so this also discussion, I wanted to have it later because that study was discussed.
Because this is young. There are toxicities in PARP. If it was very old, if this patient was like 75, then I wouldn't consider that. Maybe, but this is 48.
You have a very valid
He
point.
will tolerate.
So you have a very valid point. So, Aram, you want to have a PARP inhibitor early?
Not now, but
No, it's okay. Not now.
testing it early, better results.
Will come. You want to add it? Sorry, you want
Testing
to do
early will lead to better results. The testing might
better
be
result. How? That's what his question.
The tissue is fresh.
Okay, some information that you can help you change in the mutations. What happened? That is one.
sensitivity of the test is
Sensitive test is better early than later. Okay, then anyone?
For the germline, it would make sense for cascade testing for the family.
Somatic.
I mean, yes.
His question is,
yeah. You're
he's saying
asking- you're
somatic.
asking somatic, right?
Why you want to do somatic?
No, I understand.
Anyone? So, in principle, okay. Oh, yes, go ahead. I take help of my colleague. Get away. So, SPOP, do it. And if it is, positive, then give only hormonal therapy, don't give chemotherapy. Okay, बहुत बढ़िया. Anyone willing to? So see, these are younger guys. We are older guys. We want simple. We have a report and we want the therapy to be decided. These are younger guys. They want all information. They say, hey, we need to use them today.
So I would say we're at a little bit of an inflection point around this, right? So it's entirely possible that we may start using PARP inhibitors a little earlier. Even the sequencing used to be, it took a long time to get sequencing. Now we can get sequencing very rapidly. Used to be, we had to get tumor, and when patients had metastatic castrate resistant, we're trying to get it out of bone, and now we can get it out of blood. So I think the issue right now is we're sort of at an inflection point in multiple different domains. And so you just sort of want more knowledge. More knowledge will help you. If the patient, he's a young patient, he's probably going to progress fairly rapidly, and you would much more quickly go to a PARP inhibitor. It's entirely plausible that in a few years, you'll be able to sequence something out of his blood very quickly and convert him to a PARP very earlier, and you won't care what his primary tumor is. But right now, I think it sort of helps you sort of anticipate where you're going to go.
So, we got, regarding, we'll have one each comment for all three of them. One is cfDNA. So one of the problem with cfDNA is that cell-free DNA, you have lots of normal cells in the blood. So you will get whole lot of cfDNA. we have done a whole lot of work in lung cancer on cfDNA and ctDNA. So only having cfDNA, that provides you very limited information. ctDNA as a level, as a proportion of cfDNA, that gives you some useful information because that proportion tells you what is the body tumor load, but again, partially. Then you do have mutations that gives you far more information. So that's why you see a whole lot of people working on ctDNA level, or now moving on doing those individual mutation and methylation where the work is at this moment. But good to start with. If you want to start with liquid biopsy, good to start with doing something. Coming to the testing part, what we heard from the panel, that you do have mutation testing, you can do it later. If you have a tissue, think about it, you have a progressive disease in bone, then where you do the biopsy from and how you get the testing done. You can do ctDNA, it's less sensitive, excellent specificity, but getting test is a challenge. Old tissue, and again, that work we have done quite a lot. And one of the things we did, 1,500 patients, we had a chance to do on a whole exome sequencing. Only 30% we could do it because those tissues were old. So the older the tissue becomes, tougher it is to do molecular testing. So, but remember that, fresher the tissue you have, better you have a chance to have the yield. In the sense from tissue for the technical point of view is concerned, but your point is absolutely right. And this was shown by everyone that as the time goes by, the chances that you pick up HRR is higher because more patient becomes HRR positive. So if you get it negative in the baseline tissue and you get a tissue later, repeat it if possible. But if you're doing at baseline, there is some value there. Now coming to HRR testing and giving first line therapy, will come to that. I wanted to know what people think after the trial which is there. So this was regarding testing. So two things looks like fairly we have settled. And as we had a suggestion that we may avoid certain treatment. So you had a first line therapy. This is what was done. What was done at our hospital. We may or may not agree. Was the docetaxel required or not? Or do you wanted to give one therapy? You should have been something else. This is what happened to the patient. And this is a post-docetaxel. So post-docetaxel, how you choose those options, what you have? Yeah, anyone can take it.
So yes, we have
We chose what we chose, so it is written here. But was this the right thing to do in today's time?
So first of all, what is the HRD status and BRCA status of that patient?
Excellent.
And based on which we can plan. If HRR mutations are there, and if it is BRCA 1 and 2, and we have just given docetaxel with no ARPI we have given earlier, we can give PARP inhibitor with the ARPI in the form of olaparib and abiraterone. Otherwise, tazoloparib is not available with us. Otherwise, with azuletamide we can add that. Even if BRCA 1, 2 is not there, other mutations are there. So this is now latest recommendations. Otherwise, if on docetaxel, if PS is okay, and if burden of disease is still high, we may go for second line cabazitaxel in this patient, or otherwise docetaxel rechallenge also can be tried. Otherwise, abiraterone is a good option.
Okay. Everyone agrees that this is the similar approach? Then we can move on. Then, ever thought of lutetium?
Yes, sir. Lutetium therapy, yes, it is coming up a big way, even in the first line.
And you had this BRCA1 positive, so we have talked about it.
Can you go back? Nobody would want to give this patient lutetium?
No, he said lutetium as an option. Lutetium as an option.
So I have a question about that. So you would stop the abiraterone when you gave him lutetium, or would you continue with the abiraterone?
So lutetium therapy we can plan, and along with the abiraterone, when after maybe 3 or 4 with lutetium therapies, we can discontinue and continue abiraterone.
Continue.
Yes.
Because there is data out there that the combination of lutetium, well, not lutetium, radium, and abiraterone was very toxic. I don't think that's sort of true for lutetium. Lutetium and abiraterone has been well tolerated. Would you agree with that?
We have tried in few of our patients, especially if high burden disease, and no much toxicity we have seen.
Anyone to comment regarding this? Is a valid question that you give lutetium. Do you want to combine with something, or you want to use alone?
The one thing about lutetium is lutetium works well if the SV max is more. There has to be bone. It has to light up. And once my My question always to my colleagues is, I'm a surgeon. So if you give us, if you are giving in a triplet setting and the SCV max comes down, is it as effective? You have now some trials, upstream trials and all that. We don't have the final answers upfront. We don't have final answers upfront lutetium. How much? So the data is still out on that one. We maybe in the next 1 year we will get data on that.
Correct. So what is, yes, sir. Go ahead, sir. Yeah.
So they can be both combined.
So as mentioned by our guest was that when combined by radium, there was a huge increase in toxicity. So sometimes it can be different, but it may be troublesome for patient. And that's what he's trying to convey. So what he's trying to convey that be careful when you want to combine. Lutetium, I also always thought that is a very safe treatment. And it is a relatively safe treatment. But if you read the toxicity of it, we need to be a bit careful about it. Yes, true. So this is what we did, and then somehow we end up using OMCT. OMCT, anyone uses it? Not for our guest, but here, Ram Abhinav, you use it?
We use it.
OMCT, you use it, and what do you use it?
We use low-dose DEXA and cyclodose endoxin.
Endoxin, okay. So we call it oral metronomic chemotherapy. So it's ultimate chemotherapy plus something. So yes. Anyone else? No one? No one uses it?
We usually don't.
Yes, sir. Achha, what rationale?
So I think low-dose DEXA is a known thing that after docetaxel and ARPIs, it is known to have single-agent responses to as a single-agent therapy itself. So there are some phase 2 studies which have shown responses to endoxin plus dexamethasone. So clinical benefit. So we cannot expect a phase 3 trial at this point of time. We just want to have control for some more duration.
Fair? Okay, sir. So because for DEXA, there is a phase 3 trial, phase 3 randomized trial. And it was a surprise for me. I read a long time when we were discussing, me and Vedang. Sir, you use cyclophosphamide plus dexamethasone in your clinic, Dr. Vineet? Sometimes. Very selective. Okay. So in TMH, the OMCT is something which we use a lot. So somehow, if you keep hearing this word, this is it's a global word. It's not something invented by us, but we use a lot considering the kind of patients we choose. So what we'll do is now we'll go to some situations, which we had some discussion. But what do we do in clinic for these patients? So CRPC, MSI high. Where do you put?
There,
5%,
5%.
But it happens.
You have to give Pembro.
Pembro, everyone Pembro, everyone Pembro. Okay, so absolutely no one, no CRPC first line Pembro.
No.
But why not? So I'm saying why not? So I think colorectal cancer you want to use in first line. You want to avoid surgery also there. And I know there is a valid reason, but thought to just to make it interesting.
So many times you'll be able to, immunotherapy also comes with its share of side effects. Many times you'll be able to manage these patients with the ARPIs and docetaxel for a short time. And later, and the response rate is not that great. It's around 50 to 60%. So we are not sure whether it will definitely work for that particular patient.
Okay. Anyone else in the panel?
If PS is less, like PS is 2 or more, if a patient is frail, old, why not? We can give pembro first line if MSI is high.
Okay. Otherwise, you'll keep it.
Otherwise, we will keep it.
So way, as much you have a biological plausible reason, as a clinician, we also look for evidence. So biological, you have a label for it. FDA label is there. MSI high, any tumor you can give it. But we also have learned that MSI high in colorectal cancer, the patient behaves differently with immunotherapy as compared to other tumors. So we shouldn't be exactly extrapolating that colorectal does exceptionally well. It does exceptionally well everywhere. That's not necessarily true. Aditya, am I right? No, okay. So I'm taking validation from younger people. These are all younger drugs. So what we'll do, we'll take sorry, you wanted to say something? Some interesting situation?
You said olaparib. I don't think that is indicated. FDA approved, not FDA approved.
It was BRCA2 positive also. Yes, it was MSI high plus BRCA2 positive. So again, what you will do? I'm okay with that. I thought that discussion, but I was
some phase 1b/2 studies there, like a combination of which have been tried.
Yes, and that was the reason. So it went to molecular tumor board. So what we do at our TMH, the good thing is that you always put some blame to someone else. So we have molecular tumor board. You say, hey, it's a molecular tumor board discussion. So, and it is not in second line, it is beyond line. So we use that treatment and it worked in that patient. So wanted to highlight that, yes, it is safe to combine, that data is there. Efficacy part we can debate on for combining, but alone can be used. So you have an issue regarding if you BRCA1 positive and MSI high positive, then what do you do? That's the reason that I thought I'll put that case for. I have some another case, and that is here is positive for again BRCA1. So maybe we can have the discussion here for BRCA1 or BRCA2. Upfront positive, and there was some suggestion, and that was from our surgical oncology colleague. So if your surgical oncology colleagues tells you that systemic therapy is very important, listen to them. So why not? Why we don't want to use amplitude trial? So I heard that there's emerging data. Is there any doubt about that data? Or we want, unless the FDA tells us, we are not going to use it. But that's not what we do in India. We don't wait for FDA. Ram, why you don't want to use amplitude trial? Your, I know if I remember correctly, your hazard ratio for PFS is 0.6 or something. Maybe Aditya, you can correct me. You can just check. I know OS data is again looks like trend. That was the same primary endpoint. Based on that, we started using abiraterone, we started using enzalutamide, we started using many other, in fact, olaparib.
With quadruple regime, sir, we will be there will be concern of myelotoxicity and the toxicity.
Myelotoxic, there will be
Because there
concern.
will be
Two label, then the concern goes away.
Initially, we will start with some pinch of salt, like with some caution. Obviously, there is anemia associated with olaparib, there is myelosuppression associated with docetaxel. So there will be toxicity concerns. But with time, maybe we will, with experience, maybe some dose modifications, we will take into our clinics that regimen.
So yes, ma'am.
Eventually, if you're looking for more systemic therapy options or lutetium, if the
Yes.
patient becomes myelotoxic now itself, you'll be losing out on other treatment options at a later date.
So those concerns are there, that what happens in the future treatment. Anyone else? Sir? Okay, let me check. I have put. And I know, I have the details. I just brought I wanted to, 73 year old. This is not option. 48-year-old?
Yes.
Oh, it is option. Okay. So you won't wait for FDA label. No, I'm so like Atul, that's why I wanted to ask for Atul.
They don't tolerate triple dose after
75.
And once you don't go at PARP inhibitors for these patients, it's quite toxic.
I agree with you, sir. Modi Sahab is 70 plus.
If he has, he's not tolerant.
So why I'm saying this? Why I'm saying this? You get some. I have a patient, and that patient was, is a scientist from BRC. So 2 minutes. I'll complete in 2 minutes. I assure you. There's only one more question left from my side, and that patient insisted not on this. That was when initially you had the data came for docetaxel and abiraterone and darolutamide, and he insisted. We didn't give it. He insisted. I want it, and after discussing all across the world, and finally we gave it, and he survived, and he's doing well at this moment. Now I'm trying to convey, absolutely right what you're saying. Age is a factor, but trying to convey that once you have a data there, FDA is a label giving authority, and that is where the data interpretation is what we do it here, that I need to convince Vedang, I need to convince Dr. Vineet, and we need to convince each other and have the practice. So if you have a 48-year-old with this, I won't mind this, the data looks, because hazard ratio looks good. Another one was there, and that was again related to this for FDA, and that was for, no, this is PALB-C2, because again, was P10. There I had a patient, I think so, that I missed it. P10 positive. Anyone convinced about that data? And there's someone presented, the P10 inhibitor phase 3 randomized trial, again being positive. Ram?
I really did not ever use Capio.
I agree. Breast cancer people use it. Am I right? There's a breast cancer.
It is not available right now. So, but if it is positive, I will definitely consider using it.
Okay.
Maybe in the later lines.
At present, maybe in these patients, some platinum-based chemo and otherwise trial recruitments.
We had a situation where we used was it in trial?
Yes, sir.
One was in HSBC.
HSBC. We are running a trial capital HSBC for
Yes.
metastatic hormone system for prostate cancer. And one of that patient is surviving for more than 4 years. And his PSA is excellently behaving. And
That was based
probably
on
we are believing that is.
I agree. Yes, sir.
It was very rare.
I agree. Around 10%, that's the number, but yeah.
We only could randomize 3 patients.
So 3 patients are currently going on. They are getting the treatment and they are surviving for more than 3 years.
And capivasertib has come in HSPC without P10 loss also. Yeah, there is another fact.
That is true.
That is in the combination of abiraterone.
Abiraterone. That one was negative trial, and that gave a bit of a bad name for this drug because it was a negative trial, all comers. But looks like PTM loss. It looks like it's a positive trial, and for PTM, loss patient may come. So last comment from everyone. CRPC, some take-home message for the audience. Maybe we can start with you.
I mean, it's again, you need to personalize the treatment. The treatment should not become worse than the disease. That's the most important. Because over 75, we want to maintain the quality of life.
Totally.
Actually, also treat.
Totally agree. I have patients who have refused any treatment, so I totally agree with you. Yes.
CRPC treatment, what was slightly simple little earlier, has become more complicated, and also multiple options have come and potentially leading to better outcomes.
Older patients with a lot of comorbs, sequential therapy slowly, depending upon which it is progressing before the therapy. And for younger patients, we can start upfront with multiple combination therapies also.
Yes, ma'am.
Couple of things. So elderly age group mostly seen with prostate cancer. So burden of disease, comorbidities, performance status of the patient, then and the volume of disease to decide upon the further therapies, what is good for that particular patient, and then the response assessment can be done.
Few other point, like we should also discuss about some de-escalation of the treatment. We have given treatment, responded very well, but now with maybe indolent disease, frail patient, in some patient we may opt, after discussion obviously, some de-escalation of the treatment. And otherwise, just one point I want to ask, like about P10. So if P10 loss, we have done NGS earlier at the first go, there is P10 loss and there is BRCA also positive. So whether, because we know this is a resistance mechanism of BRCA, whether we will go for olaparib in the first line in the CRPC setting or just based on P10?
Because you have a resistance mechanism. I'll answer this question in the end. Yes.
So one thing I thought was interesting is you didn't present the whole case, but the patient was on enzalutamide and we switched it to abiraterone and there was no effect. And I think that is an old way of thinking and the more modern way of thinking about it. And we're not at an inflection point. I think we're beyond the inflection point where when somebody fails, we start using sequencing and biomarkers to identify what is the right next treatment for the patient. Is it a immunotherapy? Is it a PARP inhibitor? Is it a conventional chemotherapy? And I think that's going to continue to accelerate that marriage between biomarkers and therapy. So it won't be straight, or everybody won't be sequenced the same way.
Yeah, very similar to the others. I think there's certainly personalized and precision. At the same time, I see my colleagues, they treat, and many of you, there's an art to the medicine too. And, nuance of where the disease is, how they're progressing, the age and so forth. One concept that we didn't discuss much that we are trying to look at in the US is higher dose testosterone to resensitize to the hormonal axis. There'll be a very interesting trial that will soon launch of high dose testosterone after primary enzalutamide, maybe resensitized before secondary therapies.
Yeah, I kind of agree with Dr. Adam as to what he said. But to begin with, prostate cancer itself is an indolent disease. And the first preference should be given at the end of the day to the quality of life. And also genomics is the way to go forward. There is no doubt. Personalized care is the way to go forward. So I would like to emphasize that rather than choosing everything in the same go, maybe sequencing also would be a good option, especially with respect to performance status. And, most of them are elderly patients.
Totally agree. And we're similar like multiple myeloma. So last comment by, okay, sir. So second last comment, yes. No, sir. 80% of our patients, sir. Yes.
This is toxicity.
Uh-huh.
Financial toxicity of what we talk in US. So I think it's very important to talk about the financial toxicity of all what you are talking. That number one. Number two, by doing a bilateral orchiectomy in select patient, you save a lot of money for these patients. So these two things, in my opinion, should be considered.
Yes, sir.
No, sir, we still do bilateral orchiectomy, especially the patient who is metastatic. My advice will be you have bilateral orchiectomy because you will be saving money for the other treatment.
So 80% of our patients in TMS today also go. In fact, toxicity is financial architect. Hormonal therapy, sir. Hormonal therapy, then individual we do it. And we have a very good randomized trial this year, ASCO, comparing 250 milligram abiraterone to 1000 milligram done from Tata Hospital from our group. Another one you'll see next year being presented, 250 milligram of abiraterone versus 1000 milligram abiraterone. So you decrease the cost. So we are at TMH very cognizant, and we are in general very cognizant. Aditya, last comment that I didn't answer, BRCA positive, PTEN positive. Will you give PARP inhibitor? I said a younger person should answer. This is complicated molecular pathways. Yes. BRCA to knowing that, again, I say biology not always trumps, we get into the evidence part of it always. So we will end up giving, but I too agree with you. At heart and heart, we know there is a problem. Yes. So I think so with this, because everyone's looking after the watch. Last, madam, the last comment. Yes, go ahead.
What after progression?
Because you spoke least, so I need to have time for you. Go ahead. Yeah.
What after progression on PARP inhibitor if we use like that?
Oh, we use. So that Aditya will tell you on coffee. So thank you so much. We had such a nice discussion, and thank the panelists and thank the audience, and thank you for this opportunity, Dr. Vineet and the team. Yes.
Thank you, Dr. Kumar Prabhash. Thank you, moderators. Thank you, panelists. Thank you, chairs and speakers of this power-packed session. Ladies and gentlemen, we now move into the most anticipated moment of the conference, the SOGO oration. Orations are not just the lectures, they are a reflection of legacy and leadership. But before begin, I would have the privilege to call the chairpersons who will be guiding us through this prestigious segment. May I please request our following esteemed chairpersons to be kindly on the stage and take up their seats. Dr. Jagdish Kulkarni, consultant at Breach Candy Hospital, Mumbai. Dr. Sudhir Raval, Medical Director and Chief of Urogenital Oncology, RGCIRC. And Dr. Vedant Murthy, Professor, TMC, Mumbai. I would request Dr. Vedant Murthy to introduce our orator.
Thank you, ladies and gentlemen. It gives me great pleasure and an honor to invite my dear friend and a very cannot hear. Honor and pleasure to invite my very dear friend and colleague. Two, three exciting things about him. He lives in a beautiful island of Cyprus. And I'm sure at the end of his talk, he's going to invite all of you there. He has a hospital on top of a hill and with great views. And in that, he does great work with PSMA PET and radiotherapy and other things. And I'm not going to take too much time. His name is a mouthful, Constantino Zamboglu, but people, his colleagues, his friends call him Kostas. That is what he likes. So I request Kostas to come and deliver the fourth SOGO oration about all his work about PSMA PET and radiotherapy and other. Dr. Zamboglu.
Yeah, dear Vedang, dear faculty, thank you very, very much for inviting me to this beautiful country and to this amazing event. I've been here for 1 week and I will come back for sure. I'm really enjoying it, especially the very nice and very clever people here. So congratulations to all of you. I will talk today about PSMA PET. And by doing this talk, I faced two big obstacles. You know, we are doing this work now from 2014, starting in Freiburg, and I start to acknowledge all the people which are involved in this work from my working group, but also collaboration partners. You will see the pictures during the talk. And of course, here are 3 medical specialties, and I try to make it as much as interesting for all of you. I will try to cover primary, recurrent, and metastatic prostate cancer. And how I should do this, you know, I have 2 little girls in my home, and they really taught me on asking questions, you know, when, why, what, whatever. I think you know this business. And I try with you to travel around PSMA and to ask questions and try as best as I can to answer them. So starting with the what is PSMA? I think we have to be very, very aware of what we are imaging, and PSMA is a transmembrane molecule. It's not showing metabolism, it's a transmembrane molecule. It's involved in the folate metabolism somehow. We don't know actually the big role in cancer cells, but we know it's somehow involved in cell growth and in replication. Coming to biology, I want to emphasize that there is intralineage heterogeneity. We must know that in primary prostate cancer, but even more pronounced in the more advanced stages, it's not homogeneous. We have some patients with a lot of PSMA expressing tumors, others without, and we don't understand it yet. And even in cancers with PSMA expression, there comes physics in place. We did a nice study with our urology department in Freiburg, and we saw that the metastases, the lymph nodes need to be 2 millimeters at least so we can see them. So there's a threshold. The tumor mass has to have a certain threshold. So coming to the why do we need this? I think this is the easiest questions. We are treating physicians, we target the tumor, we want to know whether to treat, how to treat, and where to treat, and surely reliable imaging is important for this. So is PSMA PET-CT the best imaging we currently have in prostate cancer? Again, I would say this is quite easy. We have the PRO-PSMA PET trial, high-risk primary prostate cancer, showing a higher sensitivity compared to conventional imaging and a very comparable specificity. So the author said PSMA PET is the new standard of care. Coming now to the post-surgery situation, a nice trial from Jeremy Calais from UCLA, comparing prospectively in the same patient, another older PET tracer and PSMA, and again, you see a much better performance for PSMA. So I'm done, the talk is ready, we have the best imaging modality, see you soon. No, I think there are some issues we have to discuss. So, first one, we gathered together with some radiation oncologists, urologists, led by my friend Vedang. We checked the APCCC, you know, the Advanced Prostate Cancer Consensus Conferences like the United Nations of Prostate Cancer, and we checked dedicated questions on PSMA PET and radiotherapy. And just make a guess for yourself how many of them had a consensus. So how many of these 33 questions had a consensus? The result is very, very embarrassing. 75% without consensus in the APCCC, so the world-class experts. So I would say a fool with a great tool is still a fool. This was a very nice citation. Professor Martinez from the US told us in Freiburg. I learned a lot from him. So how can we tackle this? Of course, evidence. We are creating one example how we can create evidence is a global consortium called Co-Impact, 17 countries, 49 centers. We divided this project in 4 different side projects, starting from primary prostate cancer, going to the metastatic disease. Hopefully, we will collect real-world data, including clinical data and images, and soon we try to give some clinical answers. So coming now to the when and how, and let's start for, is there a role for PSMA PET in primary disease? And I want to tackle one issue. We already discussed about focal therapy. So we know primary prostate cancer, we have surgery, where's a binary situation. You have the prostate, you take the entire prostate out, right? We have the focal therapies, HIFU and so on. We can also do focal brachytherapy. Again, a binary situation. We hit the tumor, the rest we spare. In radiotherapy, we have a very nice technique, which is called focal boosting. So we can hit the tumor, but we can give lesser dose to the surrounding tissue. It's not binary, it's more a gray zone. And is this effective and safe? This was very nicely shown by colleagues from the Netherlands with a FLAME trial. You can see that they randomized between homogeneous dose to the prostate versus a focal boost, giving a higher dose to the tumor using MRI. And they showed a very nice significant DFS benefit and the same safety profile. So again, is this the end of the story? I would say no, personally. MRI has issues. Here's a nice older study from LA again. There's an underestimation of the true tumor volume by factor 3. They had whole mount sections, and MRI has a significant underestimation. And there's a large inter-observer heterogeneity. See, please, on this side, these are the centers of the FLAME trial. And in one center, the average tumor was 0.7, and in the other one, 3.3. And on the other side, if the same tumor was delineated by several radiation oncology experts, there's huge heterogeneity. The DSC of 0.6 is bad. You know, 1 is very good, and 0.6 is not what we want to have. Please remember 0.6. So now, how can PSMA PET help us? And here in Freiburg, we did the following. We wanted to answer this question, is there a role for PSMA PET imaging? What we did in 40 patients, we did an MRI and a PET. We took the prostate out, not we, but our urologist. We had a special localizer where we did an ex vivo imaging, CTs and MRI scans, and then we cut the prostate slice exactly as the localizer had the ex vivo slice. Here you can see an image from patients using ex vivo CT and MRI. And at the end, we could fuse all this information and had the information of the whole mount histology as a ground truth compared to the imaging. And here are just some of our results. Again, as you can see, PET has a larger tumor volume than MRI. And of course, the question is, who was right? How large was the tumor in the ground truth in the histology? And as you can see here, the PET is very close to the ground tumor volume with no significant differences, and again, an underestimation of the MRI. What about contouring? As you can see here, when you use manual contouring for PET to delineate the tumor, the MSC is higher, 0.8 to 0.89. So very, very less inter-observer observer variance, but it takes time, 10 minutes. We wanted to tackle this by using AI. This was just a student in my working group, but we trained very nicely neural networks based on PET images, and we've sent our networks to external experts, to Dresden and to the MGH and to Dana-Farber. And as you can see here, the DSC is between 0.8 and 0.9 between the experts and our algorithm, and it took just 2 seconds for the AI. So seeing we are dealing now with much bigger tumor volumes, the FLAME trial had around 3 milliliters. We have 10 milliliters and larger. So the question is, of course, is this feasible to delineate the tumor based on MRI and PET and to do a dose escalation? For this, we did a phase 2 trial, a non-randomized 2-arm trial called hypofocal, where we boosted using external beam radiotherapy in the one arm and brachytherapy in the other arm, HDR brachytherapy. And as you can see here now, we published the 2 years result. It was feasible, it's very safe, with a good quality of life. These results were reproduced here in India by Vedang and his team in the PROBE trial. And currently, we put these results in the big phase 3 trial recruiting. Today, we recruited the 245th patient. It's a large European trial, and we compare the standard fractionation, homogeneous whole prostate gland radiotherapy in 20 fractions versus 5 fractions of focal boost, and I'm very curious to see the results. So, and what about focal therapies? Again, it's a binary situation. We had a closer look on intermediate risk patients, again with our model, and we pooled our data with the group in China. And as you can also see here, we really miss cancer foci, and we had a closer look on the ISOP grading or Gleason grade. And as you can see down in the image, we miss significant cancers, also ISOP 3 and 4. So approximately 1/4 to 1/3 of the missed cancers were significant. Coming now in the primary stage to the lymph nodes, should we treat the lymph nodes when we don't see anything in PET? Here's a very nice property trial again from Vedang's team. Approximately 80% of these patients had PSMA PET, and they randomized between prostate only and the pelvis. And as you surely know, we had a DMFS-free survival benefit in this trial for the whole pelvis situation. So how can we explain this? I think it's quite easy. We have issues with sensitivity in PSMA PET for the lymph nodes. It's approximately just 50%. So we have to consider this by using PSMA PET. Now coming to the recurrent disease after primary treatment, I've shown you the prospective comparison coming from the UCLA, and we know here's exemplary study from Munich that it changes our treatment intent. We either de-escalate or escalate our treatment based on PSMA PET in approximately 2/3 of our patients. But of course, the question remained, is there a benefit for our patient? And can we use PSMA PET for better risk stratification? To answer this, we did the following. We had a large multi-center retrospective cohort, all treated with PSMA PET, and we matched this with the ASA-KKK trial. It's also a prospective phase 3 trial where they irradiated the prostate bed without PET. We did a quite well balancing based on several clinical parameters, over 600 patients in this comparison. And what we could find is after early, of course, follow-up, 3 years approximately, that there is an oncological benefit for the patients which were irradiated PSMA PET based. Of course, this is first evidence. The UCLA is doing a randomized trial, and I think the next 1-2 years we will have data also on this. Coming now to the risk stratification, I'm sure lots of you know the famous nomogram from Rahul Tendulkar on salvage radiotherapy, incorporating several clinical parameters. We asked ourselves, how is this working in the PSMA PET era? And as you can see here, we could reproduce more or less the same nomogram as Rahul did, but we included pelvic nodal recurrences in PET as a very strong prognostic factor. And we could increase the C index. So the Rahul nomogram had 69 C index, and we had 72 even in external validation, not only in internal. So coming now to the metastatic disease, the Oriole trial, a very nice randomized trial, not so many men, just 54 people were randomized between stereotactic radiotherapy to the METs versus observation. And I think the more important finding of this trial is when you see the patients, so you have to know all patients got the radiotherapy based on conventional imaging. So they didn't consider PSMA PET imaging, but they did an analysis afterwards, and they checked what happened to the people where all PSMA PET tumors were treated by SBRT, and these patients were much better. So when they retrospectively saw that all PSMA PET avid lesions were treated, these patients had a significant better progression-free survival. We looked a little bit deeper in the biology again. We know from a very nice review that chemotherapeutics and maybe ionizing radiation can increase the PSMA expression on the cells. We wanted to reproduce this in cell culture on a cellular level, and indeed what we observed is that external beam radiotherapy increases the PSMA level on prostate cancer cells. It's a very rapid increase, and it goes away after 24 hours. We could reproduce this in the mouse model. So we radiated just with 2 grays, and after 4 hours, because this was the best time point, we injected lutetium PSMA, and we have the feeling that it's not just an additive effect, that we saw a synergistic effect on tumor volume and even a better survival of our mice. Taking this now into the hospital, we tried a first-in-human case report. Patient 74 years old. He came with a very huge tumor in the pelvis, lymph nodes around the rectum, and we were a little bit afraid to give a very, very high dose with external beam radiotherapy. So what we did, we gave radiotherapy to the prostate, to the pelvis, and to the lymph nodes. In parallel, we gave for 2 years ADT, but we went in with 3 cycles of PSMA lutetium. And this patient amazingly was tumor-free until 2021 with no significant side effects. And afterwards, he received bone mets, and we did, of course, further procedures, and he deceased with 82 years old, maintaining a very good quality of life. I don't want to say that this is a new standard of care, but we should work on this, combining PSMA, lutetium, and radiotherapy. Coming now to the discussion you had before, I found some very nice recent data from the Netherlands that there is an ANSA flare phenomenon. So when you give enzalutamide and you quantify the PSMA as UV mean and as UV max in your patients, you see an increase in a significant amount of the lesions. And this might explain this study, also very recent, metastatic castration-resistant prostate cancers, over 100 patients. All of them had either enzalutamide or abiraterone before PSMA lutetium therapy. And there might, I say might because it was not randomized and so on, but there might be a benefit for the patients which got enzalutamide prior to PSMA lutetium. So I think this is a very interesting area of research, how to combine all these different treatments together. Another very important part, we're using PSMA PET now also for follow-up. And this is also for the academics here. We know conventional imaging is a strong surrogate parameter for overall survival. We can use this for trial endpoints in several situations. However, what we did, we pooled over 700 patients some years ago, and all of them were staged with PSMA PET. And what we see is in our study that we reach 2, 3, 4 years earlier the disease, the distance metastasis-free survival rates compared to the other studies where the patients had conventional imaging. So I would say we have to be careful. I think the biochemical resistance-free survival is more or less distant metastasis-free survival in the PSMA PET era, and we have to be very, very careful with our endpoints. Coming to the final big part of my talk, functional PSMA PET information as a biomarker. I think we are all surgeons, radiation oncologists, medical oncologists. I heard the buzzwords many times. We need prognostic and predictive biomarkers. And of course, I think to have good, especially predictive biomarkers, that it shouldn't be done randomly. We should understand what is the biology around it, behind it. And what we did several years ago in the first step, we extracted radiomic features from PSMA PET imaging, and again correlating it with whole mount histology, and we could find a very, very nice depiction of the Gleason score. And interestingly, this was even better than compared to biopsy cores. So the biopsy cores, the Gleason score and the biopsy cores was less accurate compared to whole mount histology than the PSMA PET radiomics. I think this is not surprising because PSMA PET expression is highly correlated to the Gleason score. But we also digged a little bit deeper. This is a very nice study with our proteomics core facility in Freiburg. just now published in Urology. The preprint is out soon. What we did is we did really deep into the lesions, doing mass spectrometry, doing a lot of proteomics. And what we could find, this is just one example, that distinct PET parameters like SUV max, high and low, they can characterize tumors, and also the deep biology of the tumors like proliferation, metastatic potential, and so on and so on. So a very interesting field. And this is now used in the clinics. A very nice publication coming from Australia. They showed that in the prospective therapy trial, PSMA was predictive for PSMA radioligands. I think this is not a huge surprise, but also the FDG PET, they used both PETs, was prognostic. So I think we should learn slowly to use these functional PET biomarkers. We had a small retrospective trial where we also proved this for salvage radiotherapy, that the SUV max within the prostate bed, local recurrent, is highly predictive to show us the outcomes. And we went a little more step further. Personally, I'm dreaming of individualized dose prescription. What does this mean? According to the imaging parameters, to the genetics of the patients, we should give a wholly personalized dose. And for this, we did a pilot trial in Freiburg. We used cross-fusion biopsies after PET and MRI during our HDR brachytherapy. We took the biopsies, and one part of the biopsy went to NGS sequences, and we didn't irradiate it, and the other part of the biopsy was irradiated with 4-gray ex vivo RT, and after 24 hours, we measured the residual gamma H2AX foci. This is a very good surrogate of radio resistance, of course, normalizing on several other parameters. So we checked for the intrinsic radio resistance. And what we found is that they are there's a strong heterogeneity, intertumoral heterogeneity regarding the radio resistance. Even the same patient with 2 different tumors had large differences. And very interestingly, we checked also on the PSMA PET SUV values. They were highly different between the radiosensitive and radioresistant tumors. This is just a pilot study in the first 20 patients, but we are working on it. So coming now slowly to an end, a lot of questions. Some of them were answered, some of them were not. We had a lot of work to do. And I have just 2 clinical cases just showcasing current issues we are facing. One, a male, 69 years old, very fit, no problems, Gleason 7B, PSA 11, and CT3A, just based on MRI, not based on digital rectal examination. We did a PET, because in 7B we always do a PET in Cyprus now, and we see a CN1 on PET. So conventional imaging CN0, CN1 and PET. And now is a little bit the dilemma. We have the STAMPEDE data. What would you do for the patient? And especially when you give radiotherapy, would you give abiraterone? Yes or no? I don't have in particular the answer. In these patients, we didn't give abiraterone because he had many positive factors, but of course, this is a matter of debate. Another very nice example, the same age, very fit patients. He went to the surgery, and 2 years after surgery, PSA progression, PSA is 0.3, doubling time 8 months, very high risk features, Gleason 8, PT2C, no lymph node, but PET negative. Again, the question, would you go for salvage radiotherapy? Would you go for salvage radiotherapy and ADT? Or would you just skip the radiotherapy and wait for further PSA increase and do another imaging? Again, I'm sure if I would ask 5 doctors, I would have 6 different answers. So the issue is when my daughters give me questions and I cannot answer them, I just give them an ice cream and they are happy. Here's a little bit more difficult, but I think we have lunch later onwards. And to conclude, I want to emphasize we have PSMA PET. It's a very nice new superhero in our arsenal to fight prostate cancer. One should not ignore the treating physicians. We have been there before PSMA PET. We have style. We help our patients too. I think where we have to work on is evidence, and we have to see if we can use it also as a biomarker, maybe including others like genomics or AI. So as Vedang said, there's in all my talks, it's a classical ending. Please come to Cyprus. It's a very nice island, very high quality of life, and you can have a boat trip with me. Vedang enjoyed it, as you can see here. Thank you very much.
Thank you, Dr. Zambaglu. Can we?
Thank you very much. Thank you.
Thanks so much, Chairs. Thank you, Professor. In Indian tradition, lighting the ceremonial lamp signifies the removal of darkness and spread of light, a symbol of knowledge, hope, and auspicious beginning. May I request our esteemed dignitaries to kindly come forward for the lamp lighting ceremony. I would request Dr. Sudhir Raval, Dr. Vedang Murthy, Dr. Amitabh Singh, and our guest of honor, Dr. Ganesh Gopal Krishan, for the lamp lighting ceremony. Thank you, seniors. May I request Dr. Amitabh also to please join us on the stage? May I now request our guest of honor, Dr. Ganesh Gopal Krishan, for his welcome address.
Yes, right. I should have.
Good afternoon. This is a very unusual situation that I've been faced with this morning. To welcome you and also as being the chief, as a guest of honor. I do not know to what I owe this privilege. Maybe because I've been involved with Sudhir for so many years, ever since he started his training in urology in Christian Medical College, my alma mater in Vellore. and many frequent visits to this city. I've come here to Rajiv Gandhi Cancer. I've seen it grown into a huge place for treatment of cancer in a very ethical manner, in a very cost-effective manner too. I have operated in this hospital quite a number of times. Of course, I'm an open surgery man, but I love to get my hands on the robot and use the skills that Sudhir has been transmitting to his patients. Probably I've passed that stage now, and but I still feel that it's a great tool, and I'm happy I'm in an era when I can see this. But yes, I think there's a lot of scope for such technology in our country. Uh, this is a very unusual sort of a oncology meeting, because usually as urologists we tend to be away from the radiation people and the medical oncologists. But this is one such organization where I can see that we have a group of people who are all together on the same page. We are all thinking about how we can improve the quality of life and survival of our patients with malignancy, giving them the best treatments that are available within the standards that are available within our country and within different parts of the world. And therefore, people who come from overseas will have a different view to see how patients are treated here, because we are always looking at the pocket of the patient in many of times. And you may find that many of our treatments may not actually match the book, may not match the guidelines, but so be it. As long as between you and your patient, you're happy doing what you want and you think you're doing a good job for the patient, so be it. All the very best to you, Sudhir, and to Vedang and Amitabh for organizing this meeting, and to the Rajiv Gandhi Cancer team for hosting all of us for this wonderful ceremony. Thank you very much for the honor.
Thank you so much, sir, for your kind words. May I now request Dr. Sudhir Rawal for his address.
Thank you, Charu, and good afternoon, everyone. This is the month of Shravan, which we say that month of rain. We have 4 months of rain in north, and 2 days back it was real rain as we used to have when I was kid. For 10 days, 15 days, will not be seeing the sunlight, and our clothes will not get dry because we did not have many clothes at that time, since that poverty was rule in the country after freedom. And this was in late 60s, I'm talking. We grew up with poverty, but then education and all made us, we became intellectual, knowing the whole of the world, and then earning money also. And now the situation have changed. After finishing my MBBS MS, I went to Vellore with Sir, and I was really impressed with the faculty there, with Dr. Nitin and Dr. Vishambarnath, who are also there. They are my teacher. And I came back here by serendipity. I landed up in this hospital, though I wanted to do the kidney transplant always, but my luck was written in cancer. So I was first uro-oncologist of the country in private sector and first uro-oncologist of North India. There were 3 more uro-oncologists in Mumbai. They were in TMH, Dr. Murli Kamath, legendary, Dr. Jagdish Kulkarni, and Dr. Hemant Tangavkar. And when I joined this place, Dr. Kulkarni came here to see me, that who is this guy who is MCS urology and he's doing uro-oncology. So he especially came to meet me, and he invited me for that Sogocon in Mumbai, which I could not go. And then we grew up with all conferences and all. Then a lot of young urologists, they switched over to uro-oncology, like Raghunath, Ginil, Shivasa, Gagan and all. They said, we are inspired by you because you could make career in uro-oncology in private, so we can do that. And in 2020, we had discussion with Dr. Himal and Dr. Badri and Dr. Kulkarni also to make this society. And I talked to Dr. Ganesh, and but since that time actually the pandemic came, we actually had made the society after discussion and all. And but we could not do physical meeting. Suddenly there was lockdown and everything. And then 2022, we did first uro-oncology meeting in Bangalore. Then 23, we did in Mumbai. And then 24, we were in Calcutta. And now we are in 20. This is 4th Sogocon. And when in 2005, I organized first uro-oncology conference in Lee Meridian Hospital from this hospital. That time, Lee Meridian Hotel in central Delhi, that time I called Dr. Murli Kamath And I said, sir, can you speak on, is uro-oncologist or is surgeon a prognostic factor in uro-oncology cancer? So he said, Sudhir, this is very less time and I can't speak on this, but I'll come to your meeting. So he came, and after seeing the attendance, he said, at least uro-oncology is getting established now. And this is good that you have switched over to uro-oncology. So with that, those history, now we have come now, this is fourth, and we will be having a MOU signed with SUO. That meeting I have attended many times before coming to Dallas last year. I had a friend who actually made me understand how the things are there in US. Like GUSCO, he told me this Dr. Chris Wood, he is no more here, but he was regular feature in this hospital since 2005 when he actually got introduced to me in uro-oncology conference, and finally we lost him unnecessarily. He was younger than me and I always miss him. But then in first web meeting of uro-oncology, he was our panelist, he was faculty, and we had a huge attendance, around more than 300 delegates on the web meeting. After that, but in physical meeting, he could never come. So it's a really great effort to all of my friends, and blessings of my teachers that we are here as of now, and we are going to sign a MOU with Adam Cabell and Daniel Lynn, or with the SUO. Anything we want to, shall we go ahead with the signing this thing? Yeah. So please come. Daniel.
Stays at the second and the third.
Okay.
Eight, two.
Yeah, 8-2, yeah.
Two eights.
2-8.
Eight.
No, that's okay.
Oh,
That's okay. That's okay.
Eight, ये eight कर दो ना.
Yeah.
Yeah.
Month. Yeah, that's fine. That's yeah. I can take away.
Anyway, we written it there, 2nd August in the text. So it's all
Oh, yeah, that's fine.
Two eight.
Yeah, that's fine.
No.
Okay. I was thinking about that. Yeah.
You know that.
That's okay. In the typing, in the print, it's okay.
Can I call Badri? Because he is the person who has helped me in getting this done. So,
Pretty formal. Yeah, very formal. I guess.
We get a group photo?
Yes, photo. Photo here.
You should be in the middle.
Yeah, you guys should be.
There you go.
you can come here, sir. No, we come here. Huh?
Yeah.
Oh, okay.
Here.
Come, sir.
That's a private.
Come on, sir.
This is a CEO.
My godfather.
Thank you. Oh, yeah. Better way.
May I now request Dr. Vedang and Dr. Rawal and Dr. Ganesh to felicitate Dr. Badrinath. May I now request Dr. Daniel Lin. Thank you, Dr. Daniel. May I now request Dr. Adam Cable? Thank you, sir. May I now request Dr. Ricky Fraser to please come on stage? Ricky.
Next.
Dr. Ashok Hemal. Thank you, sir. May I now request Dr. Amitabh also to please be on stage and felicitate our guest of honor, Dr. Ganesh Gopal, sir.
I wanted to do that.
Thank you so much. May I now request Dr. Nitin sir and Dr. Vishambar sir, please also to please be on stage.
I can only say a few words about both teachers. Dr. Vishambarnath, I used to call him Sherlock Holmes. He will come to know what I am doing. He will find out what I'm on up to. And Dr. Nitin was so good critic that he will speak in favor of something, and after 15 minutes, he will speak against of same thing. So
Thank you so much, sir. Thank you. Before we proceed to the end of the inaugural ceremony, we have awards for the best abstract category. And the first runner-up for this category is Dr. Aditya Dhanawat. First runner-up.
Aditya.
Do we have Dr. Aditya Dhanawat in the hall, please?
Take it. Gaurav.
The second runner-up is Dr. Mahendra Pal.
he's not
Gaurav.
Where is he gone?
He's not there. I'll take it to another.
Take it.
I was assisting him in the surgery because I can take it. Only packet खोल के ना चेक deposit भी कर लेना बैंक में.
Thank you. And for the best abstract category, the winner is Dr. Gairi Gaurav. Many congratulations.
Just for your information, Gary showed us yesterday that 3 years of ADT does not cause cognitive decline.
Not significant.
That's it. But it was really nice. Congratulations. Thank you, sir.
Thank you. Now I would request Dr. Amitabh Singh to take over the podium, our organizing secretary, for the word of thanks.
So, good afternoon, everyone. On behalf of Organizing Committee of Sogocon 2025, it's my great privilege to extend our heartfelt gratitude to all of those who have contributed in the success of program. We especially express our deepest appreciation to our chief guest Ganesh sir and the faculty from CMC Willows, whose gracious presence and inspiring address have added great dignity and meaning of this event. Our sincere thanks to the distinguished foreign speaker, Adam Kibble sir, Daniel sir. We just heard them. Now, next, we will be just hearing just after lunch, Badri sir, and tomorrow we'll be hearing Ashok Hemal sir, whose willingness to travel across borders and share their expertise has enriched the academic content and global perspective of conference. We gratefully acknowledge the invaluable guidance of Academic Council, which was headed by Dr. Gagan Prakash sir. Sir, Talwar sir hai? Okay, Talwar sir. So actually he made all the medical oncology program, and under the guidance of Dr. Gagan Prakash, me, Dr. Puneet, and from radiation oncology, I think he's not there. Okay. So with this all guidance, so we made this program successful. So we just had that idea that it should be different from other conferences. So that's why we just came up with this idea to de-intensify the treatment and how to reduce the toxicity of the treatment. And a special word of thanks to all faculty members, presenters, and delegates for their active participation and their intellectual contribution, which have brought vibrancy and depth to the discussion. Finally, we commend the dedication and tireless work of the organizing committee and support team, whose commitment behind the scenes has ensured the seamless execution of Sogocon, like especially Anju, Sam, organizing team headed by Mr. Tarun, and with the support and engagement of pharmaceutical companies, because it's not possible without their help, without their support, financial support. And with this, I would like to thank everybody just making this conference a successful conference. Thank you. Thank you, everyone.
Wow. Well done. Good.
Thank you, sir. On behalf of Sogo, I would like to request everybody to please join for the lunch in the dining area. We'll resume.
Dining area is outside.
Here.
It's not outside.
Here and there.
Outside.
We will be resuming in 1 hour and we'll continue with the academic lectures.
Thank you.
requesting everybody to please be seated. Welcome back from the lunch. This session brings together controversies, new modalities, and emerging data in urothelial cancer, from conservative approaches to immuno-oncology. May I invite the conveners for this session? Dr. Bhalachandra Kashyapi, Uro-Oncology Surgeon, Dinanath Mangeshkar Hospital, Pune. Dr. Varun Goyal, Senior Consultant, Medical Oncology, RGCIRC. For the chairing of the session, may I request Dr. Ramlesh Seth, Professor in HOD AIMS, New Delhi. Dr. Ganesh Gopalakrishnan, Professor and Senior Consultant. Dr. Simon, Senior Professor, Department of Radiation Oncology, CMC Vellore. So you can invite the first session.
Yes, Vice Chairman.
Welcome everybody after the lunch session, and I'm sure the speakers will try their best to keep you awake. So we are first beginning with a debate, and the debate is a 5 into 4 centimeter bladder tumor, Vireds plus diagnostic TURBT versus complete TURBT in view of minimizing complications of TURBT and re-TURBT. For Vireds and against Vireds. That is what the debate is. And for Vireds, Ashish Khanna is going to speak, and against Vireds, Dr. Rahul Jaina is going to speak. So I invite Dr. Ashish Khanna, who is a consultant working here in Rajiv Gandhi Cancer Hospital, and everybody here knows him. So welcome, Ashish.
Good afternoon, everybody. So in this post-lunch session, I am the first thing standing between you and your nap. So I hope in this rather unconventional side of things, I hope I can make a few points that can change something. So I'll be talking on MRI directed pathway for definitive management of bladder cancer. I am Dr. Ashish Khanna in the Department of Uro-Oncology at Rajiv Gandhi. So just to put things into perspective, a 63-year-old gentleman, I have added few details on my own, has history of gross painless hematuria, not passing any blood as of now. On ultrasound, has a 5 into 4 centimeter left lateral wall mass, and there is no hydronephrosis. So the debate is that for this 5 into 4 centimeter mass, is the path of choosing Vireds with a diagnostic biopsy of this mass the way to go? And my senior colleague, Dr. Jaina, will be talking about the conventional way of a complete TURBT. So the current therapeutic process is that you do an ultrasound, a CT scan, maybe a cytology for this patient, and then take him for maybe a flexible cystoscopy in the OPD, and then finally goes for a TURBT. So what are the issues with TURBT? This procedure, TURBT, was introduced in 1910, and almost a century has passed and nothing has changed actually. It is frequently associated with understaging, with reports of almost 40 to 50%. In about 20 to 30% patients, there would be absence of detrusor muscle in the TURBT specimen. In addition, this procedure is highly operator dependent, depending on the skill of the individual, location of the tumor, the type of tumor, whether it is a papillary tumor, sessile tumor. In addition, it is associated with additional cost to the patient. And definitely, we have seen that few of our patients do complain of the discomfort that they have in the post-operative period. So coming on to briefly about the understaging, understaging has been reported to the tune of 20 to 50%. And this data is from studies where non-muscle invasive T1 high grade have been taken up for cystectomy. And we find that they turn out to be muscle invasive in almost 20 to 40% patients. In another scenario where even despite restaged TURBT for a clinical T1 high grade tumor, which turned out to be T1 high grade on restaged TURBT also, 46% patients were muscle invasive at the time of radical cystectomy. We all know that TURBT is not an innocent procedure. There may be bladder perforation, bleeding. The patient may have to be re-explored. And again, the urethra is at injury. And we have patients who continue to shout in pain because of bladder spasms or clot retention. Is there any other difference of just doing a biopsy versus completely resecting the tumor? So I found this impactful study, although it was a retrospective study where they did a diagnostic biopsy only versus complete resection of a clinical T3, T4 disease. And this was in the pre-neoadjuvant setting. And to my surprise, that the diagnostic biopsy patients had better progression-free survival as compared to those undergoing complete resection. And this is despite that the cystoscopic biopsy was done for patients who had larger inoperable tumors. So this rings a bell. Why would this happen? And to this comes the hypothesis of circulating tumor cells. This study, which was published in the year 2010, shows that following transurethral resection of bladder tumors, there is a surge of circulating tumor cells. As can be seen, in these 6 patients, there was a surge of circulating tumor cells, and the study concluded that this rise was more so in patients with muscle-invasive bladder cancer, despite non-muscle invasive bladder cancers having higher resection times. So they hypothesized that the tumor architecture, that is the distortion of the lymphovascular space in the muscle, leads to increased percolation of tumor cells, which may reflect in the poor progression-free survival of patients who undergo a complete TURBT. And in this paper, they were able to demonstrate that although circulating tumor cells at baseline was equivalent in non-muscle invasive and muscle invasive bladder cancer patients, following TURBT, the rise of circulating tumor cells was substantially more for patients with muscle invasive bladder cancer. We all know that for a muscle invasive disease, TURBT is only diagnostic and can sometimes, because of the complications, additional costs involved, be an obstacle to the definitive management. As clinicians, we know that a delay of more than 8 weeks from diagnosis to neoadjuvant chemotherapy leads to poor survival. And data from UK and United States shows that there is a significant lag between the diagnosis, referral to the final definitive management of these patients. Importantly, the study from India also, there is one center, that is the AIIMS Rishikesh, who have reported that the initiation to neoadjuvant chemotherapy was 45 days, which is still better, but could have been even better. So I propose, and I'm going to debate about the use of image-directed pathway. This is the MRI Wirates pathway for this. The rationale of using the MRI is that we all know it has high contrast resolution, and because of its the physiology behind the MRI, it is able to differentiate between the bladder walls. Multiple studies on Wirates post 2018 have shown that there is considerable specificity of the MRI to rule out muscle invasion. At the same time, it is very sensitive, and the inter-reader agreement is also quite exceptional. So in our patient, when we are contemplating for a muscle invasive disease, my patient I'm considering would have a Wirates 4 or a Wirates 5 lesion. What would be my pathway? My pathway would be to do an MRI, and if that is suggestive of these Wirates 4 and 5, I would just maybe do a cystoscopic small biopsy and then take him up for definitive management, because my imaging is showing me that it is most probably, in all possibility, a muscle invasive bladder cancer. Do I have data to support this? Yes. There is only a single prospective study, the bladder path trial, which has shown that use of MRI directed pathway can expedite the time to correct treatment in both non-muscle invasive as well as muscle invasive bladder cancer. And the study showed that by using the MRI directed pathway, they were able to reduce the time to definitive management, which was either cystectomy or neoadjuvant chemotherapy, by a striking 30 days. Another study, which is the final concluding study that I'm going to quote, they have shown that for patients who have Wirates 5 lesion, where the possibility of extravesical disease is quite high, as the Wirates score increases, the intra and the early post-operative TURBT complications significantly rise from each Wirate category. And therefore, for patients who have Wirates 5, we may expect that around 15% of these patients may inadvertently lead to delay in their definitive management. They've also shown that inter-observer agreement is quite high, to the tune of 0.89. That makes it a good modality to use. To conclude, my opinion is that MRI-directed pathway can potentially guide management of bladder cancer patients. It may avoid TURBT, thereby reducing TURBT-associated complications, the cost toxicity, and may expedite definitive management. I have to concede that definitive learning curve and issue of feasibility, especially in the Indian setting, needs to be evaluated. So for my patient, I would definitely just take a biopsy from the tumor, if it's a Wirates 4 or 5, and take him up or offer him neoadjuvant therapy or cystectomy, whatever he chooses. Thank you very much.
Okay, Ashish, you can sit down and now Dr. Rahul Jaina, he will speak against this.
Thank you, sir. We heard a lot of hypothesis, so let's now examine the facts. So complications of TURBT, the first paper which tried to examine the complications of TURBT came out in 1980, and the latest paper was from India was somewhere in 2023. The complication rates are in the range of 6 to 14%, and 90% of all complications are Clavian grade 1 and 2. Now, this is a very important indicator. When, studies have shown that when you have a pathological T0 in the specimen of radical cystectomy, it doesn't really make a difference if that T0 was achieved by giving neoadjuvant chemotherapy or that T0 was achieved because you did a very good resection and removed all the tumor cells. Both of these subsets have the same improved overall survival and disease-free survival. So there have been multiple studies which have examined the impact of maximal endoscopic resection before cystectomy for muscle invasive urothelial bladder cancer. And they have all shown that when you have a maximal resection, the outcomes, the pathological outcomes at cystectomy are improved, which automatically translate into better cancer-related outcomes. So there was a debate in AUA this time between Dr. Daneshmand and Dr. Galsky about TMT. And although the debate is outside the purview of this discussion, what they said was that TMT will be considered to be equivalent to radical cystectomy when we prove that clinical complete response is equal to pathological complete response. So in our efforts to do this, we are striving for maximal TURBTs so that we remove all cancer cells from the bladder. So how do we propose to do that if we are proposing that let's just take a biopsy and leave it at that? If you look at studies on staging of bladder cancer on TURBTs, you will see that even today, a majority of T2 tumors, T1 tumors are understaged on TURBT. And these all lead to differing survivals. People who are understaged have worse survivals. So shouldn't our efforts be more focused on better staging rather than to just take a biopsy and leave it? How will you do a better staging? By improving the quality of your TURBT. And the quality of your TURBT will improve when you do a maximal resection. What about variant histologies? If you just take a biopsy, it is a known fact that if you have a large bladder tumor, different areas of the bladder tumor may have differing histologies. If you're just taking a biopsy of one part, aren't you risking missing out on a variant histology? Then there are certain variant histologies where you need to quantify the amount of variant histology present. For example, micropapillary carcinomas, squamous cell carcinomas, squamous differentiation, which will prognosticate the final outcome of this bladder cancer. How do we propose to do that if we just biopsy a bladder tumor? Now, so this paper has shown that how will you improve the concordance between a TURBT and radical cystectomy specimens? It is by doing a better resection. And by a better resection, they mean larger chips, more extensive resection, sample everything that you can. Now, there is a potential for hematuria. If you're leaving a mass behind, you are starting that patient on gemcitabine cisplatin. What about hematuria that can be that can happen following thrombocytopenia after chemotherapy? And then if you just leave a bladder mass inside, that can still bleed on its own, even if you're not giving him cisplatin gemcitabine. Now, I could have made an entire presentation on the pitfalls of VIRADs. That was enough. But you have to understand that I'll quote papers. So papers have shown that the learning curve for good VIRADs reporting improves after at least 100 and 150 patients. How many amongst us have access to radiologists who do VIRADs so frequently that they can accurately stage a bladder tumor on MRI? This is another such study which showed that even after, so it is a blinded study, which showed that even after 3 years of doing VIRADs, the accuracy with which VIRADs was improved or was reported was nowhere close to what the real figure was. So 26.2% were muscle invasive, which were initially reported to be 50%. After 3 years of seeing VIRADs, the same radiologist reports these in a blinded fashion as 32%. So you're still overstaging some tumors as muscle invasive. Now, this has an advantage. Now, where does this have an advantage? This has an advantage in the bladder path study, which was done in a setting by Prof. James at the Royal Marsden, where I had worked. So it was done in a setting where the time to initial consultation by a urologist, time to initial consultation for a TURBT or a cystectomy was very high. So this study, the end point was time to correct treatment. So what it proposed was that if we follow this pathway, the patients get their definitive treatment faster. It never said that the staging was better. And if we examine this study, out of the 17 patients who were said to be MIBC, 6 were not. So if we would have followed only this pathway and not confirmed non-muscle invasive nature of these tumors, we would have just done a cystectomy. And on final pathology, we'll have to explain to that patient that we have done a cystectomy for you for a non-muscle invasive disease. How do we justify that? What about resident training? It's a very common procedure for all of us. Dr. Khanna has graduated from PGI, where on an average, a resident does more than 100 TURBTs during their training. Are you going to tell your residents that if you find a large tumor, just take a biopsy and don't resect it? Where will all of these residents find a radiologist who will accurately do an MRI for them? Now, if you wear a necktie, it decreases your blood flow to the brain by 7.5%. So are you risking a stroke by wearing a necktie? In that way, if you think that a bladder tumor, a TURBT has a complication rate, it's the same. You are taking a risk by the same risk in doing a bladder TURBT as the risk you are taking by wearing a necktie. So I rest my case. Maximal TURBT is here to stay. Thank you.
Yeah. Fortunately, we are ahead of time and there is time for questions and yeah. So questions are welcome. Questions, comments are welcome.
Ashish, so the question to you first. You said you do a biopsy of this. Are you taking biopsy? You are taking started biopsy.
Everybody is here.
So that is the main area. The reason is if you are doing just biopsy to say it's a bladder cancer, that is not sufficient, because if you say it's not muscle invasive disease, how do we can give a new adjuvant therapy or systemic therapy? But not they are combined with the different protocols. So that is one issue. And secondly, as you rightly pointed out, suppose this patient wants to go for TMT. For TMT, they want to complete resect, remove the tumor completely. So these are 2 points at this point in time in my mind. So how do you?
Yes, sir. So they have actually triaged on basis of VIRADS, and they have said for a VIRADS 5 where it is obvious that it is extravesical, it is just important to take a superficial biopsy just to confirm it is a urothelial cancer. And for 3 and 4, it is imperative to biopsy a part of the tumor, taking it deep to the muscle to confirm it is muscle invasive. So that has to be done, and that is why I had the 2 images. The other thing is for TMT, complete resection, or for that matter for neoadjuvant, it was the earlier perception, and there are studies on this. I have not included, but I have read, and I'm truthful to what I'm saying, that initially they said that incomplete the resection was not possible because it was irresectable. And they found in the recent studies that when you're using the radiation, for that matter, or chemo together, it does not matter if maximal debulking is done. Although there were prior studies that have shown that maximal TURBT is the way to go, but recent studies have shown that there is no impact of leaving behind a tumor inside the bladder, just because I'm saying for patients in whom you could have actually resected, not for those in whom the tumor was such big tumors that it is unresectable. So in that subset of patients where you could have done a complete TURBT, but you have chosen not to do, the outcomes of TMT and cystectomy or neoadjuvant have been shown to be equivalent.
Actually, the major problem that I find with VIRAD scoring is, VIRAD 5 is when there is obvious perivesical extension, which can be seen on CT scan. MRI does not offer anything more than what a CT scan does, and the cost of CT scan. And most of the patients before MRI would have had a CT scan, and MRI is generally an extra investigation. The importance of MRI should be in a situation where there is a minimal muscle invasion which can be predicted on MRI and does not need a TURBT to demonstrate infiltration of the superficial muscle. If there is deep muscle involvement, if there is perivesical extension, that can be seen on a CT scan. But the MRI should be able to predict and reliably diagnose that. And that those patients are actually put in the category of VIRADS 1 and 2. They're not even put in the category of 3. So, and 1 and 2, you are in any case going to do a radical a TURBT and then demonstrate whether there is a muscle invasion or not. Only for 4, 5 you may omit, and 4, 5 is seen on CT scan. So MRI does not give you any advantage over a CT scan. Can I have one?
Or to both of you, suppose there is a tumor which is 4 centimeter or 5 centimeter around the ureteric orifice. What would you do?
Sir, as in the beginning of my talk, I said it is an unconventional path which needs more work. Obviously, at my institution, I am resecting 10 centimeter tumors also completely. So that is the conventional path I have to debate. That is why I have put in evidence in favor of what we are doing. So, as you said, it is on the ureteric orifice. I will resect it. I always resect it. And for the if there is hydronephrosis and the patient needs neoadjuvant chemotherapy, I will either stent him or put a PCN. But at the same time, it has been shown that for prediction of extravesical invasion or muscle invasive bladder cancer, the presence of hydronephrosis, VIRADS has outperformed the presence of hydronephrosis as a marker for muscle invasion. So I am still justified, I may still be justified by using this VIRAD score over the presence of the tumor on the to justify my neoadjuvant therapy or cystectomy for that matter. But as I said, in my practice, I will resect. I am resecting, but maybe it's time to change the practice if there is more strong evidence in my favor.
Okay, how many of you would leave behind a 5 into 4 centimeter bladder cancer if you can resect it completely? Raise your hands. Okay, I win.
Okay, yes, please.
The idea of not resecting at all implies that the patient is definitely going to proceed to a cystectomy. And patients don't. They might not proceed to a cystectomy because they're too ill. They have other comorbid disease. I'm not a huge fan of this, but in the United States there are, and particularly Europe, there's a lot of bladder preservation protocols where patients are getting radiation therapy in combination with chemotherapy instead of cystectomy. And last, there was great data from Memorial where patients who got a complete, now it's several decades old by Harry Erb, forgive me if I'm wrong, where if they did a complete resection for a T2 disease, like 80% of the patients, didn't require cystectomy. So I think that's one of the flaws with just going by the MRI is it assumes that everybody's going to go to a cystectomy. And I don't think that's true. I don't think it is. I guess that was more a statement than a question.
No. No, I think it's a great debate, and I think Dr. Khanna is saying what can happen in the future. But what Dr. Seth made a point, the MRI scan is only better to detect intradetrusor involvement of the cancer. For intraluminal, ultrasound is to be the best. For extraluminal, means extradetrusor, CT scan is the best. Only for the detrusor part, the MRI scan is better than CT scan. And also, I mean, like some of the paper we don't want to quote, but if the tumor is a big tumor is there and you are giving a systemic therapy with that versus tumor is reduced and then you are giving a systemic chemotherapy and afterwards you are doing. But as yeah.
That's Badri's opinion.
So another just fact, Dr. Amitabh was offering this VIRADS talk to everybody and nobody was ready to take it. So at the end it was कर लोगे तो मैंने कहा देखते हैं कर लेंगे. वो मेरे against.
No, it's a good talk.
Yes, sir.
Dr. Koneti, please. Okay, so now last comment by Dr. Koneti, then we'll go on to the next.
I just wanted to make a couple of good points. First of all, great debate, very nicely pointed out. I think this will come up later in the panel as well. I think Dr. Seth may have mentioned this. One place where maybe VIRATs can help if you've had done a pre-TOR is if you, let's say you do a TOR and you get high-grade T1 disease with or without angiolymphatic invasion or some other feature. Now, do you really need to go back and do another TOR just to get muscle? But if VIRATs is positive to suggest a deep muscle or even extravesical, then you can spare the secondary TOR. The other thing that we are missing here, if you don't do a TOR or as complete a TOR as you can, is you still have portions of tumor that you're not sampling. So you could have 30% squamous or 20% adeno or micropapillary that you're missing if you just do a biopsy of one spot in a 5-centimeter tumor. So you can get a incorrect histologic assessment and prognostic assessment. And I think that's going to be important as well.
So for the variant histology, because I was debating for a definitive management, we will get that definitive histopathology on maybe the cystectomy specimen. And for these people like those with squamous differentiation or micropapillary, any which ways you are going to give them neoadjuvant therapy, the complete management is not going to change.
Differ here. If you have a variant histology which is not responsive to neoadjuvant chemotherapy, you will go directly for a cystectomy. If you have a variant histology which is responsive to neoadjuvant, you will go for neoadjuvant. That's why it's important. I showed that in my study that you need to sample all areas to adequately quantify. For example, even if you have squamous, so you grade that according to the percentage of squamous.
Yes, yes, your points are well taken. So we have to go to the next. Good. So the debate has been good. And now the next.
Managing low recurrence in the elderly.
Managing low recurrence in the elderly, cystofulguration, intravesical ablation, and active monitoring. So there are three separate aspects to this talk. The first one will be talked about by Dr. Tarun Jindal from Kolkata.
Thank you so much, sir. Can I have my slides? So the topic given for me for the debate is feasibility of office fulguration in elderly patients who have a low risk recurrence after an MIBC. So just to put things into perspective, this is a classical index case, 84 years old male, diabetic, hypertensive, ischemic heart disease, ECOG2, had a history of 2 centimeter as well in the bladder in 2022, for which a TURBT was done and the pathology was PTA low grade. He was under cystoscopic surveillance and he was found to have, after 3 years, he was found to have a 5 millimeter papillary as well inside the bladder. The representative picture is there on your left. So what are you going to do? So the debate will probably land up to this question that how sure can you be on a visual interpretation that this is actually a low-grade recurrence or a high-grade recurrence? So this is a paper which specifically evaluated this. So your visual impression, majority of the times to the tune of around 90% is correct. So they have done a blinded study and they found that, yes, whatever the urologist believes, he's correct at least 90% of times. So yes, visually, I believe the tumor which I showed, everybody would agree that this is a low-grade recurrence. So what are the options that we have? So we have either observation, we have office fulguration, or we either go for a TURBT. So that's the point of having this debate. So why this matters? Why are we even debating? So any elderly patient who presents with, I mean, it's very common that they might have a recurrence after the primary tumor has been resected. These are elderly patients, these are frail patients, these are patients associated with so many comorbidities. To subject them to anesthesia is a task. And if they are subjected to an anesthesia, it should be done for a relevant indication. There are also cost implications associated with whatever you are doing, so that you have to be very cognizant as to what you offer to these patients. So my point is that office fulguration offers them a safe outpatient and a cost-effective alternative as compared to the other options which have been discussed in this detail. And again, if you assess by the EAU calculator, or this basically has an intermediate risk category, this falls into intermediate risk category. And if you see the stats, in the span of next 5 years, the chances of this person having a progression is approximately 5%, even lesser. So you can go conservative in these patients. And if you stratify this particular index case with the IBCG group stratification, so you find that it was a single tumor, the size was less than 3 centimeters, the recurrence happened after 2 years. So technically, this can actually be treated with a low risk criteria rather than an intermediate risk criteria. And what do the guidelines say? All the guidelines presently support, and EAUA particularly strongly supports, that if you have a low-grade recurrence in a TA tumor, you can safely offer them office fulguration. EUA has not very well defined about the size criteria, but if you go to the AUA, they have defined that if the recurrence is less than a centimeter, you can actually very well endorse a office fulguration to these patients. And what are the long-term outcomes? The long-term outcomes are right in front of you. So the chances of cancer-specific mortality in these patients is approximate 0%, and the progression is 3 to 5%. So that gives you substantial data to offer this technique to your patients. And the money also matters. So why it makes sense? Office fulguration, this is the US-based data. So the office fulguration will cost you somewhere around $1,000, while a TURBT will go up to $12,000. It avoids the risk of anesthesia, general anesthesia, or spinal, whatever anesthesia you offer. It's an outdoor procedure. Hospitalization is not required. The recovery is technically in a day or a couple of hours. And it avoids the complications of TURBT, which howsoever less are certainly there. The ideal candidate profile, age more than 70 years, ECOG 0 to 2, a solitary tumor, or 1 or 2 tumors. All the tumors have to be less than 2 centimeters in size. There should be no associated CIS, and the anesthesia risk has to be higher. How it's done in a very simple manner. You do a lignocaine gel instillation, you give some oral analgesics, you can give some sedation. With the help of a cystoscope or a Bugbee electrode or a laser, you can ablate the tumor. The entire duration is approximately 10 to 15 minutes at the max. The risk of complications are minuscule. So to conclude, it's a safe, simple, and cost-effective method, specifically in the scenarios which I have quoted. It is more suited towards elderly patients who have a low-risk recurrence and pose an anesthesia risk. Thank you so much.
Thank you, Tarun. Anybody has any comments on this? We do have a little bit of time. After all three. Can we ask Dr. Saurabh Patil to speak to us about intravesical ablation?
Good afternoon, everyone. I think maximum evidence is with Dr. Tarun, but let's see for what the future holds. I will be speaking about intravesical chemoablation. So what we all are discussing here, we are actually discussing about the ways to treat low risk bladder, intermediate risk cancers. And we all are debating against TURBT. So we are trying to avoid the risk of TURBT. We have to understand the disease here. The disease is not all intermediate risk are similar. What we feel or think as an innocent disease could have progression, recurrence or progression. That's why the IBCG substratified this intermediate risk into 3 risk groups depending upon the number of lesions, the recurrence, and the number and the size of the tumors. So what it is important for prognostication, because the risk of recurrence and progression is different in all these 3 subtypes of intermediate risk groups. What are the treatment recommendation? Again, if we focus on the IBCG recommendations, they have said almost everything. But the bottom line here is some treatment required. So active surveillance, it does have some problem in form of compliance. Severe anxiety, imagine somebody having bladder cancer inside, even if he is elderly. Again, it's a matter of great caution. And strict cystoscopies every 3 monthly. Chemoablation, is it new concept? No. Almost a decade ago, Dr. Briganti, who was interested in bladder cancer at that time, they did a RCT with same low-grade recurrent intermediate risk group. And they tried some intensive form of MMC thrice weekly for 2 weeks versus standard chemotherapy, standard MMC induction. And they did it before TUR to see what is the effect of this MMC in the cystoscopy. And they found out that in spite of giving extra dose, it was safe, much tolerable, less of toxicity, and the complete remission or the complete response was better in the intensive dose. Again, couple of good quality data was published in next few years. This is a single non-randomized comparative study by the Italian group, where they studied the same group, same intensification dose, and compared it with TURBT followed by induction MMC, and again found out it to be comparable. Like again, we are comparing non-TURBT, non-resection versus complete resection. So it has to be inferior, but again, it was similar in this study. toxicities were same in spite of having double dose, and no patient discontinued the treatment because of the toxicity. Dablakla study, we all know this, published in 2023 in JCO. Again, they included high-grade lesions, same risk of group, high-grade also included, and they studied it for median 34 months. They wanted to see how many people required intervention at the end of 2 years, and they found out that there were fewer patients requiring re-TURBT or the interventions in the intensive MMC group versus the standard TURBT arm. Recurrence-free survival was also comparable. Now, this could be the game changer. This is a new molecule, same MMC in the dose of 75 mg. And it's a formulation with RT gel. Basically, it is a liquid in the normal temperature. When it goes inside body, it forms a gel, and it sticks to the bladder mucosa, and over maybe 6 or 8 hours, it delivers a controlled drug formulation, improving the efficacy. We have very good two comparative trials published recently in 2023 and 2025, Atlas and Envision trial, where the same risk group were studied, and 6 weekly doses of this UGN 102 with 75 mitomycin was given versus TURBT. Complete remission was equivalent. Patient achieving this complete remission at 3 months after UGN, they have very good durability response at the end of 1 year. And the probability of disease-free survival after 12 months from the TURBT was better with UGN compared to standard TURBT arm. Again, adverse effects were there, more in UGN expected. Initial 3 months, they were more. As the duration advanced, then with time it reduced. And with treatment, the side effects were very less. Discontinuation because of treatment or MMC was hardly less than 5%. Recent study, ongoing study, started in 2025. After 5 years, final result will be published. These are the interim results by the same group, Neil Shore and group. They studied same 6 weeks UGN against, only 6 doses of UGN at the dose of 75 mg. And they found out that complete remission was in the tune of 80%. Again, durability of this response was 80 to 82%. Side effects were more than 50%, but again, manageable with medicines. Discontinuation was hardly 3%. So they concluded that this UGN molecule is very well tolerated and causes meaningful complete remission and good durability response in this subset of people. What are the learnings? Risk stratification is very important. Not all these are similar looking cancers. Intravesical chemoablation, we have very good evidence right now, maybe not in the guidelines in 2025, but these newer formulations have very promising role, and it's just a matter of time that guidelines will incorporate this drug into the guidelines. And what are we treating elderly? Like Dr. Tarun said, maybe 83-year-old, 70-year-old, who are these elderly? What we think as for survival, they are thinking something different. This is Al Pacino with his current girlfriend, not wife. So these are heterogeneous, definitely heterogeneous group of people, very difficult to treat. Thank you so much.
Dr. Ashwin Tamhamkar.
Good afternoon all. Yeah, can I have the presentation on? So I'm going to start the talk by remembering Professor Willett Whitmore here, because the surveillance policy, of course, came in from Whitmore's aphorism. All of us know about it. Of course, it was for prostate cancer, and he lived his entire life into managing oncology and especially the prostate cancers. And the journey actually started with bilateral adrenalectomies, which he used to do, and then later he had gone into the phase of active surveillance after living the entire life, because he had enough experience to get those vibes across. Now, when I apply that mathematics for bladder cancer in an elderly individual, it asked me the same question: is cure necessary when possible? We are talking about the same thing here in an elderly individual. And points in favor of the hypothesis are probably it avoids risk of the procedure complications, which previous colleagues have elaborated, reduces the cost, especially in settings like NHS or something where you have a treatment burden associated cost. minimizes recurrence, or the chances of recurrence, progression, and survival are pretty much acceptable. They are not bad because this is a low grade disease or a febrile biology disease. It's a patient centric approach and ultimately reduces the over treatment. Of course, there'll be some concerns about just observation because you're seeing a tumor and you're not treating it at all. Diagnostic uncertainty, high grade suspicion, missed progression, and anxiety of tumor being in situ, and that translates into sometimes patient preference for knocking off the tumor as well. Now the expectant management actually started with Professor Soloveitch's studies, where there was limited number of patients who were observed for this. Two good figures from that paper: average growth rate, which we talk about these growth rates in kidney tumors always, so something similar, 1.7 millimeters a month. That's the average growth rate, and nearly it takes 13 months for a new lesion to develop in a low grade disease. So these are two important figures, wherein you are not touching upon the patient by any surgery, not any major anesthesia or any other consequences. These are some studies of patients with active surveillance on bladder cancer monitoring. Of course, the numbers are limited. You won't have large numbers. You can't have comparative studies here. But the point to be taken here is very few out of those progress actually to muscle invasive high grade later. The similar thing, which is Italian study of bladder cancer, Italian active surveillance bias experience, where they have nearly 50% patients requiring subsequent interventions, which they called it as failure. But interesting to know, out of that, 20% were benign, or less than 10% were high grade, and less than 1% were muscle invasive. So that was, and at a meaningful follow. The treatment-free probability rate at 12 months, 1 year, was about 60%, and 3 years was 40%, which means 40% patients did not require any treatment under anesthesia or a procedure when they were monitored for a tumor. Typically, the failures were happening more for patients with multiple lesions and a frequent associated tumor, as in frequent tumors. Good part, again, the last statistics, muscle invasive disease was only less than 1%. That's important. IBCG group, people have quoted this. They have risk stratification, and based on that, they take it forward for the understanding. There is a Japanese group which has actually told how to do the surveillance for these patients. So 3 to 6 monthly cytologies and cystoscopies. That's the plan. And you convert that when the appearance of a lesion changes to little high grade potentially. That's a observer find, intra-observer finding. When patient develops a hematuria, lesion crosses more than 10 millimeter, or the size of number of lesions increase more than 5. These are the pointers to be, or the cytology turns out to be positive. Sort of quoted about this study, but of course the limitation is it's a new one, so you don't have long-term outcomes. Probably in another couple of years, the evidence will get a little more mature. Now, when I see this, it's basically something similar to intermediate risk stratification of a bladder cancer. You have a recurrent disease in a known low-risk cancer. Then it gives me a stratification by IBCG group, wherein it will stratify the individual based on multifocality, size, early recurrences, frequent recurrences, and failure of prior therapy. Based on that, if you have more than 3 risk factors, probably I would not observe. But if you have low or intermediate risk, intermediate group, I can potentially consider for an observation. So that's my ideal patient of active surveillance, who is an elderly, biologically, as Saurabh said, probably biologically, who may not be able to father a child at that point of time, less than 5 lesions, more than 1 recurrences, which is not very early, less than 1 per year recurrence, which is not frequent. He is treatment naive. There is no chemotherapy being taken. Asymptomatic, no hematuria has happened, and he understands the nuances well, compliant, and especially non-smoker there, because there is a small association of active smoking with progression and recurrences as well. Most importantly, that patient probably would have ran the chat GPT before coming to the clinic and asked the question himself, what's my risk of dying of bladder cancer at 15 years when I have a low risk? And the chat GPT tells him that it's less than 1%. Then at that point of time, if he comes to me, I would probably sink in and say, okay, let's observe. So last thing, that's probably me after 20 years from now. Again, I ran the chat GPT before coming here. So probably what I would say today, I'll do an TURBT, but after 20 years, maybe I will go on a side of observation. I would have had enough experience on this particular domain. Thank you so much.
20 years down the line, you will do it. You will not do it today.
Probably yes.
Probably
yes.
So you have answered.
Yes.
Okay.
I want to raise a poser. You have these elderly patients. Would you strictly follow this protocol of 3 monthly checks and all that, or just say once in a year or once in 2 years?
So practically speaking, we don't do this lot because if
Why not?
So even at 80, there's a contradictory statement here, because even for MIBC, the guidelines say if the patient is fit at 80, do a cystectomy, then why not TURBT? I'm debating myself, unfortunately. I'm giving a hypothesis against what I just said. But then no harm in doing a cystoscopy is at least
It's still
6
painful, whether you say flexible and all, these elderly 82s and all coming. I live in a city where there are about 10 old age homes, and I get patients like this.
Correct.
And they don't,
So 6
they don't
monthly
like
would be a
coming.
good bait.
They don't like coming at all.
Yes, sir. So maybe 6 monthly would be a good bait, sir.
Why not 1 year, 5 millimeters? This guy said that Mark Soloway, I remember attending that session.
Yes.
He said, I don't even bother to tell the guy he's got a 2 millimeter tumor. I just said, go home.
Yes, I completely agree, sir. Yes. So that interval is cannot be defined precisely. It all depends upon the patient to patient experience.
Yes,
Actually,
Jagdish?
with the travel or trauma and coming to the hospital, that is more than.
They might have a fall or fracture. A lot of things actually count into picture.
Yes, Jagdish?
One of the practical problems in old age people, they are on blood thinners, antiplatelet. So all these things ultimately bleed and they go in sometimes in emergency, which may be difficult at all management. So I think how do we manage that kind of thing?
So that's a challenging situation, because in that particular context, doing a clot evacuation, compromised vision, you may end up with perforations and stuff. So
I'm saying, so
it's always better to knock off. So at this point of time, today I will say yes. I don't know what happens after 20 years. So yes.
See, sir, in practice, we all are following mainly observation because these are more than 80 or 80 plus, less than 5 millimeter. We do fulgurate, we do TURBTs, but then we have to counsel them accordingly because anxiety is too much. Keeping a tumor inside has a great anxiety, but less than 5 millimeter tumor, single tumor, yes, I think observation is the way.
Maybe if you have not done a cystoscopy and if you have picked it up on ultrasonogram and the patient is not on anticoagulants, then maybe you can follow up. That can be the only special situation. But if you have done a cystoscopy, and then how much more are you going to do by fulgurating?
I mean, I exactly agree. I mean, if you're just doing a cystoscopy and seeing the tumor and coming out and then telling the patient that you have a tumor inside, I think that doesn't make sense either ways. It just takes another 5 minutes for you to fulgurate that tumor. Because as sir said, that majority of these patients are on anticoagulants. You do a 5-minute job, and I think that the risk of bleeding also comes down. The risk of reinterventions comes down. And as sir said, I would probably after that increase the time of cystoscopy rather than doing it more frequently.
Can I just ask
The presence of a flexiscope and a laser makes the small fulguration very much more attractive than actually passing a resectoscope inside and resecting, and or even using a bug bee.
Okay, Sanjay.
Yes.
Could you do intravesical mitomycin ideal after ablation? Then you combine Saurabh and you.
That's a gel.
We'll put in a gel.
No, but that is yet not available. I hope debate is over and then I can go this way. It is not yet available in India. It is very much costly, around 1 lakh.
Talking about traditional mitomycin, I
Okay.
ablate and then I put a
No harm.
catheter in the
Yes, we all do it. We all do it.
Thank
you.
Yeah, Dr. Nitin. Older patients.
Cystoscopies.
Which goes to the general practitioner is if they develop symptoms. So the people who develop hematuria are seen. Otherwise, because the longevity is there, but low-grade tumors at that age unlikely. And so if you scope, I think what you said is right. So as well as take a bug bee and fulgurate it. But why to scope is a question. So I think the most of the advice usually is only symptomatic follow-up so that you don't encounter this situation.
Thank you very much. So that has been a very interesting debate. And now we have a special.
Now my pleasure to call our good friend, Dr. Badrinath Koneti, to speak on managing high-risk NMI-BC beyond BCG in 2025, maybe 2028, 29. I might have the pleasure of introducing Badri to you all again. He's the president of the Alina Health Center Institute and the chief academic officer at the Alina Health System and regional dean at the Idaho College of Osteopathic Medicine and a professor of urology at the University of Minnesota. Stage is yours, Badri.
Thank you all. I appreciate it. Thank you again for the invitation to be here with a couple of my good friends from the SUO as well. And thank you, Sudhir, for engaging with the SUO and making this a nice collaborative occasion for us. I looked at the theme of this conference and it said de-escalation of therapy. I'm not sure exactly how this fits in because this is either is escalation of therapy. If you look at it from the point of view of what we're doing right now, we're just giving BCG or mitomycin. Now we're coming up with all these new treatments that add on top of BCG. It is also escalation of costs. So perhaps the only de-escalation component is you're de-escalating from cystectomy as opposed to going full bore in the management of these patients. So these are my disclosures. Just so we understand and are on the same page about what is BCG unresponsive disease, and that's the FDA approved definition. It's persistence or recurrent CIS alone or with or without Ta/T1 disease or papillary disease within 12 months of completion of adequate BCG therapy. And adequate BCG therapy is defined as either 2 full induction courses or 1 full induction course and at least 2 of 3 of the first set of maintenance BCG. And of course, if you have recurrent high-grade papillary disease within 6 months of completion of adequate BCG and anything else that's BCG refractory. We also throw in BCG intolerant patients into this group. A whole bunch of different treatments have been tried in these patients who cannot seem to either tolerate BCG or respond to BCG. And this is the cornucopia of treatments. Some are devices, heated MMC. We've done radiofrequency-induced treatment, thermochemotherapy, valrubicin, BCG interferon. All sorts of things have been tried, but none of them really worked. None of them have gotten FDA approval except for valrubicin, which today probably would not get approved because its response rate was 7% at 1 year. So it's really a useless drug, in my opinion. So these are the emerging treatments for non-muscle invasive bladder cancer in different settings. Mostly everybody is going after the BCG unresponsive setting because the FDA has approved single-arm trials for registration and FDA approval. So that's very unusual, but most often you have to compare with either a control arm or another treatment arm. So that's why every company that's in this space is first trying to identify the 100 patients who have BCG unresponsive disease and try to establish that this drug works in that group before getting FDA approval. And then they move it up the chain to intermediate risk disease or BCG naive disease. So the systemic therapies, surprisingly, Pembro was the first one that got approved in this setting. And more recently, there have been some BCG enhancers, I call them, sasanlimab and durvalumab. They're both being reported out between this year and next year. At least 3 and more gene therapies have been tried, and we'll go over some of these. And then devices, gels, I think we already heard about the mitogel that's been FDA approved. And then there's sundry other treatments that we'll go into in some minor detail. The Pembro was the first systemic therapy in the new generation of drugs for BCG unresponsive disease that got approved. And in this, they had 2 cohorts in this Keynote 057 trial. Cohort A was CIS plus minus papillary, and cohort B was papillary only. And interestingly, complete response was defined as absence of high-grade disease at 6 months. So if you had low-grade disease, that did not count. You just should not, the patient should not have high-grade disease at 6 months and was considered a complete responder. So in the Pembro trial, patients got Pembro every 3 weeks for a total of 2 years, and about 40% of them had a complete response at 6 months. And when you went out to 1 year, about half of that 40%, or about 21%, retained their complete response. And at 36 months, now we're just reporting the trial out of we submitted our abstract to the SUO just today, and it suggests at 6 years worth of follow-up, you have about 20% or so patients who are maintaining this complete response. So there's some subset, 1 in 5 patients will be long-term responders and avoid cystectomies. And those who do go on to get cystectomy, very few will have aggressive disease. Of 44 patients in this trial who went on to get a cystectomy, only 2 had T3 disease and 1 had node-positive disease. So generally, even though you don't do the cystectomy early, it's still safe to put them through this therapy and you're not compromising anything. But side effects are obviously quite high. Nadofaragene is the other FDA-approved drug, was the second one, kid on the block, if you will. It's a gene therapy. It really involves a gene that's in an adenoviral vector that produces interferon locally. The unique thing about this is it also has a gene for SYN3, which is a detergent, which allows the virus to attach to the bladder mucosa or the urothelium and then allows for viral replication and production of local interferon. Yeah, if you remember, there were trials previously using just interferon into the bladder, but that did not last long because interferon gets metabolized very quickly. So this is a much better way to retain some local production of interferon. And again, response rates at 6 months, about 42%, and it's about half of them will retain it at 1 year. And at 5 years, we have reported out on the 5-year data on this trial, 13% will retain the response. So really only about 1 in 10 will retain long-term response. The third one that got FDA approved is nogapendakin in Bacicept. If you can say that fast, I will give you $10. But it's one of those, it's called N803 or Alt803, and it's a BCG enhancer. So you need BCG with this. Interestingly, the Quilt trial actually had 3 arms. The cohort A was just like everything else, CIS plus minus papillary disease, just high-grade papillary disease. And in the patients who had CIS plus papillary disease, they tried to use just the new drug. This drug actually is a IL-15 super agonist. What it does, it increases local production of IL-15 in the bladder, which enhances the immune response elicited by BCG and increased killer cell activity. So just giving the drug alone will not help. You need to use it with the BCG, and they have cohort A and cohort B, and both of them showed good response of about 70%. So you see the response went from 40 to now 70%. And at 12 months, almost the same number, about 69% retained the response. It did decay over time, 2 years and 3 years, but still about at 2 years, 50% of patients retained their response. So the response rate is much better with this combination therapy. Interestingly, women and those who had to have reinduction of treatment, if the first 6 weeks didn't work, they have to go back again for another 6 weeks. They did not respond as well as those who responded right off the bat. And cohort B had very similar outcomes. One thing to point out that I didn't mention earlier is with nadofaragene, interestingly, papillary disease responds much better than CIS, and same is true for nogapendakin as well. The other drug that is now on fast track approval at the FDA is cretostimogene, which is a gene therapy agent. It actually selectively, it's an adenoviral vector that contains a gene with an E2F promoter, and it specifically attaches using the CAR receptor, which is present widely in the urothelium and gets internalized. And basically the way it kills the cell is the virus starts replicating very fast because of the E2F promotion. So the E2F promoter is missing in many bladder cancer cells because they all miss the retinoblastoma gene, and E2F pathway is deactivated. By replacing that, it allows this virus to replicate very fast. So it basically swells the cell and makes it burst. So it literally is a mechanical destruction of the cell. And then when it bursts, it also has a gene for GM-CSF, which augments local immune response. So it's a pretty complicated set of things that occur. But the effect is quite dramatic. Again, about 75% complete response at 6 months, which is maintained in about 50% of all patients. Almost 2/3 of the patients who respond maintain the response at 12 months, and about 1/3 of them maintain it at 2 years. So really, again, you're getting to the second generation of these agents, which are all in the 70% response range. Detalimogene is another gene therapy agent, which uses a gene that the delivery method is different. Here, you don't use a virus. Here, you use liposomes, and the liposome contains double-stranded DNA, which actually stimulates the RIG pathway, retinoic acid-inducible genes, which augment immune response. It also has IL-2. So again, all of this is immune-targeted. It recruits local immune response and increases response of the tissues to natural killer cells. This is a very exciting gene therapy because they just had phase 1 data released, which suggested at 6 months, the response was about 60% in all comers at the highest dose level. They are just launching their phase 3 study. It's underway in multiple countries right now. It's called the LEGEND study, so we'll wait to see what the data says. Many of you may have heard or known about this drug called, or device really, that contains a drug, which is gemcitabine. It's called TAR-200, and it's called the pretzel in common parlance. It really is a polymer tube that is twisted on itself, and it's straight, and then you cystoscopically insert it into the bladder, and it automatically twists into this pretzel-like form, and it contains an osmotic element, and it also contains gemcitabine. So the inside of this tube absorbs the urine and then slowly pushes out the gemcitabine. So the gemcitabine slowly gets released over 3 weeks. And they started doing these studies in patients who had advanced bladder cancer, muscle invasive disease, who are not candidates for cystectomy, and they showed partial response. So that's how they decided to take it upstream and use it in non-muscle invasive bladder cancer. And this is a 3-arm study that Sunrise 1, that is the registration trial for this device. So they've used the device with a IO or checkpoint inhibitor called sertralimab. They've used the device alone, and then they've used the sertralimab or the checkpoint inhibitor alone. The checkpoint inhibitor alone did not work, so they stopped that arm. And when you compare the other two, it looks like adding the checkpoint inhibitor doesn't do anything. And this is data from ESMO last year, and this year at the AUA, they presented the same, the updated version of these data. And the complete response is pretty much the same. It's about 83% or so in these patients. And many of them, over 50%, will retain their response. So this is actually even better than Credo, better than Nogopendakin. So this is almost becoming, generation 3 of the drug. The only pain with this device is you have to replace it every 3 months, and you can do that up to 6 months. And then after that, if they're completely responding, you can go to once every 3 months. But so it's a lot of cystoscopies, which patients may or may not like. Then the other set of drugs that are coming to being is targeted therapy. So TOR2 was a trial that looked to seeing if patients who had FGFR mutations, if you treated them with erdafitinib, which is a FGFR targeting agent that's been used in advanced disease and many other cancers, including urothelial cancer. It's actually FDA approved for treatment of metastatic urothelial carcinoma. You're just using this in the context of NMIBC. And this is a trial that Jim Caro did in Sheffield, where they compared the oral erdafitinib. So that's the one advantage. This is the only oral drug as opposed to IV or intravesical. And they compared it to dealer's choice intravesical chemotherapy. And the results were dramatic. There was a 30+% improvement in response by using oral erdafitinib. But this is only for patients who have FGFR mutations. Low-grade and intermediate-risk bladder cancers, 50 to 60% or more of these patients will have FGFR mutations. High-grade disease, probably not so much. CIS, not so much. So this is really more pertinent to early-stage, lower-grade disease, if you will. The downside is the side effect profile of erdafitinib is really bad. I have patients who have nail changes, hyperphosphatemia that they cannot tolerate, but there are more targeted FGFR inhibitors coming, which only target FGFR2, not PAN inhibitors that are much better tolerated. So I think watch this space. This is really going to get exciting in the near future. TAR-210 seeks to take the concept of instead of putting the erdafitinib by mouth, they put it into their pretzel and you can put it into the bladder. And that does seem to work well in the phase 1 study with very high response rates of 80+%. There is an ongoing trial, Moonrise 1, that is using the pretzel device, which has erdafitinib. You can put it into the bladder in patients who have FGFR mutations. The advantage is you avoid the systemic toxicity. And the other advantage is you only need to replace the pretzel every 3 months, as opposed to every 3 weeks with the gemcitabine. So that's the advantage of this. So in select patients, this may be a great option. This is just a quick comparison of all the data out there, and I will give you a little more synopsis. The only thing I wanted to point out here was the bar for getting a new drug approved by the FDA in BCG unresponsive disease is pretty low. So you just need to have a complete response rate of 40%. You need to have a 12-month disease-free survival rate of 30%. And almost all of these drugs have met it so far, and that's why they've got FDA approval. And if you look overall as to what is happening in this space, the first generation of these drugs got about a 40% complete response. Second generation, 70% plus response. Duration of response has gone from 20 to 50%. And in device-based treatments like TAR, or targeted treatments with using FGFR inhibitors, the complete response can go to 80% or so. The systemic IO still remains to be seen what value they add, especially because they have much higher levels of toxicity. And I would say in my experience, the gene-related therapies seem to have the least intense schedule and toxicity, especially nadofaragene. You only need to give them 1 instillation every 3 months. So it really is much better tolerated by the patient, and the intensity of treatment is much lower. Couple of quick words about BCG naive setting or where you cannot use BCG. I won't go into details about the Atlas study that was just talked about, as well as the Envision trial, except to point out some of the issues. This was a trial that compared patients who just got TURBT to getting neoadjuvant mitogel. And if they did not respond, you did a completion TURBT in those patients. And clearly there was a significant difference in response and in disease-free survival between the two groups. But the Atlas trial did not complete its enrollment. So it really was not powered to get results with 282 patients. And none of the patients who got TUR got post-TUR chemo installation. If every one of them had got post-TUR chemo installation, then maybe 20% of them would have, the recurrence rate would have come down by 20%, which have been a fairer comparison. Because really what you're trying to say is neoadjuvant mitomycin better than adjuvant mitomycin, and we really don't know. Gemcitabine docetaxel, maybe many of you are using this. This sets a high bar for us to meet in early stage disease as well as in more aggressive high-grade disease. 89% complete response rates, which is maintained at 6 months in most of the patients who do respond. So it's a pretty good drug combination, well tolerated. And we're waiting for the phase 3 bridge trial, which is in BCG naive patients to see what happens. And the trial is finished accruing 870 patients. We're just waiting for the data readout at 2 years. Last 2 trials that I want to highlight. POTOMAC is a trial that is bringing in the idea of using systemic durvalumab along with BCG maintenance. So these next 2 trials really are BCG enhancing trials. If you have BCG shortage, you cannot use these approaches, obviously. But in this trial, they are comparing BCG induction and maintenance, standard, versus BCG induction, maintenance, and durvalumab, and BCG induction only and durvalumab, trying to see whether you can skip maintenance by adding systemic IO, and disease-free survival is a primary endpoint. The data is not yet reported out. Hopefully, it will be this year at ESMO. I talked to the PI who I know well, who mentioned that at 1 year, all of these patients, it looks like they all need maintenance. So the arm that really responded best was the one that got Durva, BCG with maintenance. They did better than BCG plus maintenance. And there was no difference if you took away the maintenance therapy. And induction did not help. The CREST trial is the last one I'll bring up. This one actually used a different drug, a systemic therapy, sasanlimab, along with BCG induction maintenance, versus in the same concept, BCG induction plus maintenance, BCG induction plus IO, or BCG induction maintenance and IO. And again, the combination of BCG induction, maintenance therapy, and sasanlimab did much better. One key thing here, sasanlimab is a subcutaneous checkpoint inhibitor, so it's going to change how we administer these drugs because all of them are now going to change to subcutaneous. And if you look at it, there's about a 7% difference. Is it worth the extra drug therapy and the cost? I will leave that to everyone to judge. Again, there's a plethora of trials in this space in BCG naive and BCG unresponsive setting. So lots of activity, and there's not enough time to discuss all of them. So BCG shortage has prompted search for alternatives. Gemdosi appears to really work well, so we need to make sure we hold everything up to the same standard, and it's cheap. The therapies work differently by disease type. CIS, something may respond better. TAT1, something else may work better. And primary chemoablation, maybe it is a real thing. We'll have to wait and see. BCG augmentation does appear to work, but maintenance of with BCG is required. And what about maintenance use of these novel drugs? Many, such as cretostimogene, you have maintenance for 2 years. It's a gene therapy. It is not BCG. Why do we have to use 6 weeks of this or every 3-month boosters? We have no idea. So, but the companies are not asking those questions because each dose costs between $35,000 and $60,000. So I don't think they're going to be asking that question anytime soon either. So thank you very much.
Thank you very much, Dr. Badri, for that very exhaustive and very elaborate presentation of what the status is today of BCG in bladder cancer. We have time for a question.
Yeah, we have, because he has time, another 6 minutes. So in a country like India, where BCG shortage is not an issue, what would be your main messages to the...
So I guess if in BCG non-responders or BCG intolerant patients, to be honest, I would frankly use gemcitabine docetaxel. It's cheap, it's easily available. All these others are, hard to get and much more expensive. If that's not an option, or if you fail gemdosi, then you really have to think about which ones of these. And there maybe BCG enhancement may be something to think about in those patients.
And in all these studies, what percentage of patients had carcinoma in situ, and what percent, when you talked about complete response?
Yeah.
So were you talking about complete response to carcinoma in situ or to active TA disease or T1 disease? Because you had three categories, TA, T1 and carcinoma in situ.
So that's a great question and a really good nuanced point to bring out. So the endpoint is complete response only for CIS. So for papillary disease, as you say, it makes no sense to look at complete response because when you do TOR, that is the complete response already. So in those cases, event-free survival or disease-free survival is what they're looking at. And generally if you look at the total populations of cohorts, cohort A of 100 patients roughly in each of these trials, everybody had to have CIS and plus papillary disease. And most of the trials in cohort B, which included only papillary without CIS, the numbers were between 50 and 100 patients. So we're not talking about exhaustive numbers, but that's and then when you look overall in BCG naive patients, about 26% of those, 20 to 30% of those patients will have CIS, but almost most others will have papillary disease as well.
At International Oncology meeting, Dr. Raghunath will remember 23rd we had gone to Germany. There was a guy from Argentina, he talked about imucothel, which is actually seaweed, and they had created a drug from that. And he had shown BCG failure patients had done very well. In fact, there are also some patients who were BCG naive. Imucothel. Have you heard about that kind of?
Well, actually, there's some data a long time ago. Don Lamb had been experimenting with this too, and it did seem to have some effect, but never really has taken off. And I've not seen any other trials in it, but it's been known for.
Yeah, that has been reported very transiently. Badri, what is your protocol for, say, basically we are getting, because of the shortage of the BCG, we are giving a gemcitabine docetaxel. So for intermediate risk, we are giving monthly for a year. For high risk, we are giving monthly for 2 years. Now I have a couple of cases. We have given induction BCG, failed. We put on gemcitabine docetaxel that worked for some time. Now they failed after maintenance. So what do you think for these kind of cases?
So if the patient had CIS and if they they recur with CIS after a 2-year gap, then you can re-challenge them with BCG because it does seem that if, for whatever magical reason, if you have a gap of 2 years or more with CIS alone, they behave like a new tumor altogether. They don't really have a resistance at that point.
I have two questions. One is, do we have a maintenance schedule for gemdosi? Because we have up to 1 year. After that, we are not. And we have been comparing a 3-year maintenance schedule for BCG vis-a-vis a 1-year schedule for gemdosi because we are observing, at least most of us are observing that at least by 2.5 years, we are finding failures with gemdosi. Question one. Question two, for some weird reason, in Indian population, I'll just look at others as well, we are not finding that many CIS here. Most of our population is just G3, T1, T2, T1 or TA. We don't find CIS. Are we going to have a different biological behavior for them?
Good question. First question about the gemdosi maintenance. So far all the data we have is on 1 year's worth of maintenance. And this whole idea of 3 years of maintenance for BCG as well, we have to be cautious about applying that broadly. Because if you look at the EORTC trial, in intermediate risk patients, 1 year of BCG maintenance is just as good as 3 years. So it's only in the high risk category you need 3 years. So with gemdosi, nobody has really separated them out and tested whether you need 1 year here and 2 years there. So we don't know. Then with regards to your second question, that's actually true in the Asian population. I do some work in China too. There too, you don't get a lot of CIS, and we're not sure why. We're not sure whether that's because they're not aggressively biopsying. Because you see, if you do random biopsies, most of the European studies say about 7 to 10% of patients will have unsuspected CIS when you do random biopsies. You may argue, is that important or not? But so I don't know the prevalence of random biopsies, template biopsies here. If we do it, then you may get a more realistic estimate of what CIS there is that you're missing. But there may be some biology here too.
It has failed BCG or no side effects of BCG, and you have to stop BCG because he has a miserable condition. So what do you suggest? You de-escalate for hyperthermic therapy or you go for gemdosi?
I would try to really rule out potential BCG. I try to lower the dose. I've gone as low as 1/10 of the dose. You can give them, BCG plus interferon. You can de-escalate. You can pre-medicate them with a cocktail. I use, lidocaine, gentamicin, lidocaine, and bicarb cocktail. Like you do that about an hour before, and then do. So you try all sorts of things and make sure they're not. And the reason I've been pushing so hard is I've increasingly started to use the VALAR analysis, which is AI-based analysis of the histology to see if they are BCG responders or not. And if that suggests they're going to be BCG responders, I'll really try to do everything I can to use BCG in these patients.
Anytime they are responder, but they are miserable with
Correct,
the urinary
miserable, yeah.
symptom.
Yeah.
So I'm scared of starting BCG, so I de-escalate to
hyperthermia. Yeah.
You said you can reduce the dose to 1/10. Is there data? What is the data? Because people have used 80 milligrams, 40 milligrams, but 1/10 would be only 12 milligrams.
Yeah.
Is
Actually, this is all anecdotal, to be honest. Mike O'Donnell, who I used to work with, he has even gone as low as 1/100th. He said basically a whiff of BCG is good enough. I don't know, but 1/10 is reasonable. And some people, and Don Lamb will do that now. If you start dose reduction, they actually will also do sub-Q injection of BCG at the same time to get some systemic stimulation, because you avoid local and you do systemic. And Lamb believes that if you do that, even in the SWOG study, one of the arms was that. It was intravesical plus subcutaneous injection. So there does seem to be a benefit by doing it. So maybe you can do that. You reduce the intravesical and just do some systemic.
Because it just came that way. Even 120 dose just happened.
Yeah. That's right.
Nobody actually figured out as to why it should be 120. And I think if you're looking at an immune modulation, as Michael O'Donnell said, just a whiff of it, we don't know.
Dr. Conetti, so finally, the question what being asked, so for maintenance therapy for high-grade cancer, we give for 2 years. That is the protocol by Mike O'Donnell. Because that is the largest study they have published. And for intermediate risk, 1 year. So monthly, no. For the gemcitabine docetaxel for 2 years. And then one more question, the DART 200, when you use those, the foil inside the bladder, what happens like when you give an intravesical therapy, we tell the patient pee in the proper pot, it's a chemotherapy. What happens for those kind of patients? That's the question patient they ask,
Yeah, we have not been saying anything specifically different. You just make sure that nobody else uses the toilet, basically, because it is chemotherapy, right, that you're putting. And we're experimenting with a newer form of this, same sort of device that actually breaks, and then the device itself flushes out, so you don't have to do a cysto. So there's new things that are coming.
Thank you very much.
I'd like to call Dr. Srivatsan Ramani from Chennai to talk about renal preservation strategies in upper tract urothelial cancer.
Mike is not on. It's on. It's on.
Check. Next, I'd like to invite to the stage Dr. Srivatsan Ramani from Chennai to talk about renal preservation strategies in upper tract urothelial cancer.
Can I have my slides, please? Yeah. Very good afternoon to one and all. It's a difficult job to follow in Dr. Badri's footsteps to talk. That was an extensive thing. So my agenda today is renal preservation strategies in upper tract urothelial cancer. We know it's a very rare cancer, and that's why only one topic has been reserved to the urothelial upper tract tumors. So what I'm going to talk about is the risk stratification. This is the most important part of the entire talk. Rest all we know to put a ureteric catheter, we know to do a segmentectomy, we know everything else. So I'm not going to talk about the surgical strategies. I'm just going to talk about the risk stratification and what is the evidence that we have currently to have a renal preservation strategy. So we all know it's a rare tumor, 5 to 10% of the urothelial cancers, histologically similar but distinct. HPE availability is one of the most important problems that we face, that we don't have adequate tissue to process the tumor and the staging. UTUC is strongly associated with Lynch syndrome and certain toxic exposure, higher rate of FGFR3 and HRS mutations, but lower frequencies of RB and TP53, which is more common in the bladder tumors. BCG response, not as much as we see in the bladder, and it's difficult to process it in the ureter as well. Importantly, it has a worse stage by stage prognosis. Renal function is often poor at the diagnosis, and that is one of the reasons that it has to be preserved and conserved as well. And this is mostly a vulnerable patient population. For importantly, an MDT care is required. So kidney sparing UTUC, you have to have imperative indications as well as elective indication. This is anatomically solitary kidney, functionally solitary kidney, significantly baseline CKD patient, bilateral tumors, and obviously major medical comorbidities. Electively, yes, low risk UTUC, solitary, low grade, low volume, and there are certain select high grade tumors in which you can try conservative management or what is called as a kidney sparing treatments. So this is the usual, we all know about this, how we divide into low risk, high risk, and depending on the low risk and high risk, we decide upon whether it's a conservative or a kidney sparing surgery versus endoscopic management versus radical nephro. For all practical purpose, let's assume that radical nephroureterectomy with lymphadenectomy is the gold standard for any high risk UTUC. There is no controversies with regards to that. But the basis of my talk is to decide which are all the candidates for preservation, because we are all into NSS and other preserving the kidney units is what the name of the game currently. So coming to the stratification, and this is the most important slide of my entire talk. There are two different types of stratification, and you can follow whichever you find it to be convenient. So we have the EAU, as in the bladder, the usual confusion as to which guidelines to follow, but you have the EAU, which is very simple, divides it into low risk and high risk, unifocal, and these are all very simple, not very complex like the bladder ones. Tumor size less than 2 centimeter, negative for high grade cytology, low grade biopsy on the URS, and no invasive aspect on the CT. High risk, now all these factors need to be present for low risk. That is the most important line in that. And in high risk, you have a multifocal disease, a tumor size more than 2 centimeters, high-grade cytology, high-grade biopsy, local invasion on CT, hydronephrosis, previous radical cystectomy of bladder cancer, and histological subtype. Any of these factors is sufficient to declare it as high risk. So it's a very fine line. Immediately, the patient will go on a high risk if any of these factors are present, and obviously obviating the need of a conservative or a preserving protocol. Now, if you come to the AUA, it stratifies the high grade into a favorable and an unfavorable ones. Obviously, just to make sure those favorable ones can go for a kidney preserving strategy. So that is any cytology, but no invasion on radiology, no hydronephrosis, normal nodes, no N1, unifocal appearance with a papillary and not a sessile tumor, and lower tract, there should not be any involvement. So this is very crucial for us to understand which are the patients you choose for which type of strategy that we go. Now we come to the role of the risk stratification. We need more data because that stratification alone may not be sufficient for us. So there are various nomograms as we saw in the morning. We have the Forrester, the Petros, the Freefeld, and I would like to only dwell upon two nomograms here. The first is the Forrester, which was published in 2021. These are all very recent data. I'm not talking about old data, which we used to follow in 2010 and other things. So this was a retrospective data, and these are the various factors they took into account. Again, very similarly, previous radical cystectomy, multifocality, invasion, tumor size, hydronephrosis, cytology, and so forth. But they found that if you use this, you can rule out the patient who require radical nephroureterectomy, and thereby they cannot be the candidates for endoscopic management as well. Now, the second nomogram that I would like to see the technical feasibility of a ureteroscopic management is the endometry score. This was published in the Journal of Urology in 2025. So these are the various score that is used. The tract anatomical consideration, whether there is a ureteral anomaly, stricture is there or a stricture more than 1 centimeter. Radius of the tumor, similar to the previous nomograms, 2 centimeter, 2 to 3 and more than 3. Architecture, papillary or sessile. Count, single or multifocal, and the tumor location. This is very crucial. Now we divide the upper tract into a kidney-related upper tract or a non-kidney-related upper tract, and that's how you decide this answer. As the endometry score increases, the likelihood of endoscopic success decreases, and you can use this as a means to understand whether an endoscopic will help you in clearing the tumor. Probably you will have recurrences, but you will be able to still maintain the OS. So these are the guideline recommendation by the EOA. Offer kidney sparing management as a primary treatment option to patients with low risk tumors. Very strong. Both the endoscopic and distal ureterectomy depending on the location. Very strong. And perform second look ureteroscopy within 8 weeks. Though the strength rating is weak, I would suggest it as a very strong recommendation. The reason I will tell you later. So I'm not going to go into the treatment option. I'm very well aware the urology communities know how to do a ureteroscopy, an antegrade, retrograde, whichever way you want. There are some confusion regarding to what laser to use. It started with an NDAC, YOHAC, holmium. Now the thulium laser is also in favorite. There is also a paper on a light touch laser, which is a diode laser, which is supposed to have less fulguration, thereby giving you a better biopsy. And nowadays, with enucleation coming into work, even in the ureter and the calyx, they would suggest a enucleation to have a better biopsy instead of completely fulgurating it without a HPE this thing. Use of excess sheath is recommended because you're excluding the bladder from the upper tract, and thereby you prevent the implantation rate. And you also always have to do a intravesical mitomycin to prevent implantation recurrence in the bladder. Again, in the high risk group, distal uretrectomy with an LND depending on the location, a segmental uretrectomy, or very rarely a ureterorhinoscopy ablation. Now, this is the final thing. So kidney, calyx, and renal pelvis. If it is a calyx and low risk, you can still do an endoscopic ablation. Very rarely, if it is a T2, then obviously you have to go for a RNU. If it is IREX, there is no question that you will have to go for a radical nephrouretrectomy. In the pelvis, again, a more flexible ureteroscopy approach is welcomed here, whereas in the iris, there is no option but to go for a nephrouretrectomy. Similarly, in the ureter, a slight variation is low risk versus high risk. If it is a favorable high risk, you can still think about doing a distal uretrectomy, thereby preserving the renal unit. The problem with all this thing is the ipsilateral recurrences. Okay, I'll just go through it fast so that I'll just finish it. So this is the oncological survival, the endoscopic versus the radical nephro. There is not much difference in the overall survival or the cancer-specific survival. I'll just skip all this for the sake of time and directly go to the apologies. So you're all talking about the mitogel. This is the level 1 evidence that we have, and this is recommended in the guidelines as well, that a mitogel installation be done after the adjuvant therapy for treatment after UTUC endoscopically. And this is the Olympus trial which proved, and there is a very good response, complete response out of 58%, and a durability of response at the end of 2 years, which is most important in a case of a UTUC endoscopic management. Not going into the details of it. These are the pros and cons of the mitomycin gel. Mainly, the stricture rate is very high, 20 to 30%. So we need to be careful about that. Other than that, we have a new trial which is going on, which is the Enlightened trial, which uses padeliporfin, which is the new drug. They have recruited, completed, but it will yet to be released. And I already spoken about the intravesical mitomycin. It has to be done in any case where you're doing an endoscopic management. So these are the future direction that we are looking ahead, pembrolizumab with BCG and also the padeliporfin. These are the results which are yet to come forth. Thank you.
Maybe one question, because we are right now short of time. If none, then the questions can be asked during the coffee time. And Dr. Vineet is the next speaker. Thank you very much. Thank you. In fact, there are lots of issues. I'm sure you'll get questions later on, Dr. Srivastava. Dr. Vineet Talwar is going to talk about frontiers and perspectives in carcinoma urinary bladder.
Thank you, Chairman sir. And this is going to be a reiteration of what Professor Kunti has just now alluded to in NMIBC, although I would dive into one of the drugs which are used in that. So, as you see, the bladder cancer epidemiology, it is the 9th most commonly diagnosed cancer globally. 60% of the cases and 50% of the deaths occur in less developed countries. So that's a problem here. And the less developed you have on this side. And it is the 13th leading cancer-related cause of death globally. So thankfully, most of the majority of bladder cancers are non-muscle invasive bladder cancers, which are about 70% of all the cancers known. And they have a typical patient journey. They start with symptoms, hematuria, urinary problems, dysuria. Then you do a cystoscopy, urine cytology imaging. And then you have the two basic stratas, that is NMIBC and MIBC. The risk assessment, as we have already discussed till now, it is low, intermediate, high, and very high. And 45% of the patients with NMIBC are diagnosed with high-risk disease. And they have about 17% to 89% 5-year recurrence-free survival. and 10% have progression. If you talk of the guidelines, which has already been alluded, the most common are the AUA and the EAU. If you talk of the high risk, it is CIS T1 more than 3 centimeters multifocal. And if you talk of very high risk, then it is BCG unresponsive variant histologies, LVI, and prostatic urethral invasion. So the recommended treatment options are according to the risk stratification, that is the low, intermediate, and high. I would be delving on the high, which is the patients who are BCG naive, who have features of very high risk disease. In this, you give intravesical BCG or cystectomy. Those patients who are again BCG naive don't have any features of very high risk disease. Again, intravesical BCG is there as CAT1. And those who are unresponsive or intolerant, there again intravesical chemotherapy. Then you have pembrolizumab, and then you have NADO and NOGA. I'll not tell the full name because they are tongue twisters. And of course, cystectomy is there. So this is in nutshell where you have the BCG unresponsive disease whenever you have the high or the very high risk patients. So BCG is the treatment which is the standard of care in NMIBC as of now, and it consists of induction phase and the maintenance phase. And basically, it infects the bladder epithelial cells and increases the PDL1 expression and decreases the BCG effectiveness over a period of time. So that is the potential mechanism, and this is the schedule. You have the weekly followed by the 3 weekly installations till about 36 in high-risk patients. But there is an unmet need when you find that almost 50% of the high-risk patients experience recurrence or progression. This could be partly due to the patient compliance also, because it has been seen in many articles about barely about 10% of patients adhere to full 3-year maintenance BCG schedule. So obviously there is an unmet need, and you can have that despite benefit from BCG induction maintenance, 50% experience recurrence in less than 5 years or become unresponsive where you have to use other modalities. And preclinical data suggests there is a role of PD1, PDL1 axis in the bladder cancer and involvement of BCG tumor in tumor PDL1 expression. And there is a clinical evidence to support that. We are using pembrolizumab as monotherapy in these patients who are refractory. And a combination of BCG and a PDL1 inhibition has been seen in rat models. And that was the gist where this trial, that is the CREST trial, was there, in which saselimab and BCG were used in refractory NMIBC. So this drug is basically a humanized IgG4 anti-PD1 antibody. This is the structure of this. And this prevents the interaction between PD1 and PDN1 or 2. And that leads to T cell proliferation and inflammatory cytokine reaction in vitro. So that is the basic mechanism of this drug. And this was studied in this trial, which is going on. The primary objective of this trial is that you have 3 arms and you have 1:1:1 randomization, in which saselimab, as Dr. Conetti had said, it is the drug which is given subcutaneously. It is given once every 4 weeks, 300 milligrams up to 25 cycles. And this can be given as an isolated induction BCG plus the IO, or it can be given with BCG induction maintenance and the drug, and third is only BCG induction maintenance. So these are the patient subgroup is high risk BCG naive NMIBC, CIS T1 high grade TA, no prior immunotherapy or immunostimulatory agents. Randomization, I told you 1:1:1. And these are 3 arms. They continue till recurrence or progression or persistence of CIS. And then, of course, the follow-up is seen, and also the toxicity and the safety profile and the quality of life indices. And this was the summary. And we found that there was event-free survival, which was seen whether it was at 24 months or whether it was at 36 months, when you gave both of them in combination, that is the whole induction and maintenance BCG plus saselumab. And the treatment-related adverse events are reported in 87.1 and 70.2% patients, that is the control arm and the treatment arm. And serious adverse events were in about 17%, where you use this monoclonal antibody versus 1.4 in the other arm. So this was the first study to show a statistically significant reduction in the risk of the event-free survival with the saselumab in combination with the BCG in refractory patients of NMIBC. Median duration of exposure of this drug was about 80.3 weeks in the combined arm versus 98.1 weeks in the other arm. So this showed a statistically significant improvement in EFS, and patients with CIS, the probability of continued CR was greater in the combination arm, and safety profile was generally consistent with the known profile of each individuals. So this is going to be accrued, I think, the end of December 2026. So by the time the results will come, and this is the summary of this trial. Thank you.
Thank you very much. Can I request Dr. Kashyapi to sum up this session?
Thank you. So this session on urothelial cancer, the first was a debate exploring whether can we get away without doing a complete TURBT by the newer imaging. Perhaps we have still not reached there yet. It could have a specific role in certain conditions. Second was can we de-intensify the treatment in very low risk recurrences in elderly patients? As Dr. Ganesh Gopalkrishnan and active monitoring was suggested by Dr. Ashwin also. So very small tumors, you can very well easily follow them up. Fulguration, if you happen to do a cystoscopy, a fulguration is a good strategy. Intravesical chemoablation is also a good strategy. So basically, these small tumors have a very low chance of progression. You can very easily de-intensify the therapy and choose whatever is feasible. Dr. Conetti updated us on the upcoming strategies for high-risk bladder cancer, superficial bladder cancers. Various new things are coming up. Cystectomy still remains the standard of care because all these newer therapies, we need to see what happens in the long run. 2 years down the line, 5 years down the line. Dr. Srivatsan updated about can we preserve the upper tracts in low-risk upper tract urothelial cancers. Dr. Talwar has commented about the newer therapies, especially the sasanella, and let us see how things develop in future. Thank you very much for this session.
Thank you. Thank you, sir.
Thank you so much, Dr. Bhalachandra and Dr. Varun, for convening the session. Thank you, chairs, Dr. Ramlesh, Dr. Ganesh, and Dr. Simon. Thank you all the speakers for this session. Moving on to the next round, I would like to invite the conveners. Dr. Ganesh K. Bakshi, Professor, P. Hinduja National Hospital, Mumbai. Dr. Pankaj Goyal, Consultant Medical Oncology, Rajiv Gandhi Cancer Institute and Research Center. To chair this session, I would like to invite Dr. Santosh Kumar, Senior Professor, CMC Vellore. Dr. Shrinik Shah, Consultant, Ahmedabad. Dr. Jaskaran Singh Sethi, Senior Consultant, Radiation Onc, RGCIRC. Dr. Arpit Jain, Consultant Medical Onc, RGCIRC. And Dr. Arundhati De, Consultant Radiation Onc, Apollo Multispeciality Hospital, Kolkata. Chairs can now invite the first speaker.
Yeah, can we invite first person is a clinical role of ctDNA in urothelial cancer. Can I invite Aparna Dhar from Gurugram?
All right. Good afternoon, everybody. Thank you so much, Dr. Talwar and organizers for having me here today. And this is interesting. I think this is the first time I'm talking about the role of liquid biopsies in urothelial cancers. So before we look at the role of liquid biopsy, question number one, is there actually a role for molecular profiling in urothelial cancers? Well, the answer is yes, there is. And this was actually quite a learning for me too when I started doing the workup for this presentation, that profiling is actually essential. Now, the muscle invasive and the metastatic urothelial carcinomas, we do know are genomically very, very diverse and harbor several potentially actionable alterations. So some of the key molecular drivers that we tend to see are your TP53, your RB1, which is more specific with your neuroendocrine tumors, as we know, that confers to neuroendocrine biology. And then you've got your FGFRs, your ERBB2s, you've got your PIK3CA, your TSC1s, and your KDM6As. So the molecular profiling not only helps classify these urothelial cancers, but I think what they also do is they help divide them into their various subtypes. And this is just a slightly more advanced way of looking at it, if I could say. And what we can see over here is that there are various subtypes. You've got your luminals, your non-luminals, your stroma-enriched, your basal squamous. This is that very classical, the basal squamous, where we tend to see the TP53 RB1. This is actually the subtype that works best with immunotherapy. And then obviously your neuroendocrine tumors that are there. And all of them have very distinct molecular biology. You've got your luminal papillary, where you've got your classical FGFR3 fusions, which is one of the most common fusions we see in our urothelial cancers. And what I thought was absolutely brilliant over here is that, interestingly enough, I did not know this, so this was a good learning for me, is that even anatomically, they're very unique. So if you look at the upper tract urothelial carcinomas, they have a higher frequency for FGFR3 fusions and your KMT2D mutations, which actually confers sensitivity to immunotherapy. Vis-a-vis when we look at bladder tumors, and then you've got the other subtype where you tend to see more of your TP53s and your RB1s. Why is this important? Because this actually helps to direct our therapeutic indications. And this was a fantastic study that was done way back a couple of years ago, actually. This is with the TCGA. And this is one of the key hallmarks where they looked at 412 metastatic urothelial carcinomas. And what they saw was it actually found a lot of great information. One, obviously, were your classical mutations. You have your ERBB2 amplifications. You're going to have your CDKN2A, N2B losses, those amplifications. You've got your ARID1As, which confers sensitivity to synthetic lethality with PARP inhibitors. You've got your TSC1s, which activates the mTOR pathway. So mTOR inhibition is a potential treatment option. You've got your PIK3CAs, your FGFRs. But what really, really stood out over here was the various mutational signatures. So these are usually associated with a high tumor mutation burden. And in addition, what we also found over here, which I think really makes it stand out versus your other solid tumors, are ApoBex signatures. ApoBex signatures are genomic changes that happen within the tumor that actually increases the neoantigen load. So when it increases the neoantigen load, it is supposed to confer a higher tumor mutation burden. And what they saw in these 412 cases, in around 12% of them, they actually had a high ApoBex signature. So when the ApoBex signature went up, your TMB went up, which in turn meant that these patients respond really well to immunotherapy. So I thought this was absolutely brilliant and kind of explains why a lot of our urothelial carcinomas respond really, really well to immunotherapy. But if there is an oncogenic driver like your FGFR3 fusion, they are not going to respond that well. Or your ERBB2 amplification, they're not going to respond that well. But in the absence of an oncogenic driver, these tumors actually do brilliantly well because of these genomic signatures that are very unique to them. And again, those that had a high ApoBex signature, and this heat map, I think, very beautifully captures that the various transcriptomic diversity that is actually linking the gene expression to the histological grade, to the tumor stage, to the PD-L1 status, and the clinical risks. And what was even more interesting is that PD-L1 expression clusters were more frequently seen in the basal subtype. Remember, the basal is the TP53 RB1, which leads to neuroendocrine differentiation. So, and the squamous subtype. So we tend to see it more over there. And these data, though it's technically more academic and we're not really applying it into our clinical practices today, but it is worth having this kind of information going forward. And in fact, in the realms of urinary bladders and in the realm of these cancers, there is a lot of transcriptomic data that is coming out because these seem to be driven, yes, with their unique molecular signatures, but it is these various methylation signatures that are running there, your ApoBac signatures that are there, that are actually conferring and helping driving and understanding how to treat these particular cancers. So after looking at all of that, is there really a role for liquid biopsy? Of course, there's a role for liquid biopsy. If you are going to be looking at the mutational landscape of a tumor, yes, today maybe not all the platforms. So first, when I talk about liquid biopsy, I'm talking about the role of circulating tumor DNA. Circulating tumor DNA is essentially the somatic DNA that gets lysed from the tumor cell into the bloodstream, and that's what you isolate, not circulating tumor cell, which is the intact cell. Now, there is some great work happening also in the realms of CTC and urothelial cancers, but due to paucity of time, I have only 10 minutes, I'm going to stick to ctDNA. So the role of ctDNA, yes, it is pretty abundant in actually finding and, picking up these mutations. I'm going to show you 2 case studies from our clinic where we've used liquid biopsies. And one of the key reasons is that, and we know this time and again, across all solid tumors are heterogeneous. As the disease progresses, as it metastasizes, especially when it goes from advanced to metastatic, the tumor biology is going to change. And there is always going to be inter and intra-tumor heterogeneity. And the best way to combat this is using a liquid biopsy. And again, I repeat, ctDNA. And there are a plethora of ways in which ctDNA can be used today. We have it right up from early screening to treatment monitoring, to molecular profiling, to resistance mechanisms. So picking those up for actually kind of, there's a very nice trial that they are doing. I know it's in GI cancers where it's called the Victory trial. And what they've actually done is looking at the ctDNA, the copy number of ERBB2, they've either increased or decreased the medication. So there's an escalation, de-escalation based on the copy number of the ERBB2. So this is done it's done sequentially every 2 months, every 3 months. And while you're doing a PET scan, you're also looking at these numbers to see if you should be increasing or decreasing your treatment. So that's somewhere where ctDNA works brilliantly well. In the realms of urothelial cancers, this is just something that I collated from everywhere. And I think one thing that we can see is what it's very commonly used for is molecular profiling, resistance tracking, interestingly enough, even in MRD detection. And we've got 2 trials happening. One is over here in the subgroup of patients where when they had to give atezolizumab, adjuvant atezolizumab in muscle-invasive bladder cancers, for those that were ctDNA positive, for those patients, they did escalate and treated on a ctDNA positive result, and they had a better outcome versus the subgroup that was ctDNA negative. Vis-a-vis over here, which was basically a very classical MRD test of saying if you're ctDNA positive, you escalated treatment. If you were ctDNA negative, you de-escalated. So these are, I do know that I think it's Tumbola, which is still ongoing. And even over here, there's some interesting data that has come out. So in our clinic, this is just what we tend to do. In a metastatic case, if cost is not an issue, ideally, yes, upfront, especially if you're going to consider immunotherapy. We do know we have resistance mechanisms that could be lurking around, or an oncogenic driver. So if cost is not an issue upfront, we do like doing a panel. Ideally, there is data that suggests complementary testing, but that's an ideal world, but we can't do that. So we do tissue. If tissue is an issue, we do liquid. And this is usually what we follow in our clinic. And this is just 2 very quick cases of a 68-year-old male, urothelial cancer, underwent a whole lot of treatment. And what we saw was that the patient rapidly progressed on immunotherapy, which was second line. Because of this, we sent a liquid biopsy. And over here, we found an ERBB2 amplification. This was high. So on a liquid biopsy, and this one in particular, when we see an ERBB2 high over there, it's high with 3 pluses over there, that's usually a copy number greater than 6, which means it's actionable. So we did treat over here with TDXT. Those days, the data was not available, but it was off-label, and we did see a very good response, and the patient is currently stable. Here is another case of a 59-year-old male with high-grade urothelial carcinoma, non-muscle invasive, went through a series of treatments, continued to progress, and there was rapid progression, was not really responding. So over here, we went and did a liquid biopsy and we found an FGFR3 fusion. The FGFR3 TACC3 fusion is one of the most common fusion partners we see in bladder cancer. Before I close, just a word of caution. Just because you see an FGFR3 fusion, do not act on it. Please look at the orientation of the fusion. This fusion partner works because FGFR3 is in the 5' region and its partner is in the 3'. It makes a difference on how the fusion happens because for this fusion to happen, the TKI domain has to be intact. If the TKI domain is intact, your drug will bind, your drug will work. But if this was the other way around, which means FGFR3 was in the 3' and the other partner was in the 5', it wouldn't have worked. So when you see a fusion, yay, but please double check if this is an actionable fusion. And to very, very quickly sum it up, ctDNA is a powerful tool. We are using it in other solid tumors, and I don't see why with urothelial cancers it should be left behind. And on that note, thank you so much for your patient listening.
Thank you. I think the questions can be taken later. There's one question, sorry.
Yeah. Is there any specific guideline, like is there any role of serial monitoring of circulatory versus DNA, like in the baseline and how it is decreasing with time? Is there any diagnostic implication?
As of today, there's nothing that's, set in stone in the guidelines, to be very honest. It's still work in progress. Are we using it in our clinic? Yes, in some cases where we're at this crossroads, escalate, de-escalate, over there we are doing it. But as of today, would I advocate and say do it in your clinic? No, I don't have hardcore concrete data. It's still work in progress. Okay. And FGFR amplification, I would look at the copy numbers. If the copy number is high, yes, it's worth targeting, but it would not be with edrafinib or pemigatinib. It would be with something like a lenvatinib. So if there's an FGFR2, 3, or 1 amplification, or if you have FGF ligands of 19, 16, because these bind to these receptors, these are actionable with a pan-TRK like lenvatinib. Max.
And do you do some research?
I do research. I do it all.
Thank you. So the next speaker is Dr. Priyamvada Maitre. She's speaking on extended indications of TMT.
Good afternoon, everyone. Thank you, organizers, for giving me the opportunity to talk about extended indications for trimodality therapy for bladder cancer today. We all know that trimodality therapy consists of maximal TURBT, curative radiotherapy for the bladder, along with a concurrent radiosensitizer. And in this approach, cystectomy is reserved for salvage. Now, indications of TMT probably depends on who you ask. We know that there are surgeons who would say there is practically no patient who is eligible for TMT when it comes down to it. And I have known some radiation oncologists who say everyone wants to preserve their bladder, don't they? But jokes apart, there are a few points that we all keep in mind when we talk about TMT. Patient can be medically unfit for a cystectomy, in which case there is no alternative. They may be completely unwilling to lose their native bladder. They have to have a good bladder function at baseline, which is worth preserving. They should be willing for regular cystoscopies at follow-up, and they should be okay with the risk of salvage cystectomy if required. There is no argument about these points. But the textbook teaching says that an ideal candidate for TMT should have preferably a small T2 tumor, no nodes, no CIS, good renal function so that they can have their chemo, no variant histology, they should have had a complete TURBT, and if a neoadjuvant chemo is given, there should be good response or ideally a complete response. But are all of these indications absolute or relative? We'll discuss that. Looking at the long-term outcomes of TMT, MGH in Boston was one of the pioneering institutions, and they published their very long-term data where they showed that how the bladder preservation got better over the years. their survival rates improved and the risk of salvage cystectomy reduced. In this data, T2 stage, no CIS, TURBT completion was prognostic, not predictive. In another series, this is from a pooled analysis of RTOG trials, about 500 patients again. Almost 40% patients had a T3 or T4 disease. They got their protocol prescribed chemotherapy and a 10-year bladder cancer specific survival of 65%. Interestingly, when we look at the prognostic factors, T2 is again a prognostic factor in all these patients who were treated with TMT. Our experience has been similar. Over a decade, we have treated about 200 patients with plan of the day technique. In our cohort, almost 40% patients are T3 or T4 stage again. 18% are even node positive. And over a median follow-up of 30 months, we got a 3-year bladder cancer specific survival of 86%, which is not bad at all. Would these patients serve better with the cystectomy? So this is some data from nationwide study across Netherlands, where they looked at about 1,500 bladder cancer patients. Some of them had cystectomy and some of them had bladder preservation. After adjusting for baseline factors, there was no difference in the outcomes. In this cohort, almost 30% had a T3 or T4 disease, 20% had CIS as well, and they were slightly older than what we see in the clinics, median age being 71 years, still no difference in the outcomes. Now, locally advanced bladder cancer sometimes comes with a lymph nodal involvement. We know that it has a worse prognosis. The question is, should we operate or preserve the bladder because the patients are not going to fail locally, they're probably going to fail distally. We have some data pooled from the UK centers, about 300 patients, all had node positive, some treated with surgery, some treated with radiotherapy, and there was no difference in the survival outcomes. Interestingly, for the patients who were not eligible for chemo and treated with only surgery or only radiotherapy alone, again, there was no difference. So the OS was similar irrespective of the chemotherapy fitness. After NACT for locally advanced, we know that it is the standard of care now, but historically more patients have been treated with neoadjuvant chemo followed by radical cystectomy. TMT was an alternative option mostly for NACT ineligible patients. But we know from the ABC meta-analysis that NACT has an independent prognostic effect, 5% absolute survival benefit irrespective of the type of local treatment. Similar data from the BA06 randomized trial, where some patients got radiotherapy for the bladder, some got a cystectomy, and NACT benefit was seen in both the cohorts. So the fitness for NACT is in itself a prognostic factor and should not be used as a selective factor for type of the local treatment. Now, having said that, response to neoadjuvant chemotherapy can help in predicting the success of trimodality therapy. There is some pilot data from PGI Chandigarh, 40 patients who all got 3 cycles of neoadjuvant chemotherapy and a response assessment. If there was at least a 50% response, they went on to have radical CTRT. Using this approach, 87% showed response, and 100% of these patients had a complete response at 6 weeks after the radiotherapy. Interestingly, 3-year OS in this cohort was strongly dependent by the type of response to NACT, which again shows the prognostic value of neoadjuvant chemo. Now, another expanding indication is consolidative TMT after neoadjuvant chemo IO, which is now becoming the standard of care. The International Bladder Cancer Group has highlighted this as one of the priority for research. So patients with locally advanced bladder cancer, they receive their systemic therapy, either chemo alone or chemo IO. And after that, if they have a complete response, they would be interested in bladder preservation, and radiotherapy to the bladder is one of the ways to do it. This is an area of active ongoing research. This is the RETAIN-2 trial, which was shown in the ASCO recently. They treated localized bladder cancer with nivolumab and DDMVAC neoadjuvant therapy. And depending on the residual disease and the cytology, the patients could choose between the cystectomy or radiotherapy. And early outcomes show that using this approach, most of the patients were free of distant metastasis over a reasonably medium long-term follow-up. Now, what do the updated guidelines say? The EAU guidelines this year say that trimodality therapy is an option either upfront for patients who are not eligible for chemo or after the neoadjuvant therapy if they are still interested in preserving their bladder. Similarly, the ISMO guidelines say that TMT is an option for all the muscle invasive disease irrespective of the fitness of neoadjuvant chemotherapy. NCCN guidelines for stage 3A, they show that TMT is a category 1 recommendation. And for a more advanced bladder cancer, after downstaging with systemic therapy, depending on the CR or PR, consolidation CTRT is still a good option. Coming to the variants, we see them often in our clinic. The best data that I could find for this is the pool data from Canada, about 800 patients. 14% had a variant histology, and there was no difference in the outcomes. The outcomes were similar as in the pure urothelial. Looking deeper, the prognostic factors in this cohort was T-stage, HUN, and NACT, not TURBT and not CIS. So that brings us to TURBT. Does the extent of TURBT matter? The traditional old concept that the completion TURBT should be done comes from series such as Boston, which showed that complete TURBT predicted a CR after TMT. But the Canadian data showed that patients with more locally advanced disease are more likely to have an incomplete TURBT. That makes sense. And after adjusting for the baseline clinical factors, the extent of TURBT did not impact the outcomes after TMT. So that is something to think about. Now, this paper from the International Bladder Cancer Group kind of summarizes my whole talk. There are patients who will have favorable prognostic factors, and there are patients who will have unfavorable prognostic factors. So if we look at the factors that will favor RC, is poor bladder function, previous radiotherapy, diffuse CIS, multifocal tumors, where surgery is a better choice than radiotherapy. And in patients with a high surgical risk or in patients who are strongly desirous of preserving the bladder, a TMT may be preferred. But rest is all prognostic factors. Performance status, T2 stage, HUN, CIS, they are all, they are going to tell us whether the patient is going to do well or worse, irrespective of the treatment modality. The caveats being that the comparative data is absent. We do not have an RCT in this situation. So we have to tailor the treatment towards each patient. Finally, coming back to these factors again, I hope I have managed to show that these factors are prognostic and not selective for the bladder local treatment modality. Thank you so much for your attention.
One change which has happened from the past is presence of Virat staging now.
Yes.
I didn't find it anywhere in any of yours, this thing, whether Virat's response post chemotherapy
Yes.
was a good indicator to choose patients for TMT.
So as of now, we are not using Virads in our daily practice. It is a matter of active research, but we are doing a contrast enhanced CT scan after the neoadjuvant systemic therapy. And based on that, we are taking a decision and discussing with the patient about the local treatment options.
How about the squamous variant? If you know preoperative, do you still go ahead with the TMT same way?
So mostly similar, but we tend to prefer the upfront local treatment approach. So if they have a surgery, we talk to them about adjuvant radiotherapy, that's in the post-op setting. And if it is a small focal squamous without any CIS in the rest of the bladder, and if the renal function is good, all of the other factors, and patient is willing to preserve the bladder and risk of follow-up scopies, then we can go ahead with radical CTRT.
What is your time of reassessment post CTRT?
Post CTRT, we do 3 monthly cystoscopies, urine cytology at every visit, and contrast enhanced CT scan every alternate visit, so every 6 months, till 2 years at least. And after that, for next 3 years, 6 monthly assessments, cytology, cystoscopy, and an yearly CECT.
Thank you.
Thank you.
Thank you very much. Yeah. Can we call upon the next speaker, the perioperative durvalumab in MIBC? Sorry, your question, please.
So, Dr. Priyambada, there are patients who have non-muscle invasive bladder cancer and who are not responsive to BCG and sometimes they refuse for radical cystectomy.
Yes.
So is there any option of radiation there?
I thought of putting the NMIBC slide as well, but I took it out because of the lack of time. The only data that we have is from a single arm trial from RTOG, which was published recently. And although in conclusion they said that 88% remained cystectomy free, it was a very small trial with a lot of caveats in the interpretation of the results. So as of now, NMIBC, we generally do not prefer to offer CTRT or even RT unless there is no other option or the patient absolutely refuses the cystectomy.
Another small question is regarding patients who have para-aortic lymph nodes at presentation.
Yes.
And after systemic therapy, if they get complete response
Yes.
in nodes as well as primary, and again they refuse for surgery,
Yes.
would you consider them for radiation?
On a case-to-case basis, we have considered them because I think the extent of surgery in that case, if we were to cover all the pre-treatment, pre-neoadjuvant chemo involvement, that would be quite morbid. So as a consolidative therapy, we have done bladder radiotherapy with extended pelvic radiotherapy, but very few number of patients, and I'm not aware of any good amount of data in that. Thank you.
Thank you. Yeah. Can we go to the next speaker? Is Dr. Chirag Desai from Ahmedabad. It's a perioperative durvalumab in MIBC. Solution or dilemma?
So good afternoon, everyone. And thank you very much, Vinith and the organizing team for involving me in this program. So in contemporary time, by the time one trial is completed, the comparator arm in that trial is being obsolete. That trial is always criticized that it would have been better if X was the comparator and not the Y as in a particular trial. So to that extent, the dilemma is going to remain. But what solution this trial is being is offering to us, I will try to cover in about 15 to 20 minutes. So progress in the treatment of carcinoma bladder. On the right side, what you have is what we are going to discuss today, MIBC. On the left side, what you have is being predominantly addressed by the urologist, and the bottom on your on your right side is being managed by us medical oncologists, metastatic breast cancer. But I'm going to discuss what we are doing in the joint clinic with uro-oncologists. So we have all these options as standard treatment, but radical cystectomy and neoadjuvant cisplatin. Sorry, the box is on the wrong table. It should be down here. Neoadjuvant cisplatin-based chemotherapy is the standard of care right now, and radical cystectomy. And we could offer bladder-sparing treatment to some patients. Adjuvant treatment chemotherapy is not so very effective. That's something that we already know. So radical cystectomy can cure approximately 50% of the patient, and neoadjuvant cisplatin-based chemotherapy can cure further 5 to 10% of the patients. When we say neoadjuvant cisplatin-based chemotherapy, there are a number of patients who are not eligible for cisplatin-based chemotherapy, and they are not better not treated with neoadjuvant chemotherapy. But are all these factors absolute or relative? So look at the first box on the right side, performance status more than 1. In our practice, we are extrapolating to some of the patients with performance status 2 as well. And on the right side, renal impairment, if GFR is less than 60 ml per minute, is it automatically eliminated from the cisplatin-based neoadjuvant chemotherapy? No. There are some patients where we can offer neoadjuvant cisplatin-based therapy, and that will come out from this particular trial. So there are 4 options of neoadjuvant chemotherapy. Look at the bottom 2 boxes. The one on the right side, CMV, was being used in the past. And because of so many trials, so many patients on CMV, the advantage of neoadjuvant chemotherapy in meta-analysis was close to 5%. But if we give the top 2 lines of chemotherapy, gemcitabine cisplatinum or DDMVEC, the advantage is closer to 10%. And that's what we are using right now. So MVEC we are not using because of the superiority in toxicity profile and similarity in the efficacy profile. So gemcitabine cisplatinum has enjoyed the treatment of choice in neoadjuvant treatment for a long time, about 8 to 10% increase in the overall survival. And how can we improve the result beyond NACT, GC? It's either by DDMVEC as per Vesper 05 trial, or adding immunotherapy either as adjuvant therapy or as perioperative therapy. So in Vesper 05 trial, neoadjuvant DDMVEC versus neoadjuvant GC, and there were some patients who were treated as adjuvant treatment as well, but those patients were very small in number, and this trial showed that DDMVEC had superiority in PFS as well as overall survival. So some of us have started using DDMVEC as a treatment. But by the time this trial came, many other trials had already been started, like nivolumab trial and durvalumab trial. So all these trials are using cisplatin gemcitabine as the comparator. So these are the overview of the results for adjuvant immune checkmate inhibitor therapy. And of all this, checkmate 274 is a successful trial. And there are some caveats, but which I'm not going to discuss, because I'm going to discuss about another trial today. But based on the results of nivolumab trial, checkmate 274, adjuvant nivolumab has been approved by US FDA as well as by EU in PD-L1 expressing tumors. And these are the neoadjuvant or perioperative immuno-oncological trials in MIBC. The left side is for cisplatin ineligible MIBC, Volga, Keynote 905, and NSCT 9114. And these trials are ongoing, and the one on the right side are cisplatin eligible patients. So Niagara has been completed, it has been presented as well as published, and I'm going to discuss about the Niagara trial, not the other 4 trials. So this is the randomized phase 3 trial of neoadjuvant cisgem versus cisgem and durvalumab as the neoadjuvant as well as adjuvant therapy. And this is the trial design: 4 cycles of neoadjuvant cisgem with 1500 milligram durvalumab given every 3 weeks before surgery, then radical cystectomy, and as adjuvant therapy, durvalumab is being given every 4 weeks for 8 cycles, or no further treatment. This is not a placebo-controlled trial. Look at your right side. The dual primary endpoint were event-free survival and pathological complete response rate. And the stratification factors were T2 and 0 versus higher, renal function, creatinine clearance more than 60 versus 40 to 60, and PD-L1 high or low or negative. So with that, the baseline characteristics were equally well balanced in the 2 trials, and there were a good number of patients with poorer renal function as well, 19%, 18 to 19% in both the arms. And lymph nodes were positive in very small number of the patients. So the result cannot be extrapolated to all lymph node positive patients. So this is the primary endpoint of EFS. At 12 months as well as at 24 months, there is a significant improvement in event-free survival, 69.9 versus 76 at 12 months, and 59.8 versus 67.8% at 24 months, and with hazard ratio of 0.68, an excellent p-value. The survival also, the data is immature, but still numerically it is far better as compared to the comparator arm. If you look at pathological complete response rate in the first analysis that was conducted in January 2022, and it came out in the first publication, there was some programming error in the software where 59 patients whose data was pending from the central laboratory, it was not reflected as pending, but it was reflected as no PCR. And in the subsequent analysis in April 2024, when the next publication last year appeared, this data was available and it was appropriately incorporated, showing that with durvalumab, 37.3% of the patient had PCR, while only chemotherapy had 27.5% PCR, and that was statistically significant as per the statistical design of this trial. So both the primary endpoint of EFS as well as the PCR were met for this particular study. And we can look at event-free survival in the patient who achieved PCR as well as the patient who did not achieve PCR. And in both this subset, there was superiority of durvalumab containing arm. So one dilemma that may remain is that whether adjuvant therapy is recommended if there is a complete response. This figure shows that possibly, yes, there is an advantage of giving adjuvant durvalumab as well as for the patient who achieve pathological complete response. And this is about the overall survival. There is small but real difference. The curves are closer in the adjuvant arm. At the end of 2 years, it is 91.1 versus 95.5%. That is 4% gain in the overall survival. At 2 years, the data is not mature. Let us look at the mature data coming up in next couple of years. And for non-PCR, there is a difference between the two arms. So there were some patients who did not undergo radical cystectomy, who could not undergo radical cystectomy for various reasons. But those who underwent cystectomy, there was 9% gain in the PCR rate by offering durvalumab as compared to only chemotherapy. And the DFS was better in this subset of the patient. And the DFS in PCR as well as non-PCR, both the subset was better in the patient who underwent radical cystectomy. So if you look at PCR in borderline renal function, it was doubling from 16% was 32%. If you look at the EFS in the borderline renal function, again, there was wide separation of the curves, showing it at some significant level, even though the EFS HR was 0.69 and the upper bound is 1.01, so just missed. But still, 0.69 is something that you cannot ignore. So if you look at the waterfall plot, if you look at the forest plot, all the dots are on the left side of line of unity, and it shows that neoadjuvant durvalumab is working in practically all the subsets. And safety, I think I will discuss about the safety in the next slide. Which is important. So what are the concerns when we are giving neoadjuvant therapy? And these concerns were discussed in multiple forums where all of us were together, medical oncologist and surgical uro-oncologist. And the uro-oncologist had these three fears mainly: early progression, toxicities precluding or delaying surgery, and post-operative complication. So in the publication of this trial, post-operative complications have not been addressed, but the other two things have been addressed. So the first thing, look at the first line in this table, the event leading to death, it was 3 in each arm. So if we consider that GC is the standard of care, there was no addition of death in experimental arm with durvalumab. And look at the last two lines, events leading to cancellation of the surgery. It was 6 versus 7. 1.1 versus 1.3%, and event leading to delay in the surgery 9 versus 6. So it was equal, and there was no difference in the two arms. And if we look at the comparison of the patient who had to discontinue neoadjuvant therapy because of early disease progression, it was 2 patients, 0.4% in durvalumab versus 4 patients, that is 0.8% in the chemotherapy only arm. So very occasional patient, there was progression of the disease. So that usually, rarely ever if happens. So to conclude, the Niagara trial met both the endpoints, EFS as well as PCR. It worked in compromised renal function as well. And this additional analysis from Niagara provides further support for perioperative durvalumab plus neoadjuvant chemotherapy as the new treatment for the patient with cisplatin eligible MIBC. Now, Dr. Badrinath showed the data of Sunrise 1 and 2 and 3 study. There was Sunrise 4 study. It is the phase 2B study of gemcitabine product TAR-200 with another immunotherapeutic drug, and it is showing good improvement in the PCR rate. Just I want to show that there are multiple trials ongoing. I am just showing one of them. I showed some of them in the table earlier. A lot of work is being done. So there are 3 options to improve the outcome beyond what we are achieving with gemcitabine cisplatinum. One is Vesper 05, give DDMVEC, and the other 2 are like Checkmate 274, give nivolumab as adjuvant therapy, or Niagara perioperative durvalumab. So V05 unfortunately did not have immunotherapy arm, and both the immunotherapy study did not have DDMVAC arm. I mean, they were just gemcitabine cisplatin. So that question is not answered. But if we have to design a study today, I think I will combine immunotherapy with DDMVAC rather than gemcitabine cisplatinum, and that will give us the answer. But that answer we do not have right now. But in contemporary time, avoiding immunotherapy just to give DDMVAC is not a good option. And in practically all the diseases, including renal cell carcinoma, lung cancer, breast cancer, stomach cancer, rectum cancer, and so on and so forth. I can go on. It's a long list. Immunotherapy has emerged as treatment in many of the patients as the neoadjuvant or adjuvant therapy. And if I have to choose between two, neoadjuvant and adjuvant, neoadjuvant in practically every situation gives a better result because it exposes the immunotherapy drug to the in situ tumor, and that activates the immune activity much further. So to that extent, and there are some other points in nivolumab trial which I don't want to discuss over here because that's the point of debate actually. We can go on for another half an hour debate about neoadjuvant treatment or adjuvant nivolumab. The solution that we have from the data that we have is neoadjuvant immunotherapy with chemotherapy is better as compared to neoadjuvant chemotherapy alone. And based on this data, neoadjuvant durvalumab with chemotherapy has been accepted in NCCN as category 1 evidence. This is my last slide, and thank you very much. So, durvalumab, it's about 5 lakhs per cycle for 1,500 milligram. But to the best of my knowledge, the company offers some discount, and with that discount, confirm with the company people who are sitting outside, it comes to about 2 lakhs per cycle. 4 before surgery and 8 after surgery. I mean, that's what we are offering in many cancers. So, I mean, there are patients, there are always patients who are taking this therapy.
And Chirag, a lot of side effects of.
So, unfortunately, in any disease except for rectal carcinoma, where MSI is the biomarker, no biomarker has been emerged as a great biomarker. So, there is no biomarker for bladder carcinoma. Dr. Raja. Thank you.
Not paid out in a lot of these. I agree with everything that you've said, but just to put things in perspective, among all the studies that have been done, whether you give adjuvant nivolumab or perioperative durvalumab or everywhere else, the only therapy that is shown to have an overall higher. If you are giving adjuvant therapy, not in a metastatic setting, if you are giving an adjuvant therapy, you are giving it as an adjuvant so patients can live longer. Not that they live longer with disease. Survival benefit. And the only study that is shown an OS benefit is the DDMVAC, although it was a subset.
Right.
The overall group did not show an OS benefit, but for patients who got neoadjuvant DDMVAC compared to the Gemcitabine arm, there was a 10%.
I agree. And I have the answer to that as well. So the thing is that by the time GC was established as
I think we'll continue.
There are
continue to talk later.
multiple trials. Some of the trials did not show the advantage. Some of the trials showed a great advantage. And all the trials in the meta-analysis were put under the umbrella of neoadjuvant cisplatin based therapy, and many of them were CMV therapy, which is substandard as per the current standard of care. And nobody has done a formal large trial, and I think nobody will do it now. So there is no way to reinvent the wheel.
Chirag,
And just a second, let me finish the answer and then I will come back to you, please. And the other two trials, adjuvant nivolumab and perioperative nivolumab, they don't have enough follow-up to show us the improvement in the survival. The curves continue to show the separation down the line, and within just a couple of years, we will be able to see that survival data, and we will discuss again. Dr. Shanik and then Dr. Vinith. Yeah.
better response as compared to the ones which were across G plus C. And as far as the Niagara is concerned, the OS is not yet out.
Yeah.
So the primary endpoint was EFS.
EFS and PCR.
That has been met. The
Yeah.
secondary point is OS that will become.
That will come. That will come. That is an important, but that will come.
Thank you, sir. Thank you. We have overshot
Thank you
by
very
10 minutes. Thank you very much. We call the next speaker, Dr. Tanveer Shahid. We'll be talking on perioperative radiation therapy after radical cystoprostatectomy.
Good afternoon. Thank you, chairpersons. Thank you, Rahul sir, Dr. Amitabh, Dr. Vedang sir, for giving this opportunity. Can I have my slides, please? Yes. So I have been assigned the topic of post-operative radiation therapy after radical cystic prostatectomy in view of presence or absence of orthoptic diversion. First of all, as a radiation oncologist, by and large, whoever are sitting in the audience and chairperson also, as post-operative radiation therapy in bladder cancer, seldom we do. I remember Arundhati, Dr. Arundhati and myself, we have worked together. I think we have done hardly two or so our experiences as such in post-operative setting of bladder cancer is absolutely theoretical. This is the flow of presentation. Now, to begin with, the standard care for muscle invasive bladder cancer is surgery with or without chemotherapy. And the surgery is cystoprostatectomy with bilateral pelvic nodal dissection. The major cause, the major pitfall is the loco-regional relapse. Chemotherapy does add to the benefit, but what is that percentage of magnitude of benefit? We don't know. Adjuvant RT therefore can add to some kind of a benefit for a better outcome. Now, what is the rationale or why do we want to add radiation after the surgery? The reason is that we want to control the risk for distant metastasis. And how is that possible? Because it has been proven beyond doubt from this paper, which was published almost 2 to 3 decades ago, where it was shown that if there is a less chances of failure, or there is a less chances of distant metastasis if we don't have a failure. So freedom from distant metastasis is very good if we have a very good local control. So if we want to have a good local control, we can add radiation and thereby we can have a better outcome. Now, what is the major issue with the patient undergoing radical cystectomy? If we dig into all the literatures available, it is primarily the issue is that the loco-regional failure is the major deterrent factor why we are worried about. And what is the recurrence pattern after radical cystectomy? It is important because, and it is beautifully explained from this paper, that predominantly there is a local relapse in the pelvic nodes and also in the post-operative bed. It also depends upon whether it is a positive margin or negative margin. If there is a positive margin, then cystectomy bed recurrences are more. So therefore, adjuvant RT can look into this by giving a better control. Now, who are those patients where adjuvant RT can be advocated? Now, again, if we look into the available literature, the Bauman et al., they are from University of Pennsylvania, have done extensive work. Novotny et al., they are from Germany. Again, there are a lot of papers by them and our own Dr. Vedang's paper. The patients who will be really benefited by adjuvant RT can be the highest stage, that is PT3 or more, nodal positive disease, inadequate nodal dissection, that is less than 10 probably, positive margin, or the gross residual disease. So these are the patients in which post-operative radiotherapy can have an effect. Now, do we have an evidence for advocating adjuvant RT after the surgery in high-risk cases? And very sorry to say, we don't have any robust evidence except that the first paper published in JAMA, it is an Egyptian paper, phase 2 randomized control trial, very often quoted, but it does mention that addition of radiation does improve in the local control. And the other Belgian paper just published this year again says that modern radiation therapy, if added in an adjuvant setting, it has a better outcome. But however, we don't have a robust phase 3 randomized control trial to say that it really helps. Let's assess the benefit of adjuvant RT theoretically. Theoretically, local relapse, free survival, disease-free survival, distant metastasis, it does decrease. Toxicity, acute and late, theoretically, definitely the toxicity sounds to be more. However, with the advent of modern radiation, the things have changed. So there, it's a query. Now, is there a benefit of adjuvant RT? And if there is a benefit, why don't we routinely advocate it? And the reason is this, that is the toxicity. Surgeons have the inhibition because when they refer, they also have the toxicity issue in mind. Radiation will add up to the toxicity, and it is right in many ways because where to give the radiation. And the issue is the GI toxicity because everywhere there is a bowel. Where do we want to give the radiation? It is in the bowel. So therefore, the toxicity, GI toxicities are high as per the literature. But again, we will have to take it with a pinch of salt because these were the results when the radiations were not conformal. So with the conformal radiation, things might change. Now, the concern regarding the toxicity, and toxicity can only be decreased if organ at risk, if we can control the doses to organ at risk. And how will we do that? Appropriate RT technique. In the morning, also Dr. Indranil did mention, like, if that improvement in RT technique has to be intensity modulated radiotherapy, and it has to be under the daily CBCT, that is image guidance. There has to be an appropriate contouring of the OARs, in particular, the bowel bag, your stoma, your ileal conduit, everything has to be properly contoured and proper constraint to be given. And then only we can think, like, this is the representation where contrast has been injected while doing a planning CT scan in the stoma and in the conduit, and then the delineation has been done, and accordingly constraint has been given in order to have a restrictive dose to those organ at risk in order to prevent the toxicity. Then another few very important point as far as the ostoma bags are concerned, we have to contour the ostoma bag in patients with urinary diversion or the ileal conduit, and it has to be properly contoured. Contrast has to be pushed. While doing the planning, the physicist has to be told that how to plan it and how to avoid that, and then only we have to accept the plan. And also it's important that while simulating, the patient has to be treated in an empty stoma bag. Now looking at the dose constraint, these are the dose constraint which we often practice. And if anybody who is practicing has to look into this dose constraint very appropriately for a better outcome. Then comes the game changer, that is BART trial from Dr. Vedant Murthy sir's group. Now, BART trial, it is a randomized controlled trial where in adjuvant settings, patients were given radiation and the other arm was observation. Eligibility criteria was more than one of the high-risk features. The patient had to be randomized into observation versus adjuvant RT. And recently in Red Journal, they have published the toxicity data. The outcome data has yet to be published. And it's a proud moment because Astro plenary session this time will be holding BART trial as it's one of its presentation. And if you look at the toxicity data, as far as the acute toxicity goes, there is definitely a higher grade 2 toxicity, higher grade 2 GI toxicity. And if you look at the late toxicity, it is a similar grade 3 or more GI toxicity. So toxicity wise, acute definitely grade 2 seems to be more, but late grade 3 or more is comparable in both the groups. Regarding the contouring, I will not be going into details. There are contouring guidelines where the radiation oncologists have to follow in the post-operative setting. Then to conclude, modern adjuvant radiotherapy in muscle-invasive bladder cancer following radical cystectomy demonstrate an acceptable safety profile, at least as per the latest literature which are coming out. Radiation significantly improves locoregional control, particularly in the high-risk patients. However, evidence of overall survival benefit still it is inconclusive. We are waiting for the BART trial and also the French trial, which is undergoing, which are the randomized control trial. Those results might be changing our view overall. Now, again, it has to be predictive biomarkers has to be also taken into account, and then only we can decide and tailor the radiation as far as the adjuvant radiation is concerned. And Dr. Chirag was also mentioning that adjuvant RT individually, like it has to be incorporated with immunotherapy, but all these trials are solely based on only adjuvant radiotherapy. Thank you so much.
I have one question.
Yeah.
Is there any subgroup of patient where we can avoid radiation to cystectomy bed? Only we can give radiation to pelvic nodal region, but can that will be beneficial for the toxicity profile?
Yeah. So if you look into literature, the way the literature has evolved, so initially it was thought that if there is a margin negative, you can avoid the cystectomy bed, that is post-operative bed, and you can only give the radiation to the nodal volume. However, that theory did not really hold the test of time because the failure pattern was really not dependent upon where the failure was happening. So eventually, initially that it did hold true that you give the radiation only to the nodal volume and avoid the post-operative bed, thereby reducing the toxicity. However, the latest, the Bowman trial update and even that IBIS trial where Dr. Vedang Murthy sir is also one of the investigators, this multidisciplinary group contouring guidelines, gradually they are modifying that. So we don't have that answer that only nodal, but yes, theoretically you are absolutely right that can be one of the options, definitely, but specifically in the margin negative patients.
Thank you.
Tanvir?
Yes, sir.
Yeah.
Yes, sir.
After radical cystectomy, the entire pelvis would be full of bowel.
Correct.
And whether you have a conduit or a neobladder, how do you selectively find that tiny, and how do you concentrate on that tiny tissue? Because all the lymph nodes have been taken out. And the bed, there is practically no bed which is separate from bowel. The bowel is filling up the entire bed. And how do you irradiate the pelvic nodes which have already been taken out? And how do you irradiate the bladder bed where the bladder has been taken out and the whole bed is full of bowel? How is it possible?
So that's the challenge. Number one, if you have to see the ileal conduit, the stoma, that has to be delineated, and that can only be seen at the time of when you do a proper simulation. Like you are introducing the contrast at the time of planning CT. So while doing the contouring, you are delineating the stoma as well as the conduit. So by that criteria, then you are giving a dose constraint. For example, for ileal conduit, you are giving the dose constraint to less than 5 gray. Similarly, the nodal volumes. Nodal volumes as such, though the bowels are there, but still the nodal volume criteria is the same. You along the blood vessels, you give the margin and you irradiate the nodes. And then your doses, you are not going above 50.4 gray or 50 gray by conventional fractionation. So overall, if you see, that's the challenging part, what you are mentioning, but still it is doable with the modern radiotherapy by doing a proper delineation, proper contouring, proper planning, and treating under image guidance every day, sir.
So thanks a lot, sir. So we'll sum up. First, the molecular talk we had on urothelial cancer. I think it's an exciting concept, but when we talk about results, still a lot more to be done. And the patient, I think, knows that there are bleak chances of any suggestion of a worthful drug or targetable mutations. And if that drug is available, the second thing, then third is if patient can afford it, and the fourth, if it works. Do these tests, but clinically, I think ground reality is.
We need to still evolve on that topic. About Dr. Priyambada's talk of extended indication of TMT in various extended indications, divergent node positive, hydroureteronephrosis, and variant pathology. I think she defined the actual role of TMT. And extended role, I think the surgery plays a big role there probably. We pass on those patients who are not fit surgically for that extended indications is what was the overall thought. Coming to Dr. Chirag Desai, that is a well-known study, the Niagara study which was presented, and the application, it has, I think, going to become the standard of care. So the application of neoadjuvant chemotherapy plus peri-op durvalumab will come into practice anyways. The last talk was Dr. Tanvir. I mean, we just heard it. About post-op radiation after radical cystectomy in presence absence of orthotopic neobladder. So he outlined the indications like T3 node positive, post margin positive, and those who dissect lesser nodes. After radical cystectomy, the node count is important. At least 14 is what is said. So less than 10 nodes was quoted. And I think he discussed techniques where RT can be made safe and possible in these indications. So that is how we sum up this session. Thank you so much. Thank you.
Thank you, Dr. Ganesh and Dr. Pankaj, for convening the session nicely. Thank you, Dr. Santosh, Dr. Jaskaran, Dr. Arundhati, and Dr. Arpit Jain for chairing this session. Moving forth, this concluding scientific session covers low frequency but high impact domains, penile testicular cancers and RCCs, topic ranging from BEP toxicity to sentinel lymph nodes to IMDC driven RCC strategies. For this session to be convened, I would like to invite Dr. Mahendra Pal, Professor TMC Mumbai, Dr. Dharmishta Ashish Bapu, Consultant Medical Oncology, RGCIRC. For chairing the session, we would like to invite Professor Francis James, RCC Trivandrum, India, and Dr. Vishambar Nath, Consultant Urologist, Pace Hospital, Hyderabad.
So,
Arpit, you can also join as a chairperson.
so I would like to invite Dr. Shenik Shah. Or done, okay. Francis. Dr. Vishambar Nath, sir.
Please invite first
Excuse me,
speaker.
Arpit, first of all. So first of all, I would like to thank Charu. So, because she took out the time from her very busy schedule and she organized the session very well. Thank you. Thank you, sir. Thank you. Yeah.
May I request chairperson to call our next speaker, please?
At the outset, I would like to invite Mr. Dr. Ricky Fraser to deliver a talk on treatment of a RCC as per IMDC risk group, focusing on the ends of the spectrum. Dr. Fraser is a consultant medical oncologist specializing in melanoma, renal cancer, and immunotherapy. He is a clinical lead for the acute oncology assessment unit. He is a clinical lead for the Southeast Wales Immunotherapy Toxicity Service. He is a tutor at Royal College of Physicians College. He is a program director for the diploma and the MSc in the medical oncology, University of Buckingham. He is an honorary lecturer at Cardiff University. So I would like to invite him to deliver the talk.
Thank you. And thank you for the invite to speak. Thank you for Merck for supporting it. So my name is Ricky. I'm going to talk about kidney cancer And I'm going to talk about IMDC, but I'm also going to talk about other ways that I think we can stratify our patients. Now, this slide's actually quite important. So I speak for a lot of the different companies. I speak for Ipsen, I speak for MSD, I speak for BMS. And so what I'm going to do today, this is a Merck-sponsored talk, but I'm going to give you my honest opinion on how I manage kidney cancer. So not just a Merck view of how I manage it, how I actually manage it in my real life clinical practice. And so I'm hoping it's going to be a very balanced conversation, and then I'm very happy to take any questions. So we know that kidney cancer has changed, and we know that we started with immunotherapy many years ago. It wasn't particularly effective, but we had IL-2 and interferon. And then we had sunitinib come along in 2005, and then we've had a number of TKIs, IO-TKIs and IO-IO in the space, which is great for patients because it means we've got different options, but it means that we need to personalize that treatment for the individual patient that's in front of us. And what I'm going to argue today is not all the combinations are made equally. I accept that there are financial implications to the treatments, and I'm going to park that. Not that it's not important, but I can't influence it. What I want to do, though, is talk through some of the data and some of the implications of the data. So this slide really tells us that these are well-run, randomized controlled trials, anywhere between 600 and 1,000 patients. And so all I really want you to take from this slide is when we're looking at the frontline space, these are good treatment options, these are well-run trials, and therefore I think the data can be believed. That said, we all know that patients who get into clinical trials are often different to the patients who sit in our outpatient clinics. And so I'm going to talk about some real-world experience. I think this is important. So when I was kindly introduced, one of my main interests is immunotherapy. So I spend a lot of my time doing trials in immunotherapy, managing toxicities from immunotherapy, and I'll talk a little bit about that later. And I'm increasingly interested in the tumor microenvironment. And we know that we oversimplify things, understandably, because it's so complex. And we talk about T cells and we talk about tumor cells, and we talk about taking the brakes off T cells and allowing them to kill tumor cells. But we know that it's far more complex than that. We know that there's macrophages, we know there's T regulatory cells, and we also know there's something called natural killer cells. And what we know about anti-PD-L1 compared to anti-PD-1, and avelumab is an anti-PD-L1, is that they're very good at bringing in NK cells, which adds an extra dimension to the immune response. And that increases things like interferon gamma and other cytokines, and it's particularly relevant when you've got very vascular tumors. And so when I talk about the data, I think there is a difference in the mechanism between anti-PD-L1 and anti-PD-1. And so we'll discuss how I think that influences the outcomes. So this is a trial. Many people will know the trial. It's about 900 patients. It's a frontline trial. It's untreated patients. Endpoints as we'd expect to see: OS, PFS, response rate. And there's a PFS advantage. So patients do better with a combination of IO-TKI, and I don't think there's a great surprise there. If you look at all the trials, the message will be the same. IO-TKI does better than TKI. And if we look at the response rate, it's 60%. And if you look across all of those IO-TKI trials, response rates are anywhere between about 55 for Cabo-Nivo up to 60% for the other combos. There's an exception to that rule. And the exception to that rule is lenvatinib and pembrolizumab. So if you look at that data, there's no doubting that the numbers are stronger. The response rate is 70%. The PFS is almost 2 years. So why is that so different? What's different about lenvatinib and pembrolizumab? Well, for starters, we use 20 milligrams of lenvatinib, a dose that I've never prescribed in kidney cancer before. And I think if we're given 20 milligrams of axitinib, we probably also see response rates of 70%. Also, if we look at the number of favourable risk patients in each of those trials, it's about 22% for the Javelin trial, it's 31% for the other IO-TKI-based trials. And so we have to view the data not through a cross-trial comparison, but we have to view it through the fact that these have got different patients involved in the different trials, and therefore I would expect to see different response rates. And I use lenvatinib and pembro, and I use nivo and cabo. And if I've got a 50-year-old patient who's got no comorbidities, I would absolutely want to give them lenvatinib and pembrolizumab. But if I'm doing that, I'm giving lenvatinib at 20 milligrams because I'm aiming, like the trial suggests, that we can get a 70% response rate and 24 months of PFS. I've been speaking at a number of places in India over the last few days, and what I've heard a lot of times is, well, I use lenvatinib and pembrolizumab, but I use 8 milligrams or 12 milligrams of lenvatinib. And I would ask, well, where's the data? How do you know how good that's going to be? Because we've got the HOPE 218 trial that looked at 18 milligrams versus 14 milligrams of lenvatinib, and 14 wasn't as good as 18. So I find it really difficult to believe that 8 or 12 milligrams is going to be as good as 20. And so when we start with axitinib and avelumab, we do start at 5 milligrams BD and escalate it in exactly the same way that we would with a trial. And so again, I'm not against using lenvatinib and pembro or even cabo-nivo, but if you're going to do it, you need to give it at the doses the trial gave. Otherwise, we're just kidding ourselves that we're going to get 70% response rates, but give completely different doses. Now, the elephant in the room about this trial is that there isn't a statistically significant overall survival benefit. And that's always what people say about the Javelin 101 is, why choose it when you've got other IO-TKI combos that have got OS benefit? But again, I come back to the fact that we've got less favourable risk patients in this trial. That's not my opinion, that's the facts. And we know that favourable risk patients have a better response rate. If we look at the Checkmate 9ER cabo-nivo trial, only 30% of the patients in the sunitinib arm went on to get an anti-PD-1. If we look at this trial, more than 50% of the patients in sunitinib arm had anti-PD-1. So again, I would expect there not to be a significant difference. So it's not taken away from the fact that the other trials do, but we need to view the data through the lens of the baseline characteristics. And actually, if you look at the tails of the curves of the other combinations, the nice thing I find about axitinib and avelumab is that we've got the longest follow-up. 73 months is the follow-up we've got for that trial. We don't have the same length of trial for the other IO-TKIs. But what we do know in the follow-up we have got is those curves almost come exactly back together. If you look at this curve, it's not a massive difference at the end, but they're staying apart and we've got longer data. I don't think you can argue other than these curves are coming straight back together and we don't know which direction they're going to continue to go. And we've got some real world data with this combination. So again, if you've got a 50-year-old patient who's super fit, no comorbidities, give them 20 milligrams of lenvatinib with pembro, that's what I would do. That's what I think is the right thing to do. But in the real world, I see the 70-year-old chap who's smoked most of their lives, because we know that's a risk factor for kidney cancer. They've probably got diabetes. They've probably got some chronic chest problems. And so what I'm thinking about is what treatment can I give them that gives them the best possible chance, but is also likely to be tolerated? And in the real world data, when we look at Axiavi, this is some data from the UK, and it shows response rates of anywhere between about 50% and 60%. And so what that tells me is in the real world, not in the trial, but in the real world, people are getting similar responses as we see in the randomized controlled trials. And I think we all know that we often get randomized controlled trials that look great, and then in reality, what we see in clinical practice doesn't replicate. Now, I spent a lot of my life thinking about toxicity and managing toxicity. And one of the main questions I get is, well, how do you differentiate if this is an IO toxicity or if this is a TKI toxicity? And the most common toxicity we see is diarrhea, and I see an awful lot of diarrhea. Now, when I get diarrhea in a patient on IO TKI, let's say I've got them on Cabo-Nivo. I use Cabo-Nivo, it's a good combination. The half-life is between 100 and 110 hours. So if someone develops diarrhea on Cabo-Nivo, I've got to wait at least 4 or 5 days before that Cabo dose is going to go low enough for that diarrhea to improve if it's TKI. The half-life of axitinib is 4 to 6 hours, which means if I stop that drug today, if it's the TKI toxicity, it's probably improving by tomorrow. And if it's not, I can then start management of the IO toxicity. And so half-life, I think, is really important when we're thinking about the real world and the management of patients. Because what we don't want to do for that Cabo-Nivo patient is find out that it's probably IO 5 days down the line, start them on steroids, leave them on steroids for a few weeks, give them the side effects from steroids, and potentially negatively impact the response rates. So again, I do think half-life in the real world is important. So I like all of these ice creams. I also like mint chocolate chip, and I had one at the airport, which was lovely. But ultimately, we've got to decide between our choices. We can't, in my opinion, we can't just use one treatment for everyone. We need to use the data that's in front of us. I think the thing that unites everyone in the room is we all do what we think is best for our patients. We all put our patients first. We all advocate for our patients. We all do what we think is in our patients' best interests. And so often when we do that, we prioritize quality of life because we think what's important is patients living well with their cancer. And this data was presented at ASCO a couple of years ago from renal patients finding out what really mattered to them. Quality of life was important, it was number 3. But number 1 was to control the disease as much as possible. And number 2 was durability of response. Number 4 was rapid reduction of the tumour. The time to response with Axiavi is about 2.8 months. In my opinion, the only drug in kidney cancer that gives us the possibility of a long-term durable outcome is immunotherapy. I think TKIs can control disease. I don't think we cure people with TKIs. And we know that the response rates are much higher with IO TKIs. So if we're going to do what actually our patients want us to do, we should be giving them an IO TKI combination rather than a single agent TKI. And if we look at the different data sets, they look relatively comparable. So this is the 12-month OS. I think efficacy looks similar. So when I'm teaching my residents and my junior doctors, I often give talks like this. And at the end of the talk, they often come up to me and go, thanks for the talk, but I don't really understand how you make the decisions. You talked about patient factors and treatment factors, but I still don't really understand when that patient's in front of you, how you decide what to do. And so about 18 months ago, I produced this just to help me when I was doing teaching. And these are actually the things I use to decide what I'm going to do with that patient in front of me. Yes, I think about efficacy endpoints, but I also think about the biology of the disease. I think about the histological subtype. I think about the sites of disease. I think bone mets are different to pancreatic mets and they're different to brain mets. I think they've got different responses to IOs and TKIs. I think dosing is important. I think half-life is important, and clearly patient choice is important. But we can't get away from the fact that we use the IMDC criteria to decide our treatment choices. Do I think it's good? No. Do I think it's good for prognosticating? Not bad. Do I think it's a good predictive tool of who's going to respond? No, I don't. But it's all we've got at the moment. There's other things like KIM1 coming down the line, but for now we're left with the IMDC. So let's focus on favourable risk just for a couple of minutes. Intrinsically, we often say favorable risk is the vascular tumors. They're the ones that are driven by the blood vessels. But if you look at the Checkmate 214 data, the Ipi-Nivo data, we know that 28% of patients respond in the favorable risk to Ipi-Nivo, a pure IO combination. And so that tells me that there must be an immune component in those favorable risk patients. And equally in the poor risk patients, we know it's not just about the immune system. We know VEGF is also important. So let's look at some of that favorable risk data, because actually what we all often say when we talk about kidney cancer is that we use the data in front of us to make decisions. And so let's use the data that we've got. This isn't my opinion. This is simply what the data says. So if you look at the data for PEMAXI in the favorable risk group, hazard ratio 1.1. So it's detrimental in our favorable risk patients, not my opinion, this is the trial data, to use the combination of Pembro-Axi versus TKI. What about Cabo-Nivo? Hazard ratio 1.1. So it's detrimental to give patients Cabo-Nivo in the favorable risk group. The CLEAR study, the best, the most powerful, lenvatinib 20 milligrams, hazard ratio 0.94, marginally better than 1. And why do I think that is? I think it's because they're anti-PD-1, not anti-PD-L1. And I think anti-PD-L1, for the reasons, and I'll come back to it in a second, do better in favorable risk patients. And when I say favorable risk patients, I'm not just talking about patients with an IMDC score of 0. I'm talking about the patient who sits in front of me and looks favorable and feels favorable. The nephrectomy was a few years ago. Yeah, they might have chronic anemia. Their HB's always been low. They're scoring 1, but they're not scoring 1 because the kidney tumor is causing that HB to be low. They're scoring 1 because their HB's always been low. To me, that's a favorable risk patient. They just happen to score 1 on the IMDC criteria. And I come back to this. So this is why I think anti-PD-L1 has a massive advantage in the favorable risk group. I think we don't really understand the tumor microenvironment, but the more we understand, the more we realize it's far more complicated than T cells, tumor cells, and taking the brakes off the T cell. And so I just want to present in the last few minutes a little bit of real world data from the UK. Now, I used to give talks about kidney cancer, and I'd often stand up and say things like, well, it doesn't really matter what you use as your first line agent. Just use single TKI for everybody because everybody gets a second line therapy anyway, and I can just give them anti-PD-1 in the second line. And I used to say, well, in Valindra, 95% of my patients get to second line. So let's start with the TKI and I'll just give immunotherapy later. Is that coming to the end of my time? Okay. And actually what we saw is that and I'll just get to some of the headline things, that only 60% of patients would get into a second line therapy. So the idea that everyone was going to get IOT, everyone was going to get an immunotherapy in a later line simply wasn't true. And in the favorable risk group, a third of those patients, even in the favorable risk, never get a second line, which tells me we should use our best treatment first. And in our real world data, what we saw, because people always say, well, there isn't a survival advantage. Well, in our real world data, 1,300 patients, the hazard ratio was 0.42 for survival, a 58% improvement in survival in the real patients that we treat in the real world. And so I just want to leave you with this slide. If we think about that favorable risk group and we're actually going to treat patients based on the data, what have we got to work with? We've got the longest follow-up for axiavelamab. We've got the highest median overall survival for axiavelamab. We've got the highest response rate for axiavelamab. And we've got the best OS hazard ratio for axiavelamab. So if we're actually going to follow the data for favorable risk, I think following the data tells us to use Axiavi. And finally, in the poor risk group, which is often the group that people say we need to use Len-Pem because it's the strongest treatment. If you're brave enough to use 20 milligrams of lenvatinib, if they're 50 and fit, do that. But if you're giving patients 8 milligrams or 12 milligrams, I think you're kidding yourself that you're giving them the best combination. And if you look at the hazard ratio in the poor risk group, 0.58, I think is really impressive compared to the other trials. And so in the real world, in the UK, I'm using Axiavi across all the risk groups. And in fact, it's the only NICE approved treatment in the UK based on the data that you can use across all 3 risk groups. And I'll stop there.
Thank you for your talk and for keeping in time. We may have time for a question and a comment. Dr. Sudhi?
This, I can make some comment because I have used XE and ABI and seen very good long-term results. By the time then Cabo and Pembrolizumab and lenvatinib came, and then Cabo and this Nivo. Both of them do produce some effect on patient, but I've not seen that good effect which AV and XE was giving. What is the reason for this? Because otherwise the data says different. This Nivo, Cabo and Nivo,
yeah,
and then Pembrolizumab and everolimus, lenvatinib, they do have some more side effects, but they say they're the very good drugs.
Yeah.
But why? And is it? I don't know. It is in our patients, or you have same experience. So why this XE and AV is gone? In the not very, people are not very comfortable in using in practice.
Yeah. So I think it's a great question. And I think part of it is that the Len and Cabo, the data looks good. Well, the Cabo Nivo data looks okay. The Len Pem data looks good. But I think the reality is 70% of patients who start on 20 milligrams of lenvatinib end up needing a dose reduction. And what I see in my real life clinical practice is the patient that I give that high dose to often get toxicity, often deteriorate, and never get a second dose in, and they die having only had 1 dose. What I really like, and again, this is my honest opinion, this isn't just because I'm here, the nice thing about Axiavi is if you look at toxicity rates of things like pneumonitis, a lot less. So 0.6% versus 3% or 6%. So there's no doubt in my mind, and I do a lot of toxicity, that anti-PD-L1 is much better tolerated than anti-PD-1 as a class. So I think that's important because it means it's easier for us to titrate the different doses. And I think for a long time, people have just looked at the data, just the numbers, and said, Axiavi hasn't got an overall survival benefit. And we don't actually look at the underlying reasons why I think that's the case. And we don't think about the fact that most of our patients are 70, comorbid, multiple other comorbidities. And so for me, the nice thing about Axiavi is I can be really flexible with the dosing. But I also know, because the data tells me, that responses are just as good. The durability in my experience is just as good. It's just much better tolerated.
Problem in India is that it's very costly.
I know. And I can't sort that out today. I just wanted to leave this up. By all means, take a picture. I haven't got time to talk about it, but they're all completely free resources that are available. They're all, there's lots. So the podcast has got 150 podcasts on immunotherapy. They're all free. The IO Clinical Network is completely free to join. We've got about 1,000 members, and there's lots of free resources on that website. And there's a national meeting that I run once a month that, again, is completely free to join. So if you're interested in any of it, take a picture. My email address is there, and I'd be very happy to give you some more information. Thanks very much.
Yes.
So just we want to felicitate Ricky Fraser, sir, Dr. Ricky. So next talk is from Dr. Piyush Bajpayee in enfortumab vedotin in recurrent bladder cancer.
So good evening, everyone. Apologies for the delay. Actually, huge traffic outside. So nonetheless, I'll just try to deliver the key points over here. So as we understand that locally advanced and metastatic urothelial carcinomas, if you look at it, 50% of them, 50% of our patients would not be actually fit for cisplatin, and sometimes also platinum-based chemotherapy. So 50% are actually because of the age profile, the GFR already being low, and of course the comorbids. They're not fit for cisplatin. And most of them, after the PD-L1 inhibitors came, we thought it would be a game changer, but 70 to 80% actually PD-L1 inhibitors in the metastatic setting did not, prove the way they were supposed to be. 5% is what is the survival at 5 years in metastatic urothelial carcinoma. So this particular molecule and this particular trial, the EV301, basically is positioned somewhere where a patient has failed chemotherapy, platinum-based chemotherapy, and also a PD-L1 inhibitor. Now that PD-L1 inhibitor is being used in maintenance setting after a good response, therefore, like a javelin-like strategy, then we can actually position this if in case we see a progression. So EV301 was the trial, and this, as I mentioned, was the positioning post-exposure of chemotherapy as well as PD-L1 inhibitor. So it was designed basically to confirm, what would be the position, what would be the efficacy of EV301 post these two lines. So the patients, nearly 608 patients, 608, in a good performance status who had received PD-L1 as well as a chemotherapy prior were chosen, randomized into 1:1 configuration, and EV was basically 1.25 mg per kg, as we know the conventional dose of it, in a 30-minute IV infusion on day 1, 8, and 15 for 28-day cycle. The investigator chosen chemotherapy were either docetaxel, paclitaxel, and vinflunin. Basically, vinflunin was majorly used in Europe. Primary endpoint being overall survival, and there was these secondary endpoints, including the PFS, the overall response rates, and the other, including the quality of life parameters and patient-related outcomes. A pre-specified interim analysis was performed after 65% of the patients had died. The results of interim analysis were published in 2021 with a median follow-up of 11.1 months. A final analysis was planned. 439 deaths had occurred thereafter. So if we look at the basic demographic profile, so we can see that the age profile, I mean, this is what the patients would actually represent, elderly patient, the 6th and 7th decade, and you have more than 75 years, the subgroup, which is nearly 17 or 70 to 20% in both the arms. And then, of course, there were patients with tobacco use, nearly 55%. History of diabetes, now with this particular drug, diabetes is a concern, nearly 20% of the patients did have pre-existing diabetes. If you look at Bellman risk score, and nearly Bellman risk score more than 2 was nearly 30% of the patient. And this is important because Bellman risk score, as we understand that overall survival would be bad, nearly 3 to 6 months in high Bellman risk score. These bad subgroup of patients where there is good burden of visceral disease were also included. Now, we look at the histological subtypes. So nearly 76% of the patients 75% of the patients were actually urothelial transitional cell carcinoma and nearly 15% mixed cell type. There were small other histologies, the variant histologies, including small numbers for small cell as well. So if we look at it, basically EV significantly reduced the risk of death by 30%, that is hazard ratio of 0.7. If you look at the numbers, the overall survival was nearly 13 months versus 8.97 for chemotherapy. The estimated 12-month overall survival rate 51.5 versus 39.2 months. So due to significant improvement in overall survival compared to chemotherapy, this particular trial was prematurely stopped after the interim analysis of intention to treat population was reached. So if we look at the subgroup analysis, mostly all the patients benefiting with this particular drug. And likewise, the risk of progression, if we talk about the PFS, was also significantly impacted upon 5.5 versus 3.71 for the chemotherapy. Again, if we look at the age group profile or any other parameters, most of these were actually favoring the EV arm. The overall response rates, which is a concern, especially in a visceral disease pattern, so nearly 41% overall response rate. This is something significant when we are using this sort of therapy. Post several lines of exposure of chemotherapy, immunotherapy. So this sort of response rate is something where a doubling is happening, it catches the eye. So overall response rate was definitely almost twice the conventional arm. And this sort of trend was again seen in almost all the subgroups, irrespective of what the subgroups were. So this was realized in terms of a better response rates for all these with EV. The quality of life, because this is not chemotherapy, but this is a ADC, we are not very sure how it would behave. But nonetheless, when we compare it with chemotherapy, the overall quality of life graph is sailing better as compared to the chemotherapy arm. So numerically and overall impression is it is looking better, and all these parameters in terms of quality of life, pain scores, as well as all functioning domains were better with the EV. Now, if you look at the adverse events, basically definitely more neuropathy is what was there, and hyperglycemia was very significant in EV. So we have to watch for that. But if you look at the hematological profile, so hematologically, since it's not a chemotherapy, a direct chemotherapy, so hematological profile overall was better with EV. So if we look at the deaths which actually happened, so slightly, if you see the numbers over there, percentage over there is slightly high. But if we look at excluding the progressive disease part, so actually it was around 3.7%, almost similar to the chemotherapy arm. So most adverse events were successfully managed with dose reduction or interruption, with a low proportion of patients requiring withdrawal of the treatment overall. The majority of adverse events were mild to moderate in severity. Most of them were grade 1 to grade 2, very sort of single digit numbers over there in grade 3, grade 4 as compared to the chemotherapy arm. So the point to note over here is, if in case we see when these adverse events come, these are most common during the first 2 to 3 months of the therapy. And one of the adverse events like eye, now the ADC is, you need to also be in touch with your ophthalmologist. You need to get regular referrals to your ophthalmologist for various corneal disorders. They might be very subtle, but you need to just start looking at them early. So EVs definitely significantly improved outcomes versus chemotherapy on these various parameters: the overall survival, which was the key primary endpoint, the PFS, the overall response rates, and also quality of life parameters. So summarizing the results of this, definitely the overall survival, PFS, and overall response rates was better, and it led to actually approval of this particular drug. by the FDA as well as the EMA. So after that, of course, we need to actually look at the phase 5 sort of data that is the real world evidence to support, what actually the practice would be. So there is data coming from the Western world on the UNITE registry. This is 16 US institutions, collaborative data. 260 patients were treated with the EV monotherapy, overall response rates being 52%. We saw 41% over there, 52% over here, PFS of nearly 6.8 months, and overall survival of 14.4 months. So almost similar figures, almost similar echoes what we saw in the previous 301 data set. Pure urothelial, if we look at 58% response rates were there, and invariant histology slight drop in the response rates is seen. If you look at the various other subsets, basically whether it's a bladder primary or a upper tract primary, whether the age part, the ECOG, the diabetes, no diabetes. So there again, response rates are not dipping primarily. A couple of things, variant histology, yes, there is a difference between the responses. So if in case you're not having the typical urothelial carcinoma, more component of it is a variant histology, that is more than 50% is a variant histology, you might not get the sort of responses you would want to see with this particular drug. So UNITE study basically saw that, the PFS was quite similar, reflection slightly better than the 301. And there was no significant difference in terms of heavily pretreated patients, because this was not the classical 2 lines only, but this was 3 line, 3rd line also. So, and also in mixed histologies, there was not much of a difference. The primary site, which one thinks what to do when it's a ureter cancer, and also no difference in high, low TMB or PDL1. As I mentioned, that histological variants we need to be watchful for, especially if we see a small cell. Of course, we cannot expect much of a response or hardly any response. So please do not take this patient. If in case it is a predominant, that is a predominant histology of micropapillary or plasmacytoid, sarcomatoid, squamous cell, again, you would not get much of a responses. But then if in case it's a mixed or a minor histology, you could probably expect some responses over there. So what about other populations apart from the Western world? There is data from the Europe, almost similar figures of overall response rates, nearly 46%. PFS almost similar, of around 7 months, and overall survival of 12 months. So this was from Germany and Switzerland. And then from Japan, we see again elderly population near in the 7th decades, median age 71. Clinical response rates again 43%. And what we saw, one particular interesting finding over here, that patients who had peripheral neuropathy because of the drug are actually having a better survival in terms of PFS and overall survival. So if this drug is probably causing some sort of grade 1, grade 2 neuropathy in the patient, then probably you could expect some responses. It's probably related to a better addition of Nectin-4. This drug could probably be doing. So this particular drug is also now seen by the real world evidence, supported by the real world evidence apart from the main trial. So thank you, and we can take any questions.
Just a quick question, sir. So how do you select between EV Pembro versus the Vivencio maintenance? So with the data of the EV302 and the exceptional median OS of around 33 months, so EV Pembro to all comers, or do you select based on certain findings?
So of course, EV Pembro, if we look at the Javelin 100 data, it is good in terms if you're saying that after Javelin 100 you would do a EV301 strategy, you could probably expose all your patients to EV301. Then yes, it is a good thought process. But how many of your patients would trickle out after getting that immunotherapy and would not come to your follow-up is one thing. When we always talk that you need to put your best foot forward at once, then again, whether your best foot, your patient can take that. Now, if it's a diabetic patient, peripheral neuropathy is there, so you need to take those things into account. So you need to individualize from that perspective. And I would say, if in case there is some mixed component where predominantly transitional cell is there, but that's the major component, and there is a small component of squamoid type histology, I would still say that EV Pembro would probably be a better strategy over there.
Any other comment or questions? Okay. Thank you, sir.
If not, we'll move on to the next speaker. I believe Dr. Amandeep Arora needs to speak now because there's a flight to catch. Is that right? Yeah, welcome.
Yes. Good evening, everyone. So firstly, thank you for letting me speak out of turn. Secondly, I'm going to be speaking about testicular cancer. Not a lot of us manage testicular cancer in large numbers, but I'll still try to hold your attention for the next 10 minutes. Okay. So why are we talking about de-escalation for testicular cancer? Because these patients live long, right? Even if the patients have metastatic disease, we aim for cure in them. We have survivorship clinics actually in our hospital. We help them deal with fertility issues. So they live long, but we do not want them to live with long-term toxicities of the treatments that we've done for them, especially if they do not have advanced disease. So our aims with de-escalation are to maintain the oncological efficacy because we know we are doing good, but to reduce the acute toxicity and to avoid the long-term morbidity also, which includes having second cancers because they end up living long. So these are the stages that we will be dealing with in my talk. Stage 1 cancer, which means cancer only in the testis. The CT scan is clean, the markers are normal. And stage 2 disease, stage 2A and 2B. Okay, not stage 2C because stage 2C is considered advanced cancer. Now, stage 1 disease, coming to first, stage 1 seminoma. So 10 to 15% of patients with stage 1 seminoma have occult. So your CT scan is negative, but there is still some disease there, which will come up in the next scan. And these are our treatment options, either put them on surveillance or give them adjuvant RT or give them adjuvant chemotherapy. And we base this decision upon some risk factors like the size of the tumor or whether the rete testis is involved or not. Okay. So how do we do surveillance for stage 1 seminoma? So only 10 to 15% of patients have METs. So the RFS is 85%. Even if they do develop those METs, it is almost always salvageable. So the cancer specific survival, because we cannot write 100%, I'm writing 99%. And this is actually the surveillance protocol. We do CT scans at 3 months, then every 6 months till 3 years, and then annually. This probably seems to be a little too intensive. The advantage of surveillance is that we don't give toxicity of RT and chemo, but this is a disadvantage. We do repeated CT scans leading to radiation exposure and also cost. So can we come down on our surveillance? So there is level 1 data with a phase 3 non-inferiority trial called TRIST. 670 patients of stage 1 seminoma, lots and lots of patients in 4 arms. First arm, they did 7 CT scans like it is done routinely. In the second arm, they replaced the CT with MR because they want to avoid the radiation to the patient. Third and fourth arms, they came down on the number of the scans that they were doing. So third arm, only 3 CTs, fourth arm, only 3 MRIs. Conclusion of the study, reducing the frequency of imaging and using MRI over CT did not impact outcomes. And what outcomes? Detection of recurrences. So we were not missing recurrences if we did lesser scans and also if we replaced CT with an MRI. So that is good for our patients. Now, can this be extrapolated to stage 1 NSTCT? Probably not, because in stage 1 NSTCT, the percentage of having occult mets is 25 to 30%. That study had only seminoma patients. We don't know if that can be extrapolated to our non-seminoma patients, but I would advise against doing it because the incidence of occult mets is higher. These are the high-risk features that we have for a stage 1 non-seminoma. These are the options that we have, either again surveillance with 7 scans and not 3 scans, or give them adjuvant chemotherapy 1 cycle, or do an RPLND. There is no role of radiation therapy over here. So this is the standard that we do. If our patients are low risk, we put them on surveillance. If they have high risk features, we would want to give them a single cycle of BEP, which has excellent recurrence-free survival rates with no significant long-term toxicity. And this is the preferred treatment option in stage 1 high risk NSGCT. But there is still, we are giving chemo, right? And we're giving chemo to all. We know only 25 to 30% have occult mets, but 100% patients are getting chemo. So can we do something less? Can we do something personalized? We can do RPLND. We can do nerve sparing RPLND at centers of excellence. And only those who actually turn out as having those mets, which will then become PN1 patients, will get the chemotherapy. Or there is also an option of giving them only on surveillance again, because you've actually gone in and removed that disease. And this RPLND may be actually preferred over the chemotherapy if the orchidectomy specimen had teratoma component in maximum. So here we have an option of coming down. So don't give chemotherapy to all, but doing a primary nerve sparing RPLND is not something which is generalizable across all onco centers, whereas giving one cycle of BEP is generalizable across all centers. So I would say that we should de-escalate with caution because the surgery cannot be performed at all centers. Coming to stage 2 disease. So this is what the guidelines say. Stage 2A and stage 2B, this is seminoma, chemotherapy, 3 BEP or 4 EP. What is the case for de-escalation here? We are probably overdoing it for our early stage 2 patients. This is not stage 2. This is probably stage 2. On the right side, we have stage 2. On the left side, we have a huge mass. They are not the same, but they will both get 3 BEPs, right? So we are, and they both do great. So we are probably doing too much for that patient with that small nodal mass there. So what do? We thought of combining chemo and RT. So you might say we are combining, we were giving only chemo, but now you want to give both chemo and RT. The thing is we're giving less of each. So giving less cumulative toxicity to our patients. This is the trial, phase 2 design, stage 2A and 2B seminoma means what? Nodal size up to 5 centimeters. What are we doing? They took 116 patients. They gave involved node radiation therapy. So as per guidelines, if you are going to give only radiation therapy to these patients, they would have got the dog leg field RT, the para-aortic or the paracable and also the pelvic. We don't do that. We give it only to the node which is there on the scan. And we give single agent carboplatin. Okay. So the RT is given for the local control of the node over there, and the carboplatin is taking care of the micromets elsewhere in the body. They had a target 3-year PFS of 95%. Probably one patient extra had a recurrence, and their actual 3-year PFS was 93.5% in the study. So they've written that they did not meet their target, but then this is still something which is very sound. Second study, de-escalating chemotherapy. Okay. So the standard is giving 3 BEPs. So again, non-randomized phase 2 trial of 98 patients. What did they do? Baseline FDG PET. We all know seminoma are FDG avid. Okay. So a baseline FDG PET was done for all patients. Everybody got 2 cycles of EP so that they're avoiding bleo over here. 2 cycles of EP for all, and then they repeat the PET scan. Positive PET, if the disease is still lighting up on the PET after 2 cycles of EP, they get 2 more cycles of EP. But if the disease is not lighting up on the PET right now, they get only 1 cycle of adjuvant carboplatin. 67 patients had a negative PET out of 98. So 2/3 of patients actually needed only 2 BEP and 1 more cycle of carboplatin and avoided 2 more cycles of EP. The 3-year PFS was comparable, whether they needed 4 cycles or just 2 cycles and 1 more cycle of carbo. And the cumulative peripheral neuropathy and ototoxicity was definitely higher in the patients who were getting 4 cycles of the platinum. So chemo and RT seems so efficacious, right? We're talking of recurrence-free survival in excess of 90% for them. But non-negligible acute toxicity exists with chemotherapy. These patients are also living long. And again, we have these issues with them. So can we do RPLND again, right? We do not want to do RPLND post-chemotherapy in a seminoma because we are told that the planes are desmoplastic. I have never seen even one post-chemo RPLND for a seminoma. But when chemo has not been given, the planes should be okay. So then we can do a primary RPLND. So it should be technically feasible and safe. We avoid the systemic toxicity with chemotherapy, and we avoid the risk of second cancers, which is seen with RT and also with chemotherapy. Do we have evidence? We have no randomized control trials which compare surgery with the established treatments, but we have multiple prospective cohort studies. We have 4 phase 2 trials. 2 have been published as papers, SEMS and PRIME test. 2 have been published as abstracts also. So totally 4 studies. And how do they fare? What are the recurrence rates? The 3-year RFS is 70 to 94%, right? So the 3-year RFS is not 90% or 95%, it is 75, 80%. So it is less. It is less because you're doing local therapy, you're not giving chemotherapy. So the patients are going to have some recurrences outside. So, but all of them who had a recurrence were then salvaged. So the overall survival was not compromised. So the OS was 100% and very few patients had in-field recurrences, which means that the RPLND was done well because these phase 2 studies were done at centers of excellence. This is the paper which has been, the study which has been described in the most amount of detail, the SEM study, and the recurrence-free survival is there. If there were PN0, obviously 100%, PN1, 92%, PN2, 74%. I don't understand how they ended up having a PN3 because they were doing it on very low burden disease. So to conclude, there is definitely scope to de-escalate in early stage germ cell tumors. For our stage 1 seminoma patients, we can do fewer scans and replace CT with MRI. There is level 1 evidence for it. For our stage 1 NSTCT, don't come down on the scans because we don't have evidence, but maybe think of doing an open or robotic nerve sparing RPLND at a high volume center only. For our early stage 2 seminoma patients, instead of the 3-BEP that is standard for them, we can consider giving involved node RT plus 1 cycle of carboplatin only, or give 2 cycles of, that is wrong, 2 cycles of EP, not BLIO, EP, do a PET, and then decide if you want to give more cycles of chemotherapy, or consider doing a primary RPLND and give that adjuvant chemotherapy only to those patients who need it, which you will come to know seeing the histopath report. But all these 3 things, so in stage 1, I told you it is established, but in stage 2, these are still at the phase 2 level. Thank you so much.
Thank you, Dr. Arora, for an excellent coverage of all aspects of this topic. You do have a flight to catch. Do you have a couple of minutes for any questions or comments? Yeah.
Hello. That was very nice. Yeah, thank you.
Thank you.
You know, the U.S. guidelines are now coming in line very much with what you said. The imaging being less imaging, but if you switch to MRI, the radiation exposure is much less anyway. So I think that we've always said the number of images, we kind of went halfway between the TRIS trial and what you're proposing, what's currently on the guidelines. So that's the one thing. The next thing is on the radiation plus carbo. It didn't meet its primary endpoint and it was a phase 2.
Yes.
It's going to probably make it on the guidelines as phase 2B. But my real question to you is, and I don't know the number, what percentage of patients still had a positive PET after 2 cycles of BEP on that study?
On that study, right?
Yeah.
So 67 out of 98 had a negative PET.
Yeah.
So the remaining, so 1/3 had a positive PET.
Okay.
So they needed 4 EP. The drawback of that study is what is a positive PET is not known. So whatever the authors defined as positive PET. So that is one drawback of that study, but still exploratory, right? We can probably come down. Yes.
And the other thing about the RPLND for early stage seminoma, I think that's gaining a lot of steam now,
Yes.
and it made it to the guideline. Our NCCN guidelines is going to be on there now.
Yes.
We're also doing, I think, a fair number of people are doing this extraperitoneal
Yes.
approach, open extraperitoneal. That also might, I guess, de-intensify a bit because patients leave. I've done many of them.
In a
They
couple of
leave
days,
the
they
next
can
day
go home.
almost.
Yeah,
Yeah.
yeah,
So.
yes. Yes. Thank you so much. Yes, sir. So they all got 2 EP, and then 30 patients whose PET was still lighting up went on to get 2 more EP, so 4 EPs. Yes, so they all responded, but they had more peripheral neuropathy and autotoxicity compared to those who did not need 2 more cycles. And we came to know with that PET that probably 2/3 patients don't need those 4 cycles. So probably doing a PET midway helps you to identify who needs 4 cycles compared to who needs just 2 cycles.
Thank you, Dr. Arora.
Thank you.
Sorry, last comment.
I just want to make a point. You know, in patients who have bulky retroperitoneal seminomas and you treat them with primary chemotherapy, and if the PET is positive, typically you wait another 3 months, and some of them will actually become PET negative.
Yes.
So in this trial, after 2 cycles, how long after they finished the cycles did they do the PET? And what would have happened if they just waited in the other 1/3?
Exactly, yes.
Some of them would have become negative too.
Yes. So the first PET was done at 8 weeks, but they have not mentioned that did they wait after it was still lighting up, but they've done the first PET at 8 weeks. Yes. And they said positive PET means more than background activity. They've not even defined the SUV max in the paper. Thank you.
Thank you. Can I now invite Dr. Anand Raja from Chennai, talk about sentinel node biopsy in penile cancer.
Greetings from the Adar Cancer Institute in Chennai. And some portions of this talk may be a little bit of a repetition for people who were here yesterday. So we'll talk about evolution of sentinel lymph node biopsy in penile cancer. What was the past, what is the present, and what does the future hold? So why is staging of the inguinal staging important in penile cancer? Because nodal status is the most important prognostic factor. 20 to 30% of CN0 patients harbor micrometastasis. Early intervention can be curative. Delay in diagnosis leads to poor outcomes. So penile cancer has a prolonged local regional phase and a therapeutic window which can be exploited. So there are multiple modalities of staging the groin. You have the EAU risk stratification, the low risk, the intermediate risk, and the high risk. For the low risk, it's surveillance. For the high risk, it's staging, however you stage it. And for the intermediate risk, a lot of people stage it, a lot of people observe it. The staging options are that you can either observe it for select patients, that is the low risk, and select intermediate risk patients. You can stage the groin by open inguinal lymphadenectomy. You can stage it by the video endoscopic method, whether lap or robotic, and you can do the dynamic sentinel lymph node biopsy. So the past was that the Cabanas node was the principle of sentinel node was given by Roman Cabana in 1977. It was mapped to the anteromedial border of the junction of the epigastric vein and the saphenous vein junction. So 31 patients were underwent this procedure, and the 3-year and the 5-year OS rates were 90% and 70% for the positive inguinal node, which looks very, very good. But then none of these studies that came later on were able to replicate any of these. Studies that came later on had a very high false negative rate. So why did Cabana's technique not take off? It was because it was an anatomical based location. It was just said that the node is here, you take it out with experience. We all know that the anatomical site of sentinel node does not really work. No radio tracer or blue dye was used. It ignored individual variability. There was no real-time mapping. And later studies and all showed that the false negative rates were more than 50%, which is not acceptable. So from the 1970s to the 1990s, I call it as the silent years, when the concept of sentinel node came from penile cancer, but was adopted to almost a lot of other cancers, but not to penile cancer. So for 2 decades, there was just nothing there. And after that came this landmark publication in penile cancer, which is the Amsterdam era, or the Dutch era, as I call it, the Hornblas innovation. Hornblas in Netherlands published a series of publications who rediscovered and refined the sentinel node biopsy in penile cancer. And they said that the diagnostic performance of this early sentinel node technique was not ideal as was done by Cabana, but as they did was good, because the identification rate exceeded 95% and the false negative rate was less than 7%, which was consistent with that in other sentinel nodes, as in breast melanomas and so on and so forth. So what is it that they got right? Why were they able to replicate things? So because they use the modern technique of radiocolloid injection, lymphoscintigraphy, gamma camera, identifying it in the theater with the blue dye. Perioperative inguinal ultrasonography was done even prior to the procedure, and if necessary, they did the ultrasound guided FNACs from the suspicious nodes. And they also introduced multiple sectioning of the nodes so that they could section it at every mm interval, and then they could do IHC. So even if it's a micrometastasis, they could pick it up. So once they identified this, there was a real uptake of this in a lot of the European centers in Europe and in UK, where they further refined the study. And then the Denmark multi-center study came up with this false negative rate of 5.6%. So it was a game changer, but then outside of these few centers in Europe, it did not spread really across the world anywhere else. The reasons were that it required a multidisciplinary setup, nuclear medicine, pathology, a handheld gamma camera, which is not available even in a lot of the cancer centers. It required a steep learning curve. Infrastructure challenges were there. And most data were from high volume European centers. So a lot of it was dependent on the surgeon who was operating. So it was operator dependent. And if you were not working in that centers, in smaller centers, the advocacy was you don't replicate it, don't do it because you'll not be able to produce equivalent outcomes. So we have a very high incidence of penile cancer at our country. So after 2008 and 9, when these publications came up, we were very early adopters of this. There are a range of things that we try to inject the sulfur colloid overnight, morning, filtered, unfiltered, so on and so forth. But we published our data for in 2016 of our sentinel node technique, wherein we went ahead, did the sentinel node biopsy and topped it up with the completion inguinal lymphadenectomy, and then showed that only 1 out of 20 patients, 40 groins, the false negative rate was 1 out of 40. And once we were able to prove that, we dispensed with doing the completion inguinal lymphadenectomy and said that we'll just go ahead with the sentinel node. So we published our data very recently on our overall survival of retrospective analysis of about 8 years. The reason we have our
cases starting from 2010 all the way up till 2018.
Sorry, I think there's a
with a median
an audio. We can stop that. That's it. So this is what that's fine.
This flowchart summarizes.
So this is what it is there. I'm so sorry. I don't know whether there's an audio there in the background.
Nodes, out of which 31
the audio I think is there in this video. I think we can look at this. I think it serves equally well. So we had 307 groins in about 200 odd patients. The nodes that we were able to identify